knowledge and experience, and also helping to improve our cancer care through this meeting. So what we're going to do is we're going to have 2 sessions before the opening ceremony, the official one, which will be at 10 o'clock. We'll start with my friend and colleague, Dr. Marun Al-Khouri. Dr. Marun Al-Khouri is one of the pioneers of oncology in Dubai. He's practicing at the American Hospital in Dubai. He's a consultant medical oncologist, American board certified. You can just go back one slide as well. I should mention and thank the scientific committee. The scientific committee, Dr. Aiden Amadi, Professor Robert Wall from MD Anderson, Professor Nohan Ibrahim from MD Anderson, Dr. Saeed, thank you for your support. Dr. Farah Ali, thank you for your support. Dr. Ibrahim Bulaida, Dr. Hassan Jafar, Dr. Saeed Hamad from the Valley Hospital, and Dr. Diane Henry from Rashid Cancer Institute in Abu Dhabi. Thank you all for spending time to bring all these experts into today's and tomorrow's event. I would like to welcome Dr. Marun Al-Khouri, who is the chair of the scientific committee at the Emirates Oncology Society. Welcome, Dr. Marun.
Thank you, Professor Khouri. It's a pleasure, as always, to participate in the EOS meetings. We all are aware of the schedule and the speakers, very rich agenda. So we'll start with Dr. Vivek Sudhakar. It's a good night in Houston now, so we'd like to thank you first for being here despite the difference in time. So Dr. Vivek is an associate professor in the Department of Investigation in Cancer Therapeutics. He is the Center Clinical Medical Director, Center for Targeted Therapy, which is now the Oncology Division of Cancer Medicine at the University of MD Anderson Cancer Center. He has completed his internal medicine at Cleveland, Ohio. He is a clinical trial and physician investigator at the Department of Investigation in Cancer Therapeutics. Dr. Vivek. Good evening. Thank you for and we cannot hear you. Oh, you cannot hear me. Okay. Thank you for taking time to be with us at midnight. Oh, thank you so much. Thank you so much for the introduction. It's a pleasure and honor to meet you all virtually. Hopefully, most time we can meet you all in person. So, writing back now, that's related to the lung cancer disease of AIDS. Now, again, as we all know, it's been a wide year for lung cancer in 2021. We have had so many FDA approvals, numerous, and it's an exciting time for lung cancer disease. In the brief agenda for today, just to make sure everyone's engaged, I want to ask some questions at the same time, touching upon the latest and the greatest targeted therapies that have been approved, including EGFR, ROS1, the KRG+C area, and also touching upon direct DDI, and what we are looking forward in the future. Again, let's take a step back and see how do we treat advanced cancers like non-small cell cancer before the era of targeted therapy and immunotherapy. Actually, the majority of our patients, without the driver applications, without any biomarker, we cannot treat like this. So now we are moving forward to the era of personalized medicine. So the management of the patient's disease or disease predisposition and administration of therapy that convey the maximal effectiveness and safety given the patient's unique genetic and molecular profile, giving the right treatment at the right person at the right time is personalized medicine. So lung cancer, as we all know, has become the poster child for precision oncology. Lung cancer is being divided into subtypes, small subtypes of viral and viral subtypes. Now, the latest approvals have been in these subtypes. As you can see, recent FDA approvals for non-small cell lung cancer. Again, if you don't listen to any of my talk, just go through this. This is the one slide that's all you need to go through. In 2020, as I said, it was a watershed year. We had 2 MET inhibitors being approved, the carboplatin, and 2 RET inhibitors being approved, sulfatinib in May and then followed by sparsentan in September. After this was approved first line, Nivo EP was also approved. Uvalde was approved for outfusion. Neo-EP with the limited chemotherapy, the 9-LA regimen was also approved. Interestingly, ramucirumab plus everolimus are approved in EGFR exon 19 deleted or exon 21 mutated cancers. This year, in May, there was the amivantamab, which for EGFR exon 20 insertion mutation specifically. Again, as we all know, the KRAS G12C, the undruggable, that was considered undruggable, now you have a drug approved for KRAS G12C patients with lung cancer. So we have a host of targeted therapies, and we have a host of tyrosine kinases that target the PCS and that target the tyrosine kinases. So what we have tried is using these new drugs, particularly precision oncology for lung cancer patients, and each one pays for this, and negotiating with funding, experience, staff, training, collaborating with industry, academia, NIH, regulatory issues in the context of providing multidisciplinary care in the evolving landscape. So one of the great things that recently is happening is rapid translation from preclinical to clinic and to the real world. In 2012, because they showed that those fusions were still in lung cancer. In 2017, 5 years after the discovery of blood fusions in lung cancer, we had 2 selective regulators enter clinic. In 2020, we had 2, not just 1, but 2 selective regulators approved. So if we are to a timeline, there are 2 years from the phase 1 post-human clinical trial. These are approved in an accelerated fashion, given the magnitude of response based on the early phase 1, phase 2 studies. The first question, which is the most common actionable operation in metastatic non-small cell lung cancer? KRAS mutation, EGFR mutation, ITK, fusions, and red fusions. You are right, the answer is EGFR. Again, we know that beyond enlightenment and definite, now we have osteotomy. The resistance mechanism is going to be the future of only against these resistance mechanisms. On the on-target, the outside is going to be a huge Herculean task combating EGFR resistance. Right? So in the EGFR space, what is the latest effective? Amivantamab and dasatinib. Again, amivantamab is a human blood-specific dual antibody that targets EGFR. And dasatinib is a potent third-generation tyrosine kinase inhibitor. The efficacy is seen activating EGFR mutations. Again, the combination was efficacious in oxidative resistant and chemo-naive patients. In fact, if you see a combination efficacy in triple-naive patients, the objective response rate was 100% of 7 months. So again, the amivantamab was designed as a Mariposa study, and also the Chrysalis study was designed. And recently, amivantamab received US FDA approval in EGFR exon 20 insertion mutated non-small cell lung cancer. Again, as you can see in these waterfall plots, in this subset of patients, amivantamab had dramatic responses. Again, in fact, in the helical region, the objective response rate was 100%. In the near loop region, the objective response rate was 41%. And in the far loop region, the objective response rate was 25%. Again, what's coming up next in EGFR is this agent, the Blue 985, which is a highly potent and selective 4th generation EGFR TKI for the treatment of EGFR T790M and C797S resistant non-small cell lung cancer. Again, this is going to be, we will be seeing the data in the near future. If a newly diagnosed lung cancer patient tumor has both EGFR activating mutation and a PD-L1 positive greater than 50%, how would you treat the patient? A, treat with EGFR inhibitor only, treat with PD-L1 or PD-1 agent, treat with chemotherapy and PD-1, or treat with PD-1 and PD-L1 in combination with an EGFR inhibitor. So taking a step
back. This is an oncogene-driven tumor. In this case, you are right. The answer is A, treat with EGFR inhibitor only. All right. Moving on to poziotinib. Poziotinib is a quinazoline-based EGFR inhibitor. Interestingly, the small size and shape of poziotinib can fit to the binding pocket of exon 20. In a single institutional study done at MD Anderson, the confirmed objective response rate was 43%. Based on this, a pivotal multi-center phase 2 study was designed in North America. See, the poziotinib dose here was 16 mg once a day. The challenge in this study was, the objective response rate was just 14.8% in a multi-institutional study when compared to a single institutional study of 43%. What was the reason? The reason was poziotinib was found to have a high drug interruption rate of 88%, a dose reduction rate of 68%. Although it is active, again, it is challenging when the drug is developed across multiple centers. Again, in major cancer centers, the patients are taken care of very closely and monitored very closely, and side effects are taken care of. So, going a step back into the phase 1 area, into the drug development area, the plasma half-life when you compare poziotinib and osimertinib is different. And poziotinib has a plasma half-life of 7.9 hours compared to osimertinib of 48 hours. So the dose that was used on this study was 16 milligram orally once a day. So when we simulate poziotinib plasma concentrations, when we use a BID dosing, which decreases a Cmax and maintains a trough level above IC50. So based on this, now different schema are being designed using this drug poziotinib. And again, in the near future, you will be seeing data from the lower dosing level or the sequential dosing level or the 8 mg BID cohort as well. Next question, what is actionable in ALK positive non-small cell lung cancer? Is it the ALK mutation? Is it the ALK fusion? Is it ALK amplification or all of the above? The answer is B, ALK fusion. ALK fusion is actionable in ALK positive non-small cell lung cancer. So we have a host of therapies for ALK. So when you have a patient with oligoprogression on crizotinib versus a systemic progression, with oligoprogression, we consider local ablative therapy. In systemic progression, consider a next generation TKI. Interestingly, this algorithm gives us on-target resistance mechanism and the drugs that can address those resistance mechanisms, given that we have several agents like ceritinib, lorlatinib, alectinib, and recently brigatinib. Again, there is this ALK master protocol that randomizes patient based on the resistant mutation. And for instance, if the patient's tumor harbors the G1202R, the patient will be randomized to lorlatinib, and lorlatinib or ceritinib or brigatinib if the patient has an on-target 1171. So what is the lesson learned here? So biopsy or liquid biopsy is going to become standard of care at every treatment time point or every progression especially with targeted therapies like ALK. ROS1. So what's the latest in ROS1? So the safety and in vitro anti-proliferative activity of repotrectinib is shown here. And it was demonstrated in several patients with ROS1 related non-small cell lung cancer, especially with ROS1, the G2032R mediated resistance to crizotinib, that repotrectinib can be used in this case. The next target everyone has been waiting for is KRAS. KRAS, as we all know, has been the holy grail, and it's been considered the undruggable target. So specifically, this KRAS G12C mutation is found in approximately 13% of non-small cell lung cancer, 3 to 5% of colorectal cancer, and 1 to 3% of multiple solid tumors. Sotorasib, also called Lumikras, is the proposed INN name for AMG 510, is a novel, highly selective, first-in-class KRAS G12C inhibitor that has demonstrated anti-cancer activity and manageable safety profile in patients with KRAS G12C tumors. The study was called Code Break study, which enrolled patients at multiple dose levels. Sotorasib demonstrated clinical activity across a range of KRAS G12C mutant allele frequencies, PD-L1 tissue expression levels, and plasma TMB levels. So the data set was published in the New England Journal of Medicine earlier this year. And based on this data, sotorasib was FDA approved in May 2021. So what's next in the KRAS G12C space? There are several trials called the Codebreak 200, Codebreak 100, Codebreak 101 as monotherapy and in combination with multiple agents, including pan-ERB TKIs, in combination with PD-L1, combination with MEK, combination with SHIP2 are ongoing. So beyond the Amgen molecule, the Mirati molecule is also there. The Mirati is the MRTX 849, which is the adagrasib, is a potent covalent KRAS G12C inhibitor in vitro. Again, after establishing anti-tumor activity in KRAS G12C xenograft and non-KRAS G12C mutant human tumor xenograft models, early activity of the adagrasib in patients with lung and colon tumors has been demonstrated. So again, for KRAS G12C, we have not just one drug, but two drugs and more drugs in the pipeline for this space. I think there are more drugs and more combination therapies going to be developed in this space. HER3, interesting. Safety and efficacy of patritumab deruxtecan. So what is patritumab deruxtecan? So patritumab deruxtecan is a novel HER3-directed antibody drug conjugate. As we know, antibody drug conjugates, they consist of a monoclonal antibody, the patritumab, and they have a linker, a tetrapeptide-based linker, and a topoisomerase 1 inhibitor payload. HER3 apparently is expressed in most of the lung cancers, in 80% of EGFR mutated lung cancers, and the overexpression is associated with worst outcomes. So in this study of patritumab in 57 patients, interestingly, you can see deep activity of this agent across multiple TKI resistance mechanisms, especially in EGFR mutated non-small cell lung cancer. And anti-tumor activity occurs within 3 months in patients treated with patritumab deruxtecan. I think this is an exciting antibody drug conjugate. One of the challenges with antibody drug conjugates is the side effect profile, because they are associated with grade 3 thrombocytopenia and neutropenia in some patients. And interestingly, they also saw interstitial lung disease in 3 patients, which is 5.3%, and was adjudicated by the independent review committee as being related to treatment. So this is important because some of the antibody drug conjugates cause interstitial lung disease. And it's important clinically as we live in the COVID times, and we got to be careful when dosing patients who just were recently diagnosed with COVID or had subclinical COVID. So we want to make sure that these patients do not have any pre-existing lung damage, before starting these drugs. Again, activity was observed in patients with diverse TKI, resistance mechanisms, and they support further clinical investigation of this HER3-directed antibody drug conjugate in patients. RET, all right, this is an exciting space close to my heart. Frequency of RET fusions, 2% of lung cancer, 10 to 20% of papillary thyroid cancer, and less than 1% across multiple cancer types. And RET mutations are seen in medullary thyroid cancer, 60% in sporadic medullary thyroid cancer, and 100% of hereditary thyroid cancer. Again, the NCCN guidelines for RET rearranged lung cancer discovered prior to first-line therapy. The preferred first-line therapy is now a RET inhibitor, either pralsetinib or selpercatinib in the frontline setting. And if the RET rearrangement is discovered during first-line therapy or after first-line therapy, it's still RET inhibitor for a RET fusion positive patient. So where is the data coming from? The data comes from the Libretto study for selpercatinib. Again, in the data set of 702 patients, the primary analysis set in lung cancer consisted of 105 patients. And the previous platinum treated patients consisted of 105, and previous untreated patients were 39. The objective response rate by independent review was 64% in previous platinum treated patients and 85% in the previously untreated cohort. And again, you can see these phenomenal waterfall plots showing the maximal change in the tumor size in all target regions. And selpercatinib was effective regardless of receipt of anti-PD-1 therapy, regardless of previous multi-kinase inhibitor therapy, regardless of line agnosticity. And based on this data, FDA approved selpercatinib for lung and thyroid cancers with RET gene mutations or fusions in May 2020. The second drug for RET is the pralsetinib. This was based on the ARROW study, which was a dose escalation study. The primary endpoint was objective response rate. Again, in a similar fashion, they had a prior platinum cohort and a treatment naive cohort. The overall response rate was 70% in the treatment naive cohort, and the post-platinum cohort was 57%. And there were deep, durable responses, as you can see in this blinded independent central review. And 96% of evaluable patients had tumor reductions, and 100% of treatment naive patients had tumor reductions. This included 6% complete responses. We don't see that many complete responses in non-small cell lung cancer. Again, a 6% complete response rate in evaluable patients and 12% complete response rate in treatment naive patients. Again, this heralds the era of precision oncology and the power of targeted therapy, that a 12% complete response rate and 100% tumor shrinkage in treatment naive patients. Again, based on this data, pralsetinib received FDA approval. So what's next? So post pralsetinib and selpercatinib, which is the blue 667 and LOXO292, we see resistance mechanisms known as solvent front mutation. There is a new drug being developed to overcome the solvent front mutation called the TPX0046. I think in the next year or so, you will see data from the second generation RET inhibitor. So moving on to DNA damage repairing pathway. Again, this is the next target in lung cancer and multiple other cancers. Again, what are the DDR pathway targets? It could be the PARP, the DNA repair targets, the PARP, the double stranded breaks, the ATR, ATM, and DNA PK. The DDR inhibitors, there are several studies going on in the phase 1 area, the DNA PK, and we do have FDA-approved PARP inhibitors. In addition, other drugs like CHEK or MIT1 or V1 inhibitors are also in clinical development. So this started with a Nobel Prize for DNA repair that was awarded to Thomas Lindahl, Paul Modric, and Aziz Sinkar. Again, we have several agents in different phases of clinical development: the veliparib, rucaparib, olaparib, niraparib. So there are overlapping toxicity. The challenge is, overlapping toxicity when you combine them with chemotherapy has led to subtherapeutic dosing, and I think we need a better strategy, to develop these agents. Again, there is a differential side effect profile of these agents: the veliparib, olaparib. Olaparib has anemia, whereas niraparib has low platelets, and talazoparib has alopecia as a liability. Again, this is a current and upcoming evolution of PARP inhibitor combos. PARP inhibitors are being combined with mostly chemotherapy now and radiotherapy, but PARP inhibitors are going to be combined with VEGF therapy, immunotherapy, and several of the targeted therapies in the future. Another interesting area that is being researched is inducing chemical BRCA. Again, enhancing sensitivity to PARP inhibition by inducing homologous recombination defect phenotype in hormone HR proficient tumors with molecularly targeted agents. I think this is an area of active research, and you'll be hearing more and more and more, because therapies that can induce BRCA that is conferring sensitivity to PARP inhibitors include mTOR inhibitors, PI3K inhibitors, MEK inhibitors, AKT inhibitors, among others. Again, this is going to be an exciting area in the near future. Again, there are several PARP inhibitor combinations in clinical trials which are going to be updated in the near future. And ATR. ATR is also an apical signaling kinase along the DDR domain, and there are several combination studies going on in this ATR space. ATR is being developed as monotherapy. ATR is being developed as combination with checkpoint therapy, and ATR is also being developed in combination with PARP. So, what are the future strategies for drug development? So, we have the undruggables. So, we need to go after the undruggables. So, it has, the thing has opened up with targeting of KRAS into KRAS G12C, KRAS G12D, and KRAS G12V. So, in the preclinical space, drugs are being developed for KRAS G12D and V, and hopefully we will have drugs that can go after MYC, P53, and P-cadherin. One of the major issues that we have in oncology on primary and secondary resistance is the presence of co-occurring alterations and also emergence of resistance mutation. The emergence of resistance mutations severely impacts the durability of tyrosine kinase inhibitors in cancer. Again, we see the same overriding theme right from erlotinib to osimertinib to selpercatinib to pralsetinib to sotorasib, that there is a model of emergence of TKI resistant mutant clones. We need to identify mechanisms of resistance to the first generation tyrosine kinases. And then we need to offer combination therapies earlier in the disease course, and also develop third, fourth, fifth generation tyrosine kinase inhibitors. One of the major themes in oncology is to converting cold tumors to hot tumors. Again, cold tumors are PD-1 negative, low TMB, and low tumor infiltrating lymphocytes. And there are several mechanisms and several ideas that we can use to convert these cold tumors to hot tumors with high enriched tumor infiltrating cells, high PDL1, and converting them to a higher tumor mutation burden. Again, this is going to be a huge ongoing area of research. What is next in non-small cell lung cancer? We have the neoadjuvant therapy in non-small cell lung cancer. Surgery, whatever targeted therapy may be, surgery is the best targeted therapy for solid tumors. Surgery is the best option as curative intent. Node negative patients have residual disease. Node positive patients have residual disease. Patients present with distant metastasis, the current treatment options are non-curative. Neoadjuvant therapy with a TKI inhibitor therapy has the potential to improve disease-free rates. I think you'll be seeing more and more of these drugs being approved in the neoadjuvant therapy space. So right now, most of my talk was about genomics. And let's take a step back. The story of 6 blind men and women and the elephants. It's not just about genomics. We need a whole molecular portrait of the patient tumor walking in the door. The future is going to be metabolomics, transcriptomics, immunogenomics, microbiomics, and proteomics. Right now, the current paradigm
talk. I'm not sure if we have any questions from the audience. Yes, we have one question from Dr. Mufarrij. Audience, yes, we have a question in the back.
Thank you so much for your great lecture. I had a question. Do you have any data on the side effects of these medications? Do you see more of your side effects when you do combination therapies?
I didn't hear your question.
I said, you spoke briefly about combination therapies. Do you see unusual side effects with the combination therapy?
L1. Is there any data about that?
Absolutely. I think that
Online questions. I don't have access. Micheline? So, well, if no more questions, we will end this session. Thank you so much, Dr. Vivek, for your presentation and for answering all the questions. Have a nice evening.
Thank you.
Thank you. Thank you. Our next speaker would be Professor Mark Vincent. Professor Vincent is a professor of oncology at the University of Western Ontario and a consultant medical oncologist at the London Regional Cancer Program, where he is chair of the thoracic multidisciplinary team. He holds several patents relating to potentiation of chemotherapy and targeted agents across a broad spectrum of cancer types. He is co-founder and chief executive officer of Sarissa. Professor Vincent.
Thank you very much. Can you hear me?
Yes, we can. Thank you.
distribution between deletion 19 and exon 21 is, as we would expect, about 55 to 45. And again, a similar proportion of patients had adjuvant chemotherapy, about 55 versus 45 who did not. And here is the perhaps one of the most important graphs in medical oncology to emerge in the adjuvant setting. And placebo, two very widely separated curves here. The hazard ratio here for the disease-free survival at 0.17. It's not that common that you see this kind of a hazard ratio. The follow-up now is about 22 months for osimertinib and 15 for placebo. The median for osimertinib is not yet reached, but for placebo it's about 20.4 months. The maturity here is about 33%, so it's still possible that we will get further information for this in the fullness of time. But this is a staggeringly successful study. What you do see, particularly in the osimertinib group, is a fairly sharp fall-off after 36 months, which might indicate a hypothesis that the osimertinib might be beneficially continued beyond the 3-year cut point. But that's a hypothesis at the moment. This is the secondary endpoint in the overall population, including stage 1B. The hazard ratio is still a very, very good 0.21. The 95% confidence intervals come nowhere near overlapping the unity mark, and the p-value is very robust. If you look at the forest plot, you see the benefit here is in all of the patient subgroups by gender, by age, by smoking status, by ethnicity, by stage. Stage 1B, perhaps the benefit may be less impressive because, of course, the risk here is much lower in these stage 1B patients, but it's still pretty impressive at 0.5 and really doesn't cross the unity by 0.25 to 0.96. And in both the categories of EGFR mutation, including exon 19 and exon 21, and whether or not they had adjuvant chemotherapy. So we can see it here broken down by stage. The hazard ratio in stage 1B, stage 2, and stage 3A spread across this slide. Hazard ratios respectively 0.5, 0.17, and a staggering 0.12 in stage 3A, which indicates quite clearly that the higher the risk, the better the hazard ratio, the better the effect of the osimertinib, the more important it is to continue it. And again, that rather tantalizing fall off after 36 months in the stage 3A category, again, suggesting quite strongly that in these patients, at least, there might be benefit in continuing beyond 36 months, but that was not tested in this study, and that is something that perhaps lies in the future. The overall survival data is immature, but you see here it's trending in the right direction, favoring osimertinib with a hazard ratio of 0.4, but this is only maturity of 5%, and so we will need to wait further to get the full story here. Patients who received chemotherapy, not so many in stage 1B, unsurprisingly, only about a quarter of them. In stage 2 and stage 3, it was 70 to 80%. So this benefit, this very strong benefit, particularly in stage 2 and especially in stage 3A, occurred, whether or not you had chemotherapy, and occurred in the face of chemotherapy. So giving chemotherapy does not abrogate you from the responsibility to inform patients about the study and probably at this stage to offer them the treatment. So here you see the curves with and without adjuvant chemotherapy. The hazard ratio in each case, very impressive, 0.16 with adjuvant and 0.23 without. And of course, the without adjuvant chemotherapy here was enriched with the stage 1B patients. So here it is represented in a different kind of graphic representation. You see here for the stratified or the unadjusted, the hazard ratios for stage 2 or 3A with or without adjuvant chemotherapy. Stage 1B, it's almost most of them are without, so you don't really see a with adjuvant chemo, but the hazard ratio there, 0.38 for disease-free survival. Stage 2, with or without stage 3. So really a very substantial benefit in disease-free survival, whether or not adjuvant chemotherapy had been administered. So it's interesting to look at the relapse frequency and the location of relapse. If you see in the patients who received osimertinib, there are 11% events for disease-free survival, whereas there's 46% in the patients who got placebo. But not only was there a substantial difference in the frequency of events, failure events, that is disease-free survival events that would trigger that, but also the location of the disease. So in the patients who had osimertinib, most of the recurrences are local regional, whereas in the patients who had placebo, most of the recurrence is distant recurrence. So a completely different type of recurrence, as well as a major difference in frequency of recurrence. And in fact, the central nervous system was the most common extrathoracic location of recurrence. And you see here that in patients who had placebo, 10% of these patients developed CNS recurrence. And we know that that can be very devastating to patients, and many of them are not the same people before and after CNS recurrence. Whereas only 1% of patients had a CNS recurrence, especially a CNS-only recurrence on the osimertinib arm. And here's the CNS disease-free survival in the overall population. You see here almost nobody relapsing the CNS on the osimertinib until after 36 months. And again, there's this very interesting phenomenon where when you stop the drug, about 3 or 4 months later, some patients recur. And that, again, is a hint that there may be interesting work to be done in asking the question as to whether continuation beyond 36 months would be a good idea, and that needs to be investigated in a randomized trial. And if you look at the CNS DFS in the overall population, you see that patients start to fail in the CNS by about 4 months after surgery, and this gets kind of worse and worse out to 2 years. So ultimately, 20% of these people fail in the central nervous system, which is an unacceptable risk. And in the context of breast cancer, by the way, that would be considered completely unacceptable if there was a solution to it. And this curve clearly shows that there is. There are actually 4 lines on this curve. One of them is so close to the x-axis that it's actually difficult to appreciate. And that is the osimertinib CNS-only recurrence rate at kind of less than 1% compared to about 9% on the placebo. And the other dashed curves there are the non-CNS recurrence, which is again is heavily in favor of osimertinib. So there's bottom line is there's an incredibly high degree of CNS protection from osimertinib in people with resected common mutations in the EGFR. What about toxicity? We know that a lot of these patients expect to be healthy after surgery, and many of them are cured, or some of them are cured. We have to be very careful what we do to their quality of life. And I guess the leading indicator here is, what about adverse events leading to death? And the answer is, well, there weren't any. So it's not to say it can't happen. I think you have to look very carefully at these people, keep a close eye on them. What is the risk of interstitial lung disease? Well, it turns out to be very, very low in this population with this particular drug. But in the earlier generation EGFR TKIs, there was a certain incidence of it. So this is a safer drug, no deaths. What about leading to discontinuation? Well, it's about 11% versus 3%. So about 8 people different out of 100 are going to have an early discontinuation because of osimertinib. And I think, given the extent of the benefit here, that's an excellent trade-off. It's an excellent proposition and a very, very good deal. Any grade 3, 20 versus 13, and so on. And so possibly causally related. So any serious adverse events, 3%, 1%. What are these side effects on osimertinib? Well, there's a bit of diarrhea, but mostly it's grade 1 or grade 2, only 2% grade 3, 4. There's a bit of paronychia. There's some dry skin. There's a bit of pruritus. There's a bit of a cough. The cough, however, is identical between osimertinib and the placebo, so it is likely not due to interstitial lung disease. It's just likely due to something else, but probably not drug-related. There's a bit of stomatitis and so on, but really it is almost all of it grade 1, grade 2. That's not to say you can ignore it. I think in my personal experience, and I've given a lot of osimertinib now, some patients don't tolerate 80 milligrams so well and prefer the 40 milligram dose. So I think you should remember you always have the ability to lower the dose to 40 milligrams. And in my opinion, that almost always solves the problem. Grade 1, 2 interstitial lung disease was reported in 3% of patients in the osimertinib arm. QTc prolongation in 22 patients, that's 7%, and 1% in the placebo arm, and 1% in the one patient in the placebo group had a pulmonary embolism. So it's probably reasonable to keep an eye on the QTc on the ECG, to get an ECG before you start on this, to ask yourself, are there any other drugs that could interact to prolong the QTc? I think that's good medicine. So general medical principles apply to this as to anything else. The incidence of serious side effects is low, but it's not zero. And these patients are generally healthy, and we need to keep an eye on that aspect for a quality of life point of view. So in summary, this is the first targeted agent in a global trial to show a statistically significant and clinically very meaningful improvement in disease-free survival in these patients with resected stage 1B, 2, 3A and the common mutations, with overall a 79% reduction in the risk of disease recurrence or death with osimertinib, DFS hazard ratio of 0.21 and a very robust p-value. And the osimertinib versus placebo DFS rates at 2 years, which is a landmark analysis of 89% versus 53%. And the administration of adjuvant chemotherapy didn't have an effect on this beneficial outcome. So whether or not you give adjuvant chemotherapy, I think there's still it's still very worthwhile considering adjuvant osimertinib on top of that. And if you're going to give chemotherapy in this particular trial, the chemo was given first and then the osimertinib afterwards. This trial does not study and does not endorse concurrent osimertinib and chemotherapy. Safety profile is consistent with what we know about osimertinib and has a very, very low incidence of grade 3, grade 4 serious adverse events. So we believe that this is practice changing. And in fact, this has been endorsed by the NCCN, which recommends that in the event of an EGFR mutation positive patient with 1B, 2 or 3, that this maneuver of osimertinib for 3 years strongly be considered. And furthermore, that we should in fact do EGFR sequencing, particularly on adenocarcinomas that are resected, whether they're smokers or not, whether you intend to give them chemotherapy or not. It's very reasonable to do an EGFR status and a molecular profiling on all patients, not just the metastatic ones, but on all patients who are resected with early stage disease. And with that, I'm going to move on now to a 5-year update on the development in stage 3, the Pacific study. We know that we've hit a bit of a glass ceiling here with stage 3 non-small cell lung cancer from 1990 to just recently with the advent of development. We see that patients with regional or advanced local regional disease cured maybe 30%, perhaps it's even a bit optimistic, maybe 25 to 30%, 5-year survival with chemotherapy and radiation. Some of these patients had prior stage 1 and recurred locally. Some of them presented with stage 3 de novo. Some of them actually had a brain metastasis, but otherwise stage 3 brain metastasis resected, and you kind of treat them like a stage 3. So there's many, many different roads to the kind of stage 3 paradigm. And by the way, there's a whole issue about how you work these patients up with staging investigations that I don't have time to go into tonight. But just to make the point that, not everything that lights up on a PET scan is necessarily cancer. PET is not sensitive, it's not specific enough, and so probably invasive staging is probably a good idea with EBUS or whatever you are competent with at your institution. In this case, biopsy of the nodes happen to show sarcoidosis. So wherever you have, perhaps a high background incidence of tuberculosis, and so PET scan may be quite misleading. Management of stage 3, single modality, whether it's surgery alone or radiation alone, has very poor outcomes. We really need to talk about combination modality. Traditionally, this has been a bit of a battleground between surgeons and radiotherapists. For those patients who have N2 disease, initial surgery has really become now not a standard option, except perhaps for patients with single station small nodes in the upper mediastinum, where it is something that might be considered. This is something where you do have to really have a thoracic multidisciplinary team. You just have to establish collegiality because there's issues about turf and so on and so forth, and who manages what traditionally. And so you have to work closely here with your surgical colleagues and integrate new knowledge here. And it's very, very important for your patients, given what I'm going to show you. The standard does remain concurrent chemoradiation, now followed by immune therapy. And the question is there a role for surgery after neoadjuvant chemotherapy? Well, the NCCN has battled with this as well. This is a complex minefield, and I don't have time to go into it this evening. But basically, just to say that there are certain patients that the NCCN recognizes might be suitable for surgery, particularly patients with limited amount of nodal disease and relatively small tumors that don't invade central structures. And this is depicted here. But in the event that definitive concurrent chemoradiation is the choice, it should be followed by durvalumab. In the higher stage, T-stage patients, T3, T4, but with few or no lymph nodes, there's a spread here between unresectable, possibly resectable, and resectable, and this management has to be individualized. Some of these patients may be resectable based on the team's competence and very individualized, deep thought about this. But many of them are frankly not resectable. The one thing you don't want to do is to give inadequate chemoradiation, then get into surgery, open them up, find that you actually can't resect them, and then you could perhaps lose the opportunity for definitive chemoradiation and definitive immunotherapy. So you really don't want to half-treat these patients. And if you're going to do surgery, you should be very, very certain that you're going to be able to get it out. This is not the time or place to play around with maybe. In terms of more advanced stages, T3, T4, depends on the nodal status. If the nodes are negative, occasional patients may be resectable, but most of them are not and should be treated with chemoradiation. And especially the T3, T4, N2, and 3 patients, stage 3B and 3C, surgery is contraindicated, and these patients, the NCCN recommends, should be treated with definitive concurrent chemoradiation followed by durvalumab and then surveillance. So in the interest, I'm going to move on here.
Well, actually, Professor Vincent, we're running a little bit of time. If you don't mind, sorry to interrupt you. If you don't mind,
I can cut right through to the quick here. So basically, the 5-year survival for the durvalumab versus placebo here is going to be shown. This was a study done, good performance status patients, stage 3, had to have chemoradiation, could have had some chemo up front, but had to have chemoradiation and no chemo after the chemoradiation. Durvalumab versus placebo, up to 6 weeks. And here is the 5-year survival. This shows these curves separate early, they stay apart, they don't come together. And this is the biggest and major advance in stage 3 non-small cell lung cancer in 30 years, to be quite honest. And so this is something that has now become endorsed worldwide, including by, for example, the NCCN, and it's approved in my country, Canada, and elsewhere in the world. The hazard ratio here, 0.72. These curves are not coming together. It looks like we may be curing some of these patients, perhaps curing another 12% or so, which is a huge advance. This is the progression-free survival out to 5 years, 19% on placebo, 33% on durvalumab. This is a very large benefit. The drug has known to be safe. There are occasional instances of pneumonitis. You can discuss whether it's radiation or immunotherapy or both, but by and large, short course of steroids, hold the durvalumab, and reintroduce it if the patient recovers. It's not that common. The tolerability here is generally very good, but you do have to keep a close eye on these patients. But there's a huge benefit here. 5-year survival, sustained overall survival benefit. 43% remain alive at 5 years compared to 33% with placebo, and a third remain alive and disease-free compared to less than a fifth on placebo. And this is now being investigated in a slightly different way. Is it 2 years? Should it be 1 year of durvalumab or 2 years? Can you combine it with chemoradiation at the same time, or should it be given sequentially? And these are details that we're going to spend the next 5 years sorting out. So with that, I thank you for your time. I'm sorry to rush through it, and I hope that your patients will benefit from these exciting new innovative treatments that can potentially cure an extra percentage of these patients, which is a big thing to say in lung cancer. So thank you very much.
Thank you for presenting this impressive and practice-changing data. And it was a pleasure having you in the meeting. For the sake of time, I was told that we cannot take any questions, so we'll end this session. Thank you.
Thank you very much.
They did not cut electricity.
Bismillah ar-Rahman ar-Rahim. In the name of Allah, the most gracious, the most merciful. Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning. His Excellency, Mr. Awad Sghayr al-Katbi, the Director General of Dubai Health Authority, Dr. Marwan al-Mullah, Deputy Director General of Dubai Health Authority, His Excellency, Mr. Asim Ababna, Consul General of the Hashemite Kingdom of Jordan in Dubai and Northern Emirates, Professor Solange Peters, President of the European Society of Medical Oncology, Dr. Moses Sharhan, the President of the Emirates Medical Association, and Professor Hamid Al-Shamsi, the President of Emirates Oncology Society. Dear members, ladies and gentlemen, very good morning to everybody and welcome to the second Emirates Oncology Society Conference of 2021. Let's start this 2-meter social distancing conference by the national anthem. Let's all rise to the national anthem. Now we will listen to a verse from Quran al-Karim.
بسم الله الرحمن الرحيم إذا جاء نصر الله والفتح ورأيت الناس يدخلون في دين الله أفواجا فسبح بحمد ربك واستغفره إنه كان توابا.
صدق الله العظيم. Hope all of you will enjoy the second Emirates Oncology Society Annual Conference, and I would like to ask Professor Hamid Al-Shamsi to join me in the podium for a short talk.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to say thank you to my friend and colleague, Dr. Aida Al-Awadi, who was not introduced. Dr. Aida Al-Awadi is one of the pioneers of oncology in the UAE. She completed her training at MD Anderson, which is one of the leading cancer centers in the world, and we work closely together to improve the cancer care with our colleagues here from across the UAE for the best care for our patients. So, Your Excellencies and dear colleagues, it's our pleasure to welcome all of you today in the second edition of the Emirates Oncology Society Conference this year, which will be brought to you in hybrid format. I would like first to welcome His Excellency Awad Sghayr al-Katbi, Director General of Dubai Health Authority, Dr. Marwan al-Mullah, the CEO of Health Regulation Services at DHA, Dr. Moses Sharhan, the President of the Emirates Medical Association, His Excellency Asim Ababna, Consul General of the Hashemite Kingdom of Jordan in Dubai and Northern Emirates, Professor Sloan Peters, the President of ISMO, of the European Society of Medical Oncology, Dr. Rana Haja, Deputy Regional Director of the WHO Eastern Mediterranean Region, Dr. Khalid Saleh, General Secretary, the Gulf Federation of Cancer Control, Dr. Sami Al-Khatib, Secretary General of Arab Medical Association Against Cancer, as well as all the GCC, MENA, International Oncology Society leaders, presidents, members, and guests today, either with us here or in person or virtually. Dear all, cancer is the third leading cause of death in the UAE. We have around 2 or 3 deaths per day, which translate to around 1,200 deaths per year. And there are around actually 10 cases being diagnosed on a daily basis, which translate to around 4,200 cases per year. Again, the cancer will continue to increase, and according to WHO, the numbers will increase up to 300%. Again, 300% over the next 20 years, that's in 2040, and trust me, this is not too far from now. So we're gonna see a significant increase in the number. And this increase in number not only comes by numbers, but also with a significant expense to the economy, and also will be having significant share of any health system resources. So that's why we're here today. We have to talk about cancer. We have to think about cancer. We have to act today about cancer. So how can we fight cancer as a community and also as a health system? The DHA, DOH, and Ministry of Health and Prevention are working very hard closely to improve the cancer care through improving access to all citizens and also to the expats living in the country. Are there challenges? Yes, there are so many challenges. We have to acknowledge them, and we have to work closely to improve these challenges. So what's the role of EOS, or the Emirates Oncology Society? The EOS, which is under the umbrella of the Emirates Medical Association and the Ministry of Community Development, is a non-profit organization with a mission to complement the role of the regulators, provide evidence-based opinion for our partners, regulators, and also stakeholders taking care of the cancer care in the country. The US has been working very closely over the last years with the Ministry of Health. We have been members of the UAE National Committee to reduce the mortality from cancer, and also we've been involved in developing cancer awareness campaigns with the Ministry of Health as well. Also, we have been working very closely over the last few weeks and months with our colleagues at DHA, with Dr. Marwan Al-Mulla, to improve the cancer care, the quality control for cancer in Dubai through the assessment of surgical oncology, medical oncology, radiation oncology, pathology, and also palliative care. The EOS also has been partnered with national and international societies, for example, with ESMO, European Society of Medical Oncology, to improve the quality care. And yesterday, it was our honor to have Professor Sloan Peters to inaugurate the first accredited center in the UAE under ESMO. The ESMO also is leading the cancer research in the country. Over the last 2 years, we have published more than 30 publications in leading journals, including JAMA Oncology, Lancet Oncology, The Oncologist, BMC, and JCO. And this only shows our commitment toward our country and our nation, and also to the field of oncology in the UAE. Your Excellencies and dear colleagues, today we celebrate another milestone of the UAE oncology community. This is not just another conference. This is another step forward, inshallah, to come together, to sit down and talk and to consider how can we improve the cancer care in UAE. Over the next 2 days, we have experts from around the globe who will be providing us with the latest advances in cancer care in the UAE and the region, and which will help us also to advise our colleagues and regulators in how to improve our cancer care. Lastly, I would like to thank a few people. I would like to thank Dr. Moses Sharhan, who has been supporting us as Emirates Oncology Society from day one over the last few years. She's been available, she's been supportive, and I can't thank her enough actually to be with us here today. Also would like to thank Professor Sloan Peters, the president of the ESMO, for her support for the oncology community in UAE and also for our society since day one as well. I would like also to thank our pharmaceutical partners for the support for our research. We understand the research could be cumbersome for many organizations, but our partners from the pharmaceutical companies have been very supportive of our research, and we thank them for that. Also, would like to thank them for the patient support program, which has been helping our patients, especially in the private sector, which improves the access to the medications, which we understand very expensive for many patients and they cannot afford. I would like also to thank everybody who's been here today, who's been taking time off work to be available and to celebrate with us today's event. Also, I would like to remind you, please, to wear your mask as much as you can, sanitize your hand, and also keep the physical distancing as much as possible. And lastly, I would like to thank everybody who has been here today or also joining us through hybrid and online. Thank you so much for your attention.
Now, I would like to invite Dr. Solange Peters to give her speech, the President of the European Oncology Society.
Dear Excellencies, dear professors, dear colleagues, and dear friends, it's really my great pleasure and honor to be here today with all of you. I'm very often asked when I come here if it's the first time I come to Dubai or to the Emirates. The answer is no, I came several times here before. And one of your colleagues reminded me yesterday that I was teaching here in 2015, outside of my function from ESMO, outside of any official statement, just because I always found that this country is the root, is a country where everything can be developed, a bit like my country, Switzerland, despite it's a small country, can be developed fast and actively in an efficacious manner to reach the patient very fast. And I like how much this country can show us, demonstrate to all of us, that everything can happen through diversity. We were discussing it yesterday. That's a country where you will meet doctors and nurses from everywhere around and from far away. You will meet doctors from any countries from the globe, Europe, Americas, and of course also the region. It's a country where you will meet all ages, all genders, without any difference, as long as they have the skills and the competencies to treat the patients as well as they can. And believe me, I spent my years traveling, my 3 years of ESMO presidency traveling. There are few countries where diversity based on skills is considered first. And here, that's the first argument. First, you need to be the best in what you do, and afterwards, you can start to discuss how practically it is easy for you to come, travel, stay, and work in this country. So that's probably the way to move. Everywhere in the world, competency, skill, and patient care is the only thing we should think about when it's about choosing people and creating a system. Collaborations can happen everywhere. And this is the example, right? I'm here as an ESMO president, while there are many European countries where I never was invited to and we never went to because we don't have collaborations. So collaborations have no borders. But it's important to say that optimal cancer care can also happen everywhere. It can happen here, it can happen probably more probably here than in other countries where the commitment is not as strong as it is in this country. Of course, I like to compare this country with my country because probably of diversity, but also because we are here in countries with resources, we have to say, but small countries, right? What are the benefits of having, I would say, wealthy small countries? So first of all, you can move fast. You can move efficiently, fast, and you can always keep in mind that the patient is the goal of everything we do. And you can reach it faster than in a big country, like in Europe, for example, France or Germany. Here it can be fast, in Switzerland too. Second is quality. We can work with quality in everything we do. The third thing is solidarity. And I was impressed yesterday when I came to Abu Dhabi Hospital to see Bourjil, to see that it's also about taking care of patients who come from Syria or now from Afghanistan, because the system allows for solidarity. And that's not the case in many countries in the world. Of course, there are some flaws in being a small country. Education and research needs to be organized. And it's more difficult because you need to find time, people, resources to do it. And it's not a large country, so it's a kind of micro education that you need to put in place, that it's more difficult. The other thing is, of course, the workforce, because to find all the doctors and all the nurses and all the, I would say, caregivers, it's a challenge in a small country because not everyone can do medicine, right? So you need to look beyond, right? And of course, we need to do a bit more internal politics. We're in a small country. You need to network a bit more. But I found that here, it looks like networking is in place and works very well. So Switzerland, UAEs, there are common points, and it's a long distance. I'm coming from far away, but I can find myself feeling the efficacy and, I would say, the extraordinary capability of your country in doing that. So on behalf of ESMO, I'd like to thank you for inviting us here. 1 time, 2 times, 3 times, we'll always be there. We are very proud of having been involved in your society from the very beginning, and we are very proud that you have a society being part of the ESMO. So thanks a lot again, and have a wonderful Congress, because it's important to meet again after COVID. Thanks a lot.
Thank you so much, Dr. Peters. It's such an honor to have you with us today. So now a special address by Dr. Rana Al-Hajja, Director of Program Management at the World Health Organization in the Eastern Mediterranean region.
Assalamu alaikum, sabah al-khair, colleagues and your excellencies. Hard to mention all the names, but Dr. Al-Qutbi, Dr. Humaid Al-Shamsi, Dr. Muza, all esteemed colleagues, distinguished speakers and participants, ladies and gentlemen. Thank you very much for inviting WHO to be part of this important meeting. It's an honor for us to be here with you today at the 2nd annual conference of the Emirates Oncology Society. And honestly, it's a pleasure to be here in person. This is actually an accident. I happened to be in UAE, in Abu Dhabi, actually for another business. So when the opportunity came, I welcomed being physically present here with you all in person. And of course, the opportunity to meet is much better than being just online. And also, of course, it's a pleasure for us to discuss cancer prevention and control in the Eastern Mediterranean region from a regional perspective. Again, I would like to express my sincere appreciation for the efforts of the Emirates Oncology Society, that I will refer to it as EOS, as Dr. Humaid did earlier. It's easier, for its commitment and determination to provide a platform for informed discussion to address the profound impact of the ongoing COVID-19 pandemic on cancer services locally and around the world. And greetings also, salamat, from Dr. Ahmed Al-Mandari, our regional director. But I would also like to seize the opportunity to commend the government of the United Arab Emirates for its efforts to prepare and to respond to COVID-19 pandemic and its close collaboration with us at WHO. I think it's very obvious to many in the region that Emirates has really led efforts by example, and the efforts to better respond to the pandemic have really resulted in many lessons learned for the region and globally as well, and especially recently as an infectious disease specialist and immunization specialist, the efforts in leading the vaccination campaign, which have been just amazing. You know, I mean, I think we are here to discuss the detrimental effect of the pandemic on cancer care, and we have been maybe quite opportunistic at WHO recently, although this has been, this pandemic has affected every aspect of our lives and healthcare. It has nonetheless brought unbelievable attention to health. Never in our lifetime we have seen so much attention given to health and to the health systems that really need to be in place to ensure adequate health services are accessing and reaching everyone. As we say in Arabic, you know, عسى أن تكرهوا شيئا وهو خير لكم أو رب ضارة نافعة. You may not hate something that turns out to be better for you, or as we say in English, always there's a silver lining. Allow me please to speak briefly about cancer in the region. You've heard from Dr. Humaid about cancer in the UAE. Cancer is a leading cause of morbidity and mortality in the WHO Eastern Mediterranean region. It is the 4th leading cause of death and the 2nd cause of non-communicable disease-related death in our region after cardiovascular disease. with a growing incidence. And also in our region, we have the most significant projected increase in cancer burden among all 6 WHO regions. So things are not looking good, which means we really need to accelerate and intensify our efforts. According to the International Agency for Research and Cancer, EARC, approximately over almost 700,000 new cancer cases and over 400,000 deaths were reported in our region in 2018. A number that is projected to double in 2040, unfortunately. The increasing trend is mainly related to aging, which is, in a way, it's a good thing, we cannot control it, but also there are many other risk factors that are preventable that we can do something about. Importantly, in the UAE, a rise in cancer incidence is associated with an accentuated exposure to certain specific risk factors. Most of them are preventable, again, including physical inactivity, sedentary lifestyles, overconsumption of high-caloric foods, etc., and the low-caloric diets, in addition to the rising smoking prevalence, unfortunately. The prevalence of obesity in adults in the Eastern Mediterranean region in general remains high, especially among women, and the prevalence of diabetes mellitus parallels that of obesity. This is what we call the silent pandemic in our region. The increases in body mass indexes are expected to have substantial effect overall on various cancer incidents, whether it's colorectal, liver, gastric carcinoma, particularly among men, but also breast cancer, which is the most prevalent cancer overall, followed by lung, cervical, colorectal, and prostate cancers are also affected. And I don't really need to tell this audience here, I mean, you are the expert on cancer and non-communicable diseases, but I wanted to really address few key challenges in our fight towards cancer. 2 big challenges. First is the lack of accurate and well-defined data, because without data, we cannot assess the burden, the true burden, and we cannot monitor our interventions. And then the second one I would like to focus on is prevention, because at this point, especially for us as public health professionals, there's a lot that we can do about prevention. And what I learned from all my colleagues at WHO, that globally now 40% of cancers are preventable, 40% are cured, and 20% can be palliated. So that's a lot that we can do with 80% to prevent mortality. The data is a big issue because I think it's one of the really obstacles to come up with good health policies for cancer. Without good data, decision makers like your esteemed selves cannot really make the right decisions, where to put resources, what areas to focus on, how are we going to monitor the impact of an intervention. Therefore, having good cancer registries, good health information systems is critical. In our region, while 80% of countries have national cancer control policies, only 45% of these programs are operational, and 68% have population-based cancer registries. Yet, the systems remain deficient in early referral, especially screening, coordinated management in most of our countries, with cancer control efforts mainly directed towards treatment. We definitely need to do a lot more in terms of screening, because if we cannot prevent cancer overall, we can at least prevent mortality from cancer by early detection. With the current COVID-19 pandemic, disruptions of cancer services, including the suspension of screening programs, delays in diagnosis and treatment, including palliative care, are likely to exacerbate an increase in advanced stage diagnosis and cancer mortality, unfortunately. This was confirmed by a recent WHO survey in February 2021 that we underwent to assess the impact of the pandemic, which revealed the considerable impact of the pandemic on cancer prevention and control services in the region, mostly affecting low-income countries, but actually all countries were affected. Significantly, many EMR countries reported disruption in cancer screening, as well as treatment and vaccination services. In light of this regional burden and building on the global WHO resolution, WHO EMRO developed a regional framework. We are very good to have frameworks at WHO, but we need to make sure these frameworks are well adopted and implemented. For cancer prevention and control, which aims to support countries to develop a more systematic and integrated approach to cancer control. that is aligned with our EMRO Vision 2023 to promote healthier populations and improving access to universal health coverage while addressing sustainable development goal. Our motto in the region is health for all by all. This is not something one ministry or one society or one group of people can do. We need all concerted efforts by all partners in multiple sectors in order to reach these goals. Additionally, at WHO, we have embarked on 3 global initiatives over the last 3 years, specifically the Global Initiative for Childhood Cancer, another area that needs more attention, the Global Strategy to Accelerate the Elimination of Cervical Cancer, an area as a woman and as an immunization specialist I feel very passionate about, and the Global Breast Cancer Initiative, again, knowing that breast cancer now is mostly curable. The momentum in implementing these initiatives has been on the rise in the region. However, there are different levels of implementation depending on country context. Speaking of prevention, I would really like to congratulate the UAE for implementing and demonstrating the implementation of all these initiatives. UAE was one of the first countries in the region to introduce HPV vaccines. And I know it was not easy because we have been working with them very closely. They had to deal with very sensitive cultural, social issues, a lot of resistance, but they insisted on doing the right thing. It is one of the few countries in our region that has actually introduced HPV vaccines in their national immunization program. And I hope very soon more countries in our region will do that, because we want to protect our daughters, our sisters, our spouses, and our mothers. To reverse the trends in cancer, we need a comprehensive and coordinated cancer response that is based on robust planning and efforts towards universal health coverage. WHO remains fully committed to working with all the partners, including civil society in particular, in this endeavor. I look forward to our future collaboration to strengthen our joint engagement and to accelerate the implementation of all cancer control initiatives. Once again, thank you again very much for inviting me here today. Good luck with the meeting, all the best, and look forward to contribute to the discussions. Thank you very much.
Thank you, Dr. Rana, for this enlightening speech, and it's such a pleasure to have you with us today. Now I would like to invite Dr. Mohammed Al-Marri to give a research presentation. Dr. Mohammed Al-Marri recently completed his PhD at the University of Cambridge, specializing in population genomics. While studying at the Wellcome Sanger Institute in Cambridge, he led the analysis of the Human Genome Diversity Project, which analyzed complete genome sequences in more than 50 populations from around the world, creating the most comprehensive reference of human genetics variation. The project was published in 2 papers by the journals of Science and Cell. So I would like to invite Dr. Mohammed to the podium to give his presentation.
Okay, Assalamu alaikum wa rahmatullah. Your Excellency, distinguished guests. My name is Mohammed Al-Marri. I'd like to first thank the organizers for inviting me to talk about my research. I just have 5 minutes, so I'm going to go over quickly about my research. So, since the Watson-Crick discovered the DNA double helix in 1953, and Frederick Sanger in 1977 first discovered a method to sequence DNA, this was a huge effort that culminated in the human genome being first published in 2001. However, this was just one human genome. It does not encompass the diversity found around the world. So since then, there's been a lot of papers coming out, high impact papers, trying to catalog the variation we find globally. And for the reason is, and the biggest paper published so far is the 1000 Genomes Project, which studied 26 populations from around the world. And the goal from this paper was to catalog all genetic mutations or variants at over 1% frequency. There was a specific reason for this, because common disease is thought to be caused by common variants. So by cataloging all variants over 1% frequency, we can run association studies to identify these mutations that cause disease. So what we do is we use GWAS, or genome-wide association studies, across variants that we already know are found. We look at associations between phenotype and mutation. And doing this across the genome, we find specific mutations that are associated with disease. So in 2006, when this was first established, we just had a few points that we know in the genome that is associated with disease. But a couple of years ago, approximately the whole genome, we know thousands and thousands of mutations that are associated with disease. So we can use this huge amount of data to create risk scores for every individual. And a couple of years ago, this was shown specifically in heart disease to be quite effective. If we take the whole population, we can identify the top 1% or top 5% that have a very high risk of disease and manage their illnesses. However, as I'll show now, most of these studies are found in European individuals. And if you want to transfer the information from European individuals to other populations, the prediction accuracy goes down dramatically. This is because almost 80% of all studies so far has been done in people from European ancestry. If you look down in red, if you take all of the Middle East, it's only 0.0001% of all of this. So this is a big gap that we need to fill by doing research in the region. So in my PhD, I worked and led the analysis of the Human Genome Diversity Project, which is a huge catalog of 54 populations from around the world. And we published this last year in Science. We created the most comprehensive reference for genetic variations globally. We identified almost 70 million mutations. Almost 20 were not identified previously. And what we show here is some of these mutations reach 20, 40, 50, 60% frequency globally, but were not previously identified. So we don't know the function of these variants, so they need to be included in future association studies. And what we find is when you look at rare mutations, they tend to be geographically restricted. They're not, so as you can see from this graph, is African populations share more mutations with each other compared to Asians or Europeans or Middle Eastern populations. And a second paper I published in Cell was using the same resource to identify different structural variants, so deletions, insertions, duplications that also are reported in disease. So what we also found is, if you look across the genome, the reference genome contains many gaps that were not identified previously. So a single reference genome is not representative of everyone. We need lots of high quality, diverse reference genomes. So our papers were applauded, and we have now the biggest catalog of human genetic variation globally. However, a second paper I was personally interested in, also published in Cell 2 weeks ago, was about the Middle East specifically. So these previous projects that I work on, Arabian specific, did not have any data that was collected. So in the past 3 years, I worked on a study to take samples from all over the Middle East, from the Levant, Arabia. And when we published the study, what we found is there is very strong genetic structure or differentiation within the Middle East. The Middle East is not a homogeneous population. If you compare the Levant, even within the Levant or within Arabia, there is very strong genetic structure. And by understanding the structure, we can design medical studies in the future. And we identify many mutations that increased in frequency very recently. So just to give you an example of this mutation, it's almost 0% globally. It was not previously found, but we find it in this region, in the UAE, in Saudi, and Yemen, to be almost 50% frequency, and increased very recently. This is caused by natural selection, increasing frequency up to very high. And actually, this mutation allows you to digest milk when you're an adult. If you don't, so the lactase persistence is a derived trait. Most of the population around the world, they cannot drink milk in adulthood, but there are certain populations that can, including our region. And what you can also do with these genomic studies is you can understand the history. Because every person inherits DNA from their parents, grandparents, you can reconstruct the size of a population. So what we can see here in this study is if you compare the Levant and Arabia, actually Levant around 10,000 years ago shows us huge expansion in population size, which results in more diversity. However, Arabia, around 6,000 years ago, there was a population crash, and this crash actually creates a bottleneck which reduces diversity. So the lack of, or the less diversity we find in Arabia today is not caused only by consanguinity or caused of marriages. There was a historical reason for this. This is a population bottleneck. And this bottleneck is actually associated with the desertification of Arabia. So 6,000 years ago, Arabia was not a desert, it was actually green. and environmental changes caused a population crash. So by understanding the demographic history of populations, we can better design medical studies in the future. There are still lots of remaining gaps globally that we need to fill. That was just a very brief introduction to my research, and thank you for having me.
Thank you so much, Dr. Mohammed, on this excellent presentation, and congratulations on your achievement. Now I would like to invite you to the exhibition area ribbon cutting and opening tour. And please come back thereafter to start our award ceremony. Thank you. Welcome back, ladies and gentlemen. Let's start now the appreciation awards distribution. I would like to invite Professor Humaid Al-Shamsi to the podium to hand the awards.
أول شيء الابريشيشن بعدين الحين شو الحين التوزيع الحين التوزيع
For the appreciation award, our first recipient is Dr. Moses Sharhan from Emirates, the Emirates Medical Association President. Our second recipient is Mr. Marwan Al-Mulla, Deputy Director General of Dubai Health Authority. Our third recipient is Dr. Sami Al-Khatib, the Secretary General of Arab Medical Association Against Cancer. Invite our award committee members, Dr. Falah Al-Khatib, the Emirates Oncology Society Vice President, Dr. Sayed Termazi, the Emirates Medical Oncology Society Cultural Committee Chairperson, and Dr. Hassan Ja'far. Actually, Dr. Hassan Ja'far could not be with us due to clinical commitment. So please come to the podium to hand in the rest of the awards.
So now we are going to present the EOS awards. The first award is for the EOS Patient Advocate of the Year for Her Highness Princess Rida Talal. His Highness, His Excellency Mr. Asim Abebne, to kindly come to the podium to receive the award on behalf. So next award we have is EOS Lifetime Achievement Global Oncology Award, and this award goes to Professor Sloan Peters, please. May I request Professor Peters to come to the podium, please. Professor Peter, you want to come to the podium, have a few words for us, kindly?
Oh, thanks a lot. I will have the opportunity afterwards to describe how much ESMO has also supported everything I can do. But I'd like to say, and we discussed just right before, that in oncology, what you do is supported by the colleagues, by the network you build, and by the commitment you give to your patients and your friends. And and these colleagues. So I think we will continue this collaboration with ESMO, but beyond ESMO, at a scientific level, because we all work as scientists of cancer today, tomorrow, and I'm really pleased to be here today and to continue this mission together. Thanks a lot.
So next category we have EOS Lifetime Achievement MENA Award, and this goes to Professor Ali Tahir. If I may request, I think Professor Tahir is not here, so Dr. Ibrahim will receive the award. Thank you very much. The next category is Lifetime Achievement GCC Oncology, and this goes to Dr. Khalid Al-Saleh, please. So may I request Dr. Khalid Al-Saleh to come to the podium, please. Dr. Khalid, I was hoping if you have a few words for us. Thank you very much.
بسم الله الرحمن الرحيم. يقول الله سبحانه وتعالى: إنما يخشى الله من عباده العلماء. ويقول الشاعر العربي: بالعلم نبني بيوتا لا عماد لها، والجهل يهدم بيت العز والشرف. أني سعيد جدا للمشاركة في دولة الإمارات العربية المتحدة بهذا التقدم الهائل في العلم والمعرفة، وأتوجه بالشكر إلى دولة الإمارات قيادة وحكومة وشعبا، وإلى جمعية الأورام الإماراتية بقيادة الدكتور حميد الشامسي الذي يعطي عنوانا جديدا للحماس لدى الشباب. كما أتوجه بالشكر الجزيل إلى وطني دولة الكويت التي أنشأت مؤسسة الكويت للتقدم العلمي منذ 45 عاما لتشجيع العلماء، وأتمنى الخير للجميع في ظل هذه الأوطان المعطاءة. والسلام عليكم ورحمة الله وبركاته.
Thank you very much. So the next category is the EOS Lifetime Achievement UAE Oncology Award, and this goes to Dr. Ali Abdul Razik. Dr. Ali, please.
His Excellency Dr. Awad Al-Qutbi and Professor Hamid Shamsi and the award committee for this award, distinguished award, and thank for the scientific committee and the organizing committee for such a conference, bringing stars from all over the world and UAE. And I'm sure it will be very successful. Thank you very much.
Thank you very much, Dr. Ali. So next category now we have for US Women Oncology for the MENA region. And this goes to Dr. Deborah Mukherjee. I'm not sure whether she's here today. Dr. Mukherjee, please.
thank you so much to Dr. Humaid and the EOS committee for the honour of this award. And it really goes out to all of my friends and colleagues who have contributed to furthering the goals of women in oncology in the MENA region. And I'm actually delighted to announce that I will be joining the UAE medical community very soon and joining the CMC Dubai Hospital. So I will be delighted to continue this collaboration. Thank you very much.
So next category, we have the EOS Women in Oncology UAE Award. We have two awards in this category. So first award goes to Dr. Dina Hamza.
Bismillah, alhamdulillah. Thanks to God, the greatest, Your Excellency, professors, colleagues and friends. I'm really honored with this award today. And without you, I wouldn't have been here. Thanks to all of you.
So next award for the EOS Women in Oncology goes to Dr. Dalia Shobargi, please.
It's a really exciting moment to receive this award. Thank you so much. I would like to appreciate the Emirates Oncology Society Award Committee for choosing me for this award. I would like to extend this award to all women in this room, to all my colleagues in Oncology Dubai, Department Dubai Hospital, Thank you, Dr. Humaid, for gathering all the oncology in UAE under the umbrella of Emirates Society. Thanks so much.
So next category, we have a very important category. So it's EOS Researcher of the Year Award, and this goes to Professor Humaid Al-Shamsi.
I was a little bit reluctant to receive one or maybe two awards, but Dr. Moza insisted that I should be receiving these awards, and I'm very thankful for her trust. I'm very thankful for everybody who contributed to this research. It's not only me, but it's the entire team that I'm working very well with. My colleague and my friend, Dr. Ibrahim Abu Ghaida, my research assistant, Mrs. Faryal Iqbal, and also to my wife and my kids. Been always away from them because of this research, but trust me, this is for the country, this is for our people, this is for our nation. So thank you so much for your trust, and inshallah we'll continue to work together to improve the cancer care in the UAE through research. Thank you.
If you may allow me, I would like to say one word. He's the only president of a society at the Emirates Medical Association who has always endorsed the name of the IMA and the society in all his publications. I have never seen anyone who has done something like him. So you put us in the world map. Thank you so much, Dr. Hamid.
Thank you very much, Dr. Moza, for the kind words. So next award is a Publication of the Year Award. So this goes to Dr. Muhammad Al-Mari. I believe he is still here with us. Murray, please.
I just want to thank you very much for the organizers. I'm incredibly honored for this award. And I hope this is just the beginning for more research in the region. I look forward to collaborating with many people here in this room. Thank you.
So next category, we have the EOS Industry Research Partner of the Year. And this award goes to the Merck. So we have...
Thank you very much. On behalf of Merck, would like to thank you very much for this prestigious award. And we are really looking forward to work closely hand in hand with the Emirates Oncology Society, with the Emirates Medical Association also, to leverage the level of clinical practice in the UAE and to support the patients to get the best quality they deserve for their cancer management. And hopefully it's a beginning of more and more, inshallah, progress in our collaboration with the society and with the oncology community in UAE. Thank you very much. Thank you.
So next award, we have the EOS Member of the Year. And this award goes to Dr. Aida Al-Awadi.
Thank you so much for considering me for this award. I would like to thank everyone who believed in me and support me throughout this journey. And it's such an honor to be part of this society under great and excellent leadership. Thank you.
The next award is for Social Media Advocate of the Year. And this award goes to Dr. Dima Abdul Jabbar.
First, I would like to thank EOS administration and team, Dr. Hamid Shamsi, Dr. Moza, Dr. Falah Al-Khatib, everybody who actually was part of this society. And I'm very grateful for this award. Actually, I didn't expect my Instagram to actually boom like this, alhamdulillah. And my passion is always about educating patient family, just to make them understand how advanced we are now in the UAE, and we can treat cancer here very easily compared to the idea that it's always that we have to travel outside and to get treatment. Thank you very much for the award again, and really appreciate it. Thank you.
So next award category again is very special. So this is the EOS Outstanding Oncology Nursing Award, and this award goes to Mr. Hassan Abu Nigam.
السلام عليكم يعطيكم العافية جميعا. Thank you for the organizer committee for this really distinguished award. I'm really thankful, appreciated, I'm honored for this award. I'm proud as well to be a nurse and to receive this award. It's just goes to my team and my staff for during my journey for this success, alhamdulillah. As a nurse, I believe we should look into the nursing team in all oncology and hematology, palliative care more, put more resources in order to improve the services, inshallah, with the, such committees and such institutions and associations. Thank you, everyone. Assalamu alaikum.
The next award is the EOS Hope Award, and this goes to Ms. Narmeen Ali Muhammad.
بسم الله الرحمن الرحيم. أحب أشكر دكتور حميد الشامسي بوجه الخصوص لأنه كان معي خطوة بخطوة في العلاج في كشف عن المرض، وأحب أشكر دولة الإمارات العربية المتحدة على الرعاية الطبية الرائعة. بقدم الهدية ديت لبابا وماما لأنهم أكتر ناس استحملوني الفترة اللي كنت فيها بتعالج. شكرا.
So we're almost coming to the end of the award. So we have.
I should mention Nirmeen scored 93% in her high school exams despite being on chemotherapy and radiation and all the pain with surgery, and she had a recent surgery. So that's why she was awarded this. Maybe this wasn't highlighted very clearly.
So EOS Cancer Awareness Advocate of the Year Award goes to Professor Humaid Al-Shamsi.
Thank you again for the selecting committee. Thank you, Dr. Moza, again for your trust. All these activities actually are done not because I want to do it, but because there's a must and there's a need to educate the public about cancer. I do believe the only way to reduce mortality from cancer is by increasing access to screening, making people understand that the screening is the way to reduce mortality. Trust me, diagnosing patients in advanced cancer with stage 4 and trying to come up with a medication that costs $50,000, $40,000 per month, it's not the way to go. It's simple measure that we have to do. Every one of us has to educate our families, our colleagues, our friends, making sure they understand what's cancer and why do we need to detect this cancer early. So thank you, the selection committee. Thank you again, Dr. Moza, for your trust. Assalamu alaikum.
So now we have the final category. This is the EOS Cancer Awareness Partner of the Year Award. And this goes to New Normal Same Center campaign by AstraZeneca. This is for the Business Unit Director, Peter Raouf, please.
On behalf of AstraZeneca team, I would love to thank the Emirates Oncology Society and the organizing committee for this distinguished award and recognition. New Normal Sim Cancer campaign has been rolled out globally because in AstraZeneca, we really believe that we should be working to eliminate cancer as a cause of death. And unfortunately, the pandemic has been a very big challenge for this. I think the rollout of New Normal Sim Cancer in the UAE with a perfect demonstration how industry can work with medical societies like Emirates Oncology Society to really improve the treatment outcomes. In AstraZeneca, we really remain committed to continue working together to improve the cancer treatment outcome. Once again, thank you so much for the recognition.
So with this, we conclude our award ceremony. So we'll go to the next session, Dr. Hamed Shamsi.
Who's coordinating? Who's moderating? Okay, so So now we'll resume our agenda, and we're going to move now to the next topic, which will be covering the lung cancer. Dr. Farouk Latif will be moderating the next session. Dr. Farouk Latif is our colleague and friend from Dubai Health Authority. He's a consultant medical oncologist trained in the UK, and I believe Dr. Farouk is online. Dr. Farouk, can you hear me? Welcome, Dr. Farouk, and also Dr. Antonio Passaro. We see both of you here on the screen. So just bear with us for a few minutes until we get the connection from online participation. Professor Sloan Peters' session will be after the session, so we swap the session. So the session will be after this one. I believe Dr. Farouk is unable to connect due to technical issues, so I'm going to introduce Dr. Antonio Passaro. Dr. Antonio Passaro, he's a consultant medical oncologist at the European Institute of Oncology, Milan, Italy. He's a specialist in lung cancer with focus on predictive biomarkers, target agents, and immunotherapy. He was awarded the Cerebral Foundation for the Best Young Oncologist Publication of the Year in 2012. Welcome, Dr. Passaro, and I hope you can hear me.
Pleasure for me to be here today. So did you hear me?
Yes, we can, but we cannot see your slides yet. We can see you, yes.
Yes, I share my screen. Did you see my screen now?
Not yet. It's coming all the way from Italy, so give it some time. Yes, we can see your slides.
Okay. Perfect.
And we can hear you. Go ahead, doctor. Thank you.
Thank you. Thank you for the kind invitation. It's a great pleasure for me to be here today and to discuss this very interesting topic. So the last updates for the EGFR positive disease. So here, my disclosure. So at the present time, we have three big topics regarding the EGFR positive disease for the new updates. So the treatment of acquired resistance after the first, second, third generation tyrosine kinase inhibitors for metastatic setting, the use of the EGFR tyrosine kinase inhibitor in early stagings, and of course the targeting of EGFR exon 20 insertion. So we know that we improve the survival, we achieve a significant advantage for patients with metastatic disease that show with EGFR common mutation when treated with the standard tyrosine kinase inhibitor, the first, second, or third generation, that is the standard of care for patients with the Caucasian ethnicity. But we know that despite an initial great response to this target agent, most patients develop acquired resistance for tyrosine kinase inhibitors. But one of the important things that we know that is important to start with the best treatment, because the 30% of patients that receive the tyrosine kinase inhibitors and first line treated did not receive any subsequent anti-cancer treatment. And it is very critical also to understand how to improve the management of resistance in this particular setting. And this a recent review published with the colleagues Tony Malco, we investigate the mechanism of acquiring resistance to osimertinib, that is a standard of care. And as you can see in this cartoon, it's very difficult to uniform the management of the acquired resistance in the EGFR positive setting. And we can see that is a lot of granularity data considering the on-target alteration, off-target alteration. And about 30–50% of cases have no unknown or not a clear resistance mechanism in this particular setting. And this is the why we need to identify, of course, new target, but of course, a new agnostic treatment also for patients with a known new resistance mechanism. As you know, the most studied at the present time, a new target after the treatment of a tyrosine kinase inhibitor for the blocked EGFR pathway is the identification of MET, but the identification of MET at the present time is really in a working way. We are understanding how of these three methods, the FISH, the NGS, the immunohistochemistry, is the best way to identify the MET alteration for patients progressing to EGFR positive disease. And one of the most interesting data presented 2 years ago and about confirmed that the targeting MET with a combination anti-MET and osimertinib in patients naive for EGFR positive disease or treated with a third generation tyrosine kinase inhibitor is an option. Here we can see the preliminary result of the Tattoo trials, which we can see that, of course, the use of the combination for patients that just receive a prior osimertinib is interesting with a median progression-free survival of 5.5 months. But it's interesting to underline that the same combination in patients that did not receive a prior third generation tyrosine kinase inhibitors showed a median progression of 11 months. So these data, of course, are preliminary. And at the present time, different kind of trials are ongoing using combination of anti-EGFR and anti-MET, or also other track of possibility, as you can see in this particular slide, that we've seen the pathway and the different target and the different kind of a new approach that we can use for targeting the resistant mechanism of EGFR positive disease. And as you can see, we have an on-target therapeutic strategy on target on the EGFR disease, and off-target therapeutic strategy in those cases in which we have a new mutation, new fusion amplification, also the histology transformation. One of the two most important updates of this year were the results I presented you, the ASCO, discussing the combination of amivantamab and lazertinib in patient progressing to EGFR positive tyrosine kinase inhibitor. So this combination is very interesting and use two different kind of agents. So amivantamab, that is a fully human antibody, be specific for EGFR and MET pathway, and lazertinib, that is a third generation tyrosine kinase inhibitor similar to osimertinib. So the results that were presented this year will come back from the Chrysalis 1, that is a multi-cohort trial. And this cohort, the investigators evaluated the use of the combination of amivantamab and lazertinib in patients that progressed to osimertinib, and we have 45 patients that was evaluated. So the results was quite interesting for the overall response rate, with the overall response rate of 36%, with a median progression-free survival less than 6 months of 4.9 months. And it is why? Why? Because we have a very heterogeneous granularity data about the resistant subpopulation. Indeed, we can see here in this cartoon that in those patients that show with the EGFR MET-based resistance, the median progression-free survival for 6.7 months, and we have an overall response rate of about 50%. In the other hand, in patients that we do not identify EGFR or MET-based resistance, that was more than 50% of all patients enrolled in this cohort, the median progression-free survival was short at about 4 months, with an overall response rate of 29%. But interesting findings coming up from this group of analysis of 10 patients, very small but very interesting, in which the investigators identify an high expression with immunochemistry for EGFR and MET. And in this kind of patient, we have an overall response rate of 90%, so 9 on 10%, with a median progression-free survival of more than 12 months, 12.5. So these results and this subcohort of the Chrysalis 1 confirm that the diagnostic approach, so the non-target approach, is of course interesting to improve the efficacy results for those patients without any new particular alteration. But in those patients in which we can identify a non-target alteration for EGFR or MET, is better to identify some drug that is active on this particular pathway. The second agent that was presented this year, this is a very, very interesting, is patritumab deruxtecan. Patritumab deruxtecan is a new antibody drug conjugated that is a very complex molecule with 3 blocks, and is able to track the patient that showed also HER3 expression. In this phase 1 dose finding dose escalation, the investigators identified the intermediate dose of 5.6 milligrams per kilos, and a total of about 57 patients was evaluated. Here we can see that the activity of these new drugs was the same in patients that received a prior tyrosine kinase inhibitor plus or not chemotherapy, or without, or that they received osimertinib. And we have a median progression-free survival of 8.2 months in both the groups, and disease control rate at about 70%. So these data are, in my opinion, very stunning, considering also the possibility to treat this kind of patient with an agnostic approach regardless of the new target. And this is confirmed also when we can see that the activity of particularly deruxtecan was observed regardless of the new kind of resistant mechanism and regardless of the expression of the of HER3 membranes in immunochemistry. The second big block of the new data in the last 12 months, of course, is the use of tyrosine kinase inhibitors for the EGFR inhibition in the early setting. So here we know that the surgery is the primary treatment for those patients, but we have a high recurrence or death for patients that receive a surgery and expression also EGFR positive disease. And this is confirmed by a lot of data that are published and in the literature that confirm that EGFR is, of course, a predictive biomarker when we treat our patient with tyrosine kinase inhibitors. It's a negative prognostic factor for patients that show the EGFR at the time of also the surgery. And we have a different kind of trial that evaluate the use of adjuvant tyrosine kinase, EGFR tyrosine kinase inhibitors. But all of these data, including in Asian patient, Caucasian patient, show that disease-free survival, but not always benefit. And globally, the results was not important considered the clinical practice. But why this data not results in a change in clinical practice? So, in particular, because those trials have a limited to the design and also the drugs. And there was unclear if the adjuvant EGFR tyrosine kinase inhibitor, in particular for first and second generation, results in cure or delay in recurrence. But the results was improved with the result coming up from the ADAWA trial. The trial, as you know, is a phase 3 trial that evaluated the use of osimertinib compared to placebo in patients with the resected EGFR positive disease that receive or not adjuvant chemotherapy. The use of osimertinib was for 3 years after the end of the chemotherapy. And as we can see here, the advantage in disease-free survival for patients with stage 2 and 3A was a very, very dramatic in favor of the use of osimertinib. And these data also confirm the high activity of osimertinib for delay the presence of CNS metastasis. That is one of the key learnings for the EGFR positive disease and also for the ALK positive disease. Indeed, we need to prevent the CNS recurrence to improve the outcome, to improve the overall survival and also the disease-free survival. In this view, of course, osimertinib show a great penetration. We know from the metastatic setting and the data, also from delay the presence of brain metastasis also in the early stage. And in this view, the view to improve the early stage with EGFR positive disease, at the present time, we have a different kind of trial also in neoadjuvant setting. And this neo-ADAWA is one of the most interesting. It's a very complex study with 3 arms that compare chemotherapy in neoadjuvant setting, the chemotherapy plus osimertinib, or osimertinib alone before the surgery. Of course, the results will be interesting and maybe change in practice, but we need to improve this trial design and the future to understand how to improve the survival of our patient. Because we need to remind that our intent for stage 1, stage 2, and also stage 3 is the curative intent for patients with non-small cell lung cancer. And in this way, we have to improve also the kind of management, including chemotherapy, including tyrosine kinase inhibitors, including the combination of these new agents. For the last block of my presentation, I would like to discuss with you the new data of the very interesting for the last years about the exon 20 insertion that are a new target over the exon 19 and 21 defined common mutation and the other uncommon EGFR mutation. So when we discuss with the EGFR exon 20 insertion, we're discussing about 5-7% of all EGFR mutation. And these alterations show the same phenotype of the other EGFR mutants. But currently, we know that the use of the standard tyrosine kinase inhibitor for inhibition of EGFR setting as a erlotinib, gefitinib, afatinib over the standard dose of sinesin did not show any great benefit when used in patients with the exon 20 insertion. And now we have a high number of drugs that are under evaluation for the specific inhibition of exon 20 insertion. And you can see we have an antibody, we have an exon 20 insertion direct tyrosine kinase inhibitors, and we have also osimertinib that was tested in a double dose in the previous ASCO with interesting but not quite satisfied results. And one of the two most important drugs here is a mobocertinib. Mobocertinib is a direct inhibitor, EGFR tyrosine kinase inhibitor for exon 20 insertion that show that great results when using patients with prior chemotherapy with a disease control rate on about 10%, 100%, and also for patients that receive other tyrosine kinase inhibitors with a very interesting median progression-free survival for pretreated patient of 7.3 months and a median duration of response of 11 months. So these results, in my opinion, are very interesting considering the orphan setting for this particular patient with the exon 20 insertion. In other words, we have the data about amivantamab being a monotherapy in the same setting. And here also we have a great result. So we have a median progression-free survival of 8.3 months with a confirmed overall response rate of 40%. So based on these results, amivantamab received the fast track approval from FDA, and is the first drug that received an approval for the treatment of a pretreated patient with the EGFR exon 20 insertion alteration. This year, during the ASCO, was presented by James Young these preliminary results of another direct tyrosine kinase inhibitor for inhibition exon 20 insertion, and these results are very interesting considering that some patient, this casuistic, was just pretreated with amivantamab or poziotinib, that was the drugs used in other clinical trial. And this is important because opened the door of eventual combination or a sequential antibody and tyrosine kinase inhibitor direct for the inhibition exon 20 insertion that are a very, very important target at the present time. And I think that it's important to remind that treating exon 20 insertion mutant non-small cell lung cancer is very difficult. So because we are identifying a very heterogeneous group of mutation, but we have, of course, results that are interesting for our clinical practice, and amivantamab is at the present time approved from FDA for the treatment of patients with a pretreated exon 20 insertion mutation. At the present time, we know that the other drugs are in development, but it's important to remind the chemotherapy, the platinum-based chemotherapy remain the standard of care in first-line treatment. And the results of mobocertinib or amivantamab at the present time have not a robust data to confirm this use in first-line treatment. That the different clinical trials are ongoing to confirm or not these specific results. Thank you very much for your attention, and thank you to having me here today.
Thanks a lot, and I'm very happy to be here again, and sorry for the inversion, the switch we had to do between Antonio Passaro, who I work with also at the European level, and my talk, because Antonio had to go to his clinic. We were a little late, and now he's going to see patients. And as I'm here, more on holidays, we just switched our two talks. So my talk was not lung cancer, but I will be happy to discuss lung cancer if you want later on. But my talk was initially following the award and was just questioning for the EOS, but in general, how can a society support cancer community? And for ESMO, the question is, how can ESMO support our cancer community globally? So it's a question that applies for ESMO, but I'm sure that many of the tools I will describe might apply to any society, any group, any institution which would like to potentially invest in what we told before, education, research, and so on. So this is the state of the play. Remember, we discussed it before. It's very visual, just to really keep in mind this prediction from the IARC telling you that by 2040, these 30 million new cancer cases have to be plans, right, in our portfolio. And if you think about, this is a long-term vision, as you see, right? But if you think about how these new cases will continue to increase over time, it's highly probable that after this increase by 2040, it might, for example, and that's the example of one disease, breast cancer, it might be stable for highly developed country, high-income country because of prevention and messages of prevention. It's not the case in many developing countries, and it will continue to rise again and again by the incidence growing in this low-income country with, of course, the adoption of some of our bad habitudes over time. So that's not the end of the increase. The increase will continue. Of course, I'd always like to start my talk telling that what we do is part of this very important WHO SDG. SDG is Sustainable Development Goals, and you will see under the number 3, I love this picture, always keep it in mind. Under the number 3, we have to meet and understand what this good health and well-being means, and under the little tag, you can read this sentence about the aim of getting to a universal health coverage, which means, it's a very important sentence, that all people and communities can use the promotive, preventive, curative, rehabilitative, and palliative health services they need of sufficient quality to be effective, while also ensuring that the use of these services does not expose the users to financial hardship. So that's a wonderful definition of what we have to do as a society. First of all, and it's important for me, I know that there is some, I would say, centers and regions in the Emirates, and I hope that this will happen everywhere in the world, but I'm very happy that we could implement the first recognition for integrated oncology palliative services in Abu Dhabi, in Bourjil Cancer Institute, recently, meaning yesterday. It's interesting because we know that Bourjil Cancer Institute is one of the institutions here. You have many others, and it might be a way to imagine that paving the way of the oncology services might come from supportive care and palliative care in order to respond to the needs of patients with a diagnosis and to come with them through this journey across cancer. So it's very important to imagine that in the recognition from ESMO, these designated centers, there is the idea that you have to accept referrals from everywhere and across the country, and I think it's really about working together, and it's quite important. So the ESMO designated centers are the accreditation, right, recognizes cancer centers and provide highly integrated oncology and palliative care services with the goal of improving research, education, and clinical practice by setting standards for service development. So it's really for all of us, I think it's important to go there. You can see where we are today. We are working with many, many centers around the world, from India to Hong Kong, Guatemala, Brazil, and yesterday here in your country. So I think it's quite important to continue this effort. About the organization, ESMO in a nutshell is the leading professional organization for medical oncology, the largest international organization. We are driven by a shared determination to secure the best possible outcomes for all our patients. ESMO is committed also to care for the carers, and we should never forget about who gives care, who are engaged in action against cancer in their communities. And this is the new vision that I had to develop during my presidency, which was prolonged until the end of next year. It's about changing the paradigm we had before and going around the concept of care. And we have 3 pillars. one oncology community, education for life, and accessible cancer care. And that's what I think we have to do by 2025, maybe 2030, and I will go through what we do in ESMO as an example. One oncology community. Cancer professionals grow together in a community that fosters inclusion across disciplines and geographical borders to cater to their diverse needs, because the needs are very different. And to do that, I just wanted to give you examples of the portfolio of activity you might have. First of all, we have a group of young oncologists. It's amazingly important. We have this Woman for Oncology that now is around the world. We have a Leader Generation program, and I invite you to send us your young oncologists. We'll take them in the Leaders Generation program, and we now create also something which is called the Rising Stars, which gives fellowships to these people to travel wherever they want. We have a resilience task force. It was very important during COVID. How can you cope with all these terrible stories we had in mind, and how can we support the community? The fellowship program, which is enlarging time after time. José Baselga gave us money to develop a new program, for example, and the ESMO examination that I'm sure you have all taken, but that I try to take myself every 5 years. I think the ESMO now represents what you also observe in your country. This is our community. Our community now in ESMO is more than 25,000 members in more than 160 countries, but our community is more than 40 specialties, surgery, radiation, and so on. It's half women, and interestingly, half of them are less than 40 years old. So that's the real landscape of oncologists today. What about diversity? So probably my presidency is the one which is really taking diversity as the leading principle of everything we do. It sought to be inclusive through all the forms of inclusion, right? Specialties, age, geographies, genders, and cultures. And that's also why I like to come here, is because you have doing that in the Emirates since always, right? And you might be the only country. By serving an ever-growing base of doctors everywhere, we strive for optimal cancer care. You have to find the best people where they are. Education for life. It's a strange title, right? But oncologists everywhere must be supported in their development through continuous education that helps them keep up with standards of cancer care and advances in the field. What I mean is, you don't learn when you are a student only. You also have to learn every year. Even if you work alone in your small hospital or in your small studio, you continue to learn, and you need to have some material for that. So, of course, we have our events, which is any kind of state-of-the-art preceptorship, workshop, master classes, and the congresses. But we also have a lot of learning opportunities on the web that is very important, like the Oncology Pro, which you remember when you're an ESMO member is for free. You have all the slides, all the congress, all the preceptorship, all the academies, right? And the journals, we have 3 now, the Annals of Oncology with an impact factor of 31. We have which has tripled in the last 2 years. We have the ESMO Open, which is an open access journal, really acknowledging community papers and international vision. And we have the IoTech for the technology of immunotherapy. Of course, we also have tools for you, and that's probably the most interesting chapter I find. First of all, the MCBS. And the MCBS is a political tool, or even, and also a scientific tool, which is, I will discuss it later on, measuring the benefit of anything we do. We have the clinical practice guidelines. These are the most used today globally, but I'm not satisfied with the ESMO guidelines. And before the end of my presidency, I will have them all being living guidelines like NCCN, meaning that new changes have to be adopted on a real-time manner, maybe 1 month later, but not 6 months later. But ESMO guidelines still are wonderful, but they need to be refreshed more often. COVID-19 and Cancer ESMO portal. So what we did is to create a full package of everything you need to know about COVID-19, including vaccination now. We also created a registry. So that's a place which was, it's interesting, there were more entry on the COVID-19 Cancer ESMO portal than any other entry in the ESMO website for some months, right? So it was really what we were doing at that time. And of course, we also have everything you need for your patients in every language, including English, but also lots of other languages, explaining what lung cancer is, explaining what chemotherapy is. And you can download this as PDF if you need it for your patients. So just think about MCBS. what does it mean to be clinically meaningful for a cancer medicine? So for us, we have a very easy definition. If you want to think about the minimal denominator, we have an essential list of medicines that we build with the WHO. That's one thing that has to be available everywhere. And then we have an MCBS, which in more wealthy countries can complete the list, of course, with additional drugs. And all of these are meaningful cancer drugs. What is the EML, the essential medicine list? I was speaking with a colleague from WHO. This is a list of the drugs that oncologists around the world think they have to be available wherever you are. You are in the Eastern Africa, you need these drugs to treat your cancer patients, right? And this is a list which is growing. As you can see, we have added this year nivolumab and pembrolizumab in very specific entities. You have to produce a 100-page dossier to have the list in EML. And this list of drugs is really what you have to argue from at every government. You cannot work without trastuzumab. You cannot work without irinotecan, right? That's very important. It changes every year. But why do we do that? Because we did it and we refresh it this year. We did this survey. It's in Europe, right? You take low, middle-income countries and high-income countries. This is about accessibility to gemcitabine, irinotecan, methotrexate. And as you can see, it's unfortunately green is available, red is not. Even in Europe, right? It's far from being the case, despite the list, right? It's far from being the case. And this is the global picture, right? Low, middle, upper, and high income, about really the basis of the basis, right? It's really not the case. So we have to continue to do this political move of the essential medicine list, right? And if you have this list in mind, and now a definition for the list is to have a high MCBS score, by the way, we also developed the MCBS, Magnitude of Clinical Benefit Scale. By the way, ASCO has also adopted it now, and they have let down their own scale. So Magnitude of Benefit Scale was published twice. I invite you to go through. The idea is to present clear and unbiased statements regarding the magnitude of clinical benefit from any new therapeutic approach that you might have. And interestingly, now we have gone back to all approaches. So you can even find the benefit of taxotere in breast cancer. We have scored it too, right? So you have the score. What does a score mean? A score means that the benefit can be described when you give a drug. Not only described by overall survival, progression-free survival, which looks like being normal and a standard, but also described by quality of life, toxicity, the hazard ratio, and the long-term benefits, the tail of the curve, right? But also the prognosis of the condition. So the magnitude is something more complex than just one parameter. We have two scales, one for curative, A is the best, C is the worst, and one for palliative, non-curative, 5 is the best, 1 is the worst. And with statisticians, 20 of them, we have developed the scale. And it's very important, just go through. It's a tool, an electronic tool, and you can put any drug in, and they will give you the score, okay? Last point, accessible cancer care, which is my political move. People around the world should benefit equally from reliable cancer care built on a concerted global effort to create sustainable models of prevention, diagnosis, and treatment. So what did we develop here? It's probably a little more something which is far from the daily practice. First of all, the SCAT scale, I will speak to you about it. We have started to do a new scale about actionability of targets. EGFR, KRAS, PI3 kinase, PIK3CA mutations, for example, RET, and so on and so forth. And this has been done by Fabrice André, you probably know from Gustave Roussy. GDPR is how much in Europe, I don't know about you, we have to struggle with the policy makers, and it's about privacy, right? The protection law in Europe, and we had a lot of problems with registries in COVID. How can you create registries under GDPR? The biosimilars, the patient advocates, the WHO collaboration. I have a full-time collaborator in WHO all the time in Geneva, and we created something we have to connect to, Rare Cancer Europe and Rare Cancer Asia, where we develop lots of projects, okay? I just wanted to drive you through the story of, I like the SCAT scale, because what we do in oncology now is what we called in the past personalized oncology. It's changed to precision oncology for political reasons, but precision oncology is really about having the hypothesis of a biomarker, trying to find a way to measure the biomarker and transfer a clinical qualification of a treatment which would be precision targeted, right? And when you do that, you can go back to the old days publication from Vogelstein and colleague, who went through all these oncogenes and tumor suppressor genes, right? I remember in Vogelstein, he said at the end, we believe that the plateau is being reached. We have captured the low-hanging fruits, right? Because the same driver genes keep being rediscovered in different tumor types. And I think it's true. So we have this list of oncogenes and tumor suppressor genes. And now the question is how much you can action them. You can find targeted therapy. So here comes the SCAT. So the SCAT comes from 1 to 5. 1 is the best, and 1 means the alteration drug match is proven, and you have an association with a proven outcome, EGFR and EGFR TKI, for example. And so you have all the scale, and 5 is you have a lack of evidence for actionability, so some things that you cannot target, and we know many of them, of course, and unfortunately. And the aim of this SCAT is to be able to harmonize our terminology. What is precision oncology? What is the interpretation of clinical trial data? Categorize the level of evidence, and very importantly, to facilitate discussions at what we call the molecular tumor boards. This is an alteration, but this is not actionable. And you know because you have the SCAT scale. To adjust patient expectations, do not give wrong and false hopes to patients, and to assist clinicians and patients to prioritize precision oncology in the field. So just go through that. We will also in our guidelines have MCBS, have level of evidence, and we'll have SCAT scale to be quoted, right? Last but not least, I have created this year the ICF, the International Cancer Foundation, which is about reaching beyond the scope of ESMO usually, going across the world in the poorest country and help patients and doctors to travel up and forth to whichever country. And I have millions already in this foundation to help to support oncology everywhere. This foundation will also take from ESMO all the prevention. I decided that prevention had to be taken care of in the prevention, and we work with IARC to develop all the prevention program in the ICF Foundation. Last but not least, I was discussing yesterday about biosimilars because it's something which is stringently important in your region. We have been developing a lot of material for patients, but also political papers. In Europe, you see in oncology, we now have 13 biosimilars approved. FDA has a little less, but it's growing every year, and that's a way to minimize the cost of what we do. So to conclude this talk, how can an organization help supporting the community oncology? It's by everything we have been telling, but I would like to think a bit beyond ESMO, us, and the community, because when you improve the health of anyone, you do not only help for health, but you change the whole society. And we always have to keep it in mind. This is a scheme from WHO, how much saving a life, making people become healthier, is making a gain in the whole community, increasing the workforce participation, and basically at the end, boosting the GDP. And this is about, you know, again, the SDGs. When you have good health, you escape from poverty, you have an economic growth, you can have a responsible way to behave in the society and reduce inequalities. So I think it's also part of our job. And with this, I thank you for a nice attention.
Assalamu alaikum. It's my pleasure to be here with you today for the Lilly symposium about the RET-driven non-small cell lung cancer mutation. This presentation will be given by Dr. Edurne Ariola from Spain. She is the lead for the lung cancer unit at Hospital del Mar, Barcelona since 2017. She's a PhD oncology since 2008. She's also coordinated more than 50 trials between phase 1, 2, and 3 in lung cancer. She also directs a laboratory within the molecular cancer therapeutics group in lung cancer. The presentation will be about the first precision treatment specifically for patients with certain RET-driven mutation for non-small cell lung cancer. We have been seeing so many presentation and so many new drugs. It's really a very exciting era of precision medicine since the introduction of gefitinib in 2009 as compared to standard treatment by Tony Mock in 2009. So from one drug, we are now with a multitude of drugs, and we are seeing more and more drug in the field. Hopefully it will be, the problem is more the accessibility to these drugs than the use of them. So the floor is for you, Dr. Idun. You can start now. And we'll take questions after the presentation. Please.
Thank you very much. I'm delighted to be here, and I would like to thank the organizers for inviting me to this talk. I'm going to talk about Retevmo. Retevmo is the first precision oncology treatment for RET-driven non-small cell lung cancer and others, but I will only talk about the non-small cell lung cancer today. Okay, next, please. So these are my disclosures. Next. So the outline of my presentation, I will briefly talk about the genomic alterations we can find in the RET gene. Then we will talk about the complexity of the molecular testing in the non-small cell lung cancer setting and what the guidelines actually recommend these days. We will review the efficacy and safety of selpercatinib, Retevmo, in the Libretto 001 trial, and then I will explain to you one of our clinical cases in my institution. Next, please. So you can go to the next. So in the RET gene, we have different mechanisms of oncogenic activation. We will focus today in the RET fusions, which are the one that affect non-small cell lung cancer patients. Around 1 to 2% is the frequency we can find these alterations. RET fusions are also found more frequently in the papillary thyroid cancers and very infrequently in other cancers, as you can see here in the list. Apart from the fusions, we can find also mutations in RET. These are typical or are also oncogenic, but are typical for medullary thyroid cancer that we won't review today. So next. Next. Yeah, thank you. So the normal RET signaling, RET is a transmembrane receptor that dimerizes and can develop his downstream pathway. When it's fused, the usual partner, the most frequent one, as we'll see later, is KIP5B. And this chimeric protein also dimerizes and has a constitutive signaling, and that's what's going to lead to the uncontrolled growth and survival of the cancer cells. Next, please. So we know the molecular diagnosis in non-small cell lung cancer is now essential for providing the better treatment, the best treatment to our patients, especially and particularly in non-squamous patients. But here we can see the NCCN guidelines and also the ESMO guidelines. They all have in common the essential message of we need to diagnose our advanced patients for EGFR, ALK, ROS1, and BRAF. But the NCCN guidelines and also the recommendations from ESMO are to, if possible, perform a broad molecular testing encompassing all the genes that are actually targetable. Depending obviously on the indication in specific countries, we will have access to the drug or not, but at least we could orient these patients to clinical trials as well. All those genes, of course, in parallel to PD-L1 testing. Next, please. So fortunately, in your country, you have the indication now for Retevmo, and the indication in non-small cell lung cancer is for adult patients with metastatic RET fusion positive non-small cell lung cancer. From the practical point of view, Retevmo is a very convenient drug. It's orally provided, and the dose that is recommended is 160 milligrams twice daily, and it can be taken without any dietary restrictions. Next, please. So regarding the diagnosis, as I said, this, the genes we need, there's therapy for, need to be diagnosed, and the recommendations are to perform this broad molecular testing. The technology we're using more and more these days is next generation sequencing with panels that actually encompass all these genes, including the mutations and also the fusions that are relevant for patient care. And next, please. It's important to know that NGS is providing these results, but we can also have them if NGS is not available with FISH and also with PCR when we know only for specific already known fusions. One interesting point about NGS is that there are some technologies that are DNA based only, and this can sometimes miss RNA based alterations such as fusions, for example, and some guidelines recommend to actually use RNA based NGS for detecting fusions that are probably a better way to detect this. But the important message here is you have to know what platform it's being used, and you have to talk to your biologist and just know if RED is well covered with the technology you are actually using. This is easily performed in paraffin embedded tissue, which is our usual biopsies. And interestingly, in cases where tumor tissue is not sufficient, that happens quite a lot in non-small cell lung cancer, we can actually assess MET also in liquid biopsy. And I'll show you an example of that later. Next, please. So, what is Retevmo? What's selpercatinib? It's a tyrosine kinase inhibitor, and its main strength is that it is highly selective and potent against red and wild type, and also mutant forms. And here we can see in the diagram on the right side of the screen how it's this high specificity is probably giving this well tolerated drug compared to multi-kinase inhibitors that are much more toxic through these different mechanisms of inhibition. So it's highly potent and highly selective. Next, please. And when we have this oncogenic red, selpercatinib, Retevmo is able to arrest this downstream signaling and actually lead to cancer cell death through apoptosis. Next, please. So now we're going to review the Libretto 001. The Libretto 001 is the first study that evaluated Retevmo in non-small cell lung cancer patients. As you can see here in this study, there was a phase 1 dose escalation part, and then a phase 2 with dose expansion part with the dose that we talked about, 160 milligrams twice daily. As you can see in this study, also other red-altered tumors were included, including thyroid tumors and others with red alterations, but I will review only the data about a non-small cell lung cancer regarding efficacy. We have here 105 patients that were previously treated with a platinum doublet, and then there's a small proportion of patients, 39, that were treatment naive. The primary endpoint of this study was overall response rate according to RECIST 1.1, and secondary endpoints were duration of response, progression-free survival, and safety. Next, please. So here we can see, the fusion partners for RET. As I said before, KIF5E was the most frequent one, for both treatment naive and previously treated populations, and the second the most frequent partner is CCDC6. Regarding the characteristics of the population of the study, we can see here that there was a slight majority of females. The median age of the population was 61 years old. Majority of patients were white, non-smokers, never smokers, and with a good performance status. In the previously treated patients, we can see that the median number of previous systemic regimes was 3, which is quite heavily pretreated patients. And as you can see, 100% of these patients had received platinum-based chemotherapy, but also more than a half had received immunotherapy, and 48% had received a multikinase inhibitor previously, so quite heavily pretreated patients. Interestingly, in the previously treated population, the incidence of brain metastasis was 36% compared to the treatment-naive patients, which were 18%. Next, please. So here are the efficacy data. The primary endpoint, as I said, was overall response rate, and here we can see very impressive figures for the treatment-naive population, 85% of overall response rate with 95% of disease control rate, with a median duration of response that hadn't been reached at the moment. In the previously treated population, we can see also high responses, 64% overall response rate, and up to 92% disease control rate, with a median duration of response of 17.5 months. Next, please. So here we can see this graphically. Just bear in mind, this is the treatment-naive population. Again, 85% of responses, all of them partial responses, but here we can see it's not only high rate of response, but also very deep responses, which we know that has a clinical impact in the symptoms of the patients. Next, please. And here we can see the duration of response that was not reached, but interestingly, the median PFS wasn't reached either, but we have the 1-year PFS rate, which is 75%. This means 75% of the patients hadn't progressed at the 1-year point. So very, very interesting figures for the treatment-naive population. Next, please. Here we can see the 105 patients that had been previously treated. And here again, 64% responses with 2 complete responses. And then here we can see again the depth of this response for the majority of patients here. And we can see these little points that show the patient that had received previously multi-targeted kinase inhibitor. So really, really good results. Next, please. Here we can see the duration of response, 17.5 months, and also the progression-free survival curve with a median PFS of 16.5. Again, in this pretreated population, there was 66% of the patients hadn't progressed at the 1-year hallmark. Next, please. We know that brain metastases are a really challenging situations for patients and for physicians. And here we had some data about patients with brain metastases. There were 11 patients with measurable lesions in the previously treated population. Next, please. And here we can see the very impressive response rates, 91% for these small numbers, but still very interesting, with 3 partial complete responses, and 7 partial responses. Again, we can see in the waterfall plot the depth of these responses, which clearly has an impact in the symptomatology of our patients with brain metastases. Next, please. And here finally we have this swimmer plot where we can see the duration of response. Again, 58% of the patients that had responded had an ongoing response at a median duration of almost 15 months. Next, please. So we have reviewed the efficacy, showing very, very interesting figures and very high efficacy for Retevmo. Here we can see the safety. This is the data of all evaluable patients for safety, 702. As we can see, Retevmo was in general very well tolerated. All the toxicities, the GI toxicities, the general fatigue, skin rash, etc., were mainly grade 1 or 2, mainly grade 1, as you can see here in the graphs, and only 5% of patients had to discontinue Retevmo due to adverse events. Next, please. Regarding laboratory abnormalities, again, we can see increased hepatic enzymes and other alterations, but usually these were grade 1 and could be managed with dose reductions if necessary. Next. So now I will explain you one of our cases in our hospital. This was a 57-year-old woman at diagnosis. She didn't have any relevant comorbidities, but she was a heavy smoker and she had an index of 40 per year, and she was currently smoking when we diagnosed her. Just for the sake of time, she was diagnosed in 2018 with an adenocarcinoma of the lung that was metastatic to the brain and to the bone. Actually, the first symptom was a seizure that brought her to the emergency room and was what led to the lung cancer diagnosis. Next, please. So we performed a biopsy and molecular studies. At that point in our institution, we were starting with the NGS. So we'll see here, she had a PD-L1 of 90%, as showed in the picture. And we did single gene testing because as she was a woman and she was quite young, we thought she might have some of the expected alteration in this population, but EGFR, ALK, and ROS1 were negative by single gene testing, and then we were studying MET at that point, and it was also negative for MET amplification. We were testing a plasma NGS platform, so we had the opportunity to send samples from this patient at diagnosis for testing in the NGS in the plasma. And as we had these molecular results and the PD-L1 was high, we decided to give her whole brain radiotherapy, and well, while she was going, when she was doing the whole brain radiotherapy, we have questions now. I think you have to use this QR code. The question is basically, what would you do next? She's ongoing. She's doing her whole brain radiotherapy. She is still on treatment with steroids, and she has a PD-L1 of 90%. Current smoker, heavy smoker. We didn't think she would have any other alteration, so okay. So it's 100%. All agreed. Okay, no, it's coming up. Okay. Okay, maybe, I think we can maybe discuss it also later, but okay, still going. I'll wait a bit longer. Okay, so it's interesting. This is changing all the time. I think we can discuss a little bit. So there's options of starting pembrolizumab, as she has this high PD-L1 and no molecular alterations that we know of. Wait for the NGS in the plasma. That is going to, you have to wait at least a couple of weeks generally, at least in our setting, before starting systemic therapy to evaluate the rest of the genes that are recommended, or request NGS in the tumor if tissue is available. So I think actually all of them are right. If we go on to the next one, or there's no wrong answer, I think. Well, that's the question again, so we can go to the next one. She actually was started on pembrolizumab because we thought she wouldn't have anything else in molecularly speaking, and after one cycle she developed a very infrequent side effect but very, very severe, which was a Guillain-Barré syndrome with ascending peripheral neuropathy, and she had to be admitted in the hospital for treatment with steroids and immunoglobulins, and this was a quite severe clinical scenario. So we obviously stopped or withhold the treatment with pembrolizumab at that point and started this symptomatic treatment. Next, please. But as I told you, we had sent, even from diagnosis, plasma to the lab, and actually we had already 2 negative tests where they were negative because there was no detectable ctDNA. So while she was admitted, we sent another one trying to maximize the molecular diagnostic, and we submitted this to the OncoMyLab cell-free total nucleic acid assay. As you can see here in the table, it contains the red gene. Next. And the results came out, and she had a surprisingly, well, not surprisingly, the p53 mutation, which is very frequent, but then she had unexpectedly a red fusion with K5E, which is, as I said, the most frequent partner. Next, please. So now we have this new information, which is, I think, very relevant, and I think we will agree on that. So what would you do next? Initiate treatment with Retepmo now that it's available for you. Then repeat the red assessment in the tissue because by FISH or NGS because liquid biopsy results are not well validated, or we challenge the patient with pembrolizumab as the PD-1 was high. So I think here we will wait a little bit for the results. Okay, this is interesting. So the majority of physicians would start with Retepmo. I think, and there's some discussion on the testing, which is interesting. We had this same sensation of maybe, liquid biopsy. We were very early on testing these NGS platforms by NGS in liquid biopsy. So next, please. We perform a FISH in the tissue, in the paraffin embedded tissue, to just learn and be sure that this finding in the plasma was real. And actually, this is a FISH assay that you can see the break apart signal in the cells, confirming the red translocation. She recovered up to a grade 1 neuropathy, so she was amenable for continuing treatment, luckily, and we had the opportunity to include her in the Libretto 001. So she started receiving Retepmo. Next, please. And here I can show you just how deep and quick the response she had after 4 cycles. Here you can see the CT scan pre-treatment and then the CT scan for post-cycle 4. She actually received the dose of 120 milligrams twice daily, so slightly lower than what is actually the indication now. But she also had a very prolonged response with a duration of response of 2 years with excellent quality of life. Next, please. So just to finalize, Retepmo, I think I've shown you that it's a highly effective treatment for patients with apparent red fusions, non-small cell lung cancer. It is well tolerated, and the adverse events can usually be managed with dose reductions if necessary. But I think it's very important to find these patients because they are not that frequent, and comprehensive genomic evaluation is essential for identifying patients for this highly efficacious treatment. And next, thank you very much for your attention, and I'll be happy to take any questions.
Thank you, Dr. Ariola, for the comprehensive presentation and the really interesting case. We know that we are a little bit late on schedule, so maybe for 1 or 2 questions, if there is from the audience, if there is any burning question.
Oh, I thought you raised your hand. Yes, sir.
Can you hear me? Okay. So thank you, a very comprehensive lecture. So your advice is to do tissue NGS, or is there a difference since the shedding of cells sometimes is not very good in the blood? Is it routine that you request tissue-based testing?
So yeah, that's a very interesting question. Now, that was 2018, and we've learned a lot about NGS since then, and particularly about liquid biopsy. I think it's very important to know what technology you are using, particularly for fusions and the subject of the DNA-based only or RNA-based technology. we started doing all these NGS in plasma and tissue in parallel just to confirm our cases, to be sure that they were concordant results. And we were quite lucky to find 3 cases with red alterations, in particular in plasma. And we all, they were all validated in the tissue. So I think the lab you're working with needs to know the expertise. If it's in-house, you can directly talk to your colleagues, or if you send it to a platform, external platform, you have to make sure the technology covers well the red gene. But I think it's reliable, and we're seeing more and more examples of patients responding, and actually the trials that are currently ongoing accept the liquid biopsy results as valid for treatment. So I think from these trials we will have the prospective information, but I think we can rely on plasma samples if the technology is well established in the lab you're using. But obviously, still probably tissue NGS is a standard, let's say.
And I guess as a follow-up, DNA versus RNA, you mentioned sometimes DNA missing those fusions. Do you have any percentage, what percent that you can find on RNA versus DNA?
In particular, we have also always used DNA and RNA-based platform, so we haven't had this problem, and I don't know, and I'm also aware that all DNA platforms are not the same either, and they have different coverage of the red gene. So I think it's very important to have this conversation with the biologist that is interpreting these results, because we haven't had problems with red, for example, but we have had problems with MET and the exon skipping, which has a little bit the same problem with the DNA-based technology. So I think it's just to know very well the platform you're using.
And then I guess clinical question, we know there is another drug, pralsetinib, on the market as well. Any quick comment on tolerability versus efficacy difference with Retevmo?
Yeah, I think they are all, both of them, they are very good drugs. My impression from the data is that maybe selpercatinib, so Retevmo, is slightly better tolerated. I think that's probably the main difference. But I don't, clinically, I don't have that much experience to give you my personal sensation, let's say, just for the data, from the data.
Thank you.
Thank you.
Okay, so because of time constraint, thank you, Dr. Ariola. Thank you for the audience. And now it's time for the lunch break. Thank you, everyone, for assisting. Thank you.
يلا يا باشا. لازم تطلع. لا دم. دكتور معاذ, is Dr. Muad online? Dr. Abatul is the only one who's attending now. Dedication. لا زعلان منك خلاص. مشكلة إن شاء الله. جايات إن شاء الله. Is Dr. Muad online? Okay, can you please? Okay, so we're gonna resume our activities, even though nobody is here physically, but many people are online. So we'll try to stick with the schedule. We are 15 minutes late. So I would like to welcome Dr. Muad Al-Nasser, Consultant Medical Oncologist, Head of Thoracic and Sarcoma Unit, Kuwait Cancer Control Center. Thank you, Dr. Muad, for joining us. And sorry. And this event is sponsored by MSD Oncology under the title Long-Term Outcome with Checkpoint Inhibitors in Non-Small Cell Lung Cancer. Welcome, Dr. Muad, and the mic is yours. Doctor, you are live online. Dr. Muad, can you hear me?
Yes, sure,
yeah.
Doctor.
Yeah. Alhamdulillah, welcome, and we introduced you already, so you can go ahead with your presentation.
Inshallah.
We can see your screen.
Yes, thank you. First of all, I want to thank the organizer. My focus today is about the long-term outcomes with the checkpoints inhibitor non-small cell lung cancer. The first report, we have 5 years overall survival update from the Keynote 24. It was presented by Braham and his colleagues in ISMO 2020. And those, especially for the highly enriched population with PD-L1 expression more than 50%. So this is the first graph for the progression-free survival. We can see at this Kaplan-Meier curve, there is superiority of the immunotherapy over the standard chemotherapy, 22% versus 4%, and the median progression-free survival 7.7 versus 5.5. And this is the main overall survival Kaplan-Meier curve at landmark of 60 months. There is 31% are still alive versus 16% in the standard chemo. Almost there is doubling of the percentage of patients. Also, the median is also exactly, there is a doubling of the benefit. There is 26 versus 13.4 months in favor of the immunotherapy arm. And the hazard ratio is quite deep, 0.62. With regards to the objective response, clearly there is superiority of the immunotherapy, pembrolizumab, 71% versus 47%, and the median duration of response is 29 versus 6.3. Also, with this reports, there is about 39 patients who completed 2 years of immunotherapy, pembrolizumab, about 35 cycles, and 80% or 82% they still experience a response. 72% they are still maintaining partial response, and 10% they are having complete response. And at the data cutoff point, about 46 patients are alive without progression or using subsequent therapy. And one patient just developed secondary malignancy and was treated accordingly. This is another report was published in 2017 about the PFS2 for the same population for those with PD-L1 more than 50% in the keynote 24. And what's the definition of the PFS2 is from the time of the randomization till the progression of the next line or death. With this graph, we can see that there is a superiority of the usage of immunotherapy. Pembrolizumab, there is 21 months versus 8.5 months in favor of the pembrolizumab. So in summary, a patient who completed 2 years of pembrolizumab experienced long-term overall survival benefit, which confirming the initial results of the keynote 001, and this keynote 24 is the first phase 3 study to demonstrate the 5-year efficacy for the first-line pembrolizumab in those with highly enriched PD-L1 expression, more than 50% TPS score. I'm presenting another group of studies, especially the Empower 110 for the atezolizumab versus the standard platinum chemotherapy for selected PD-L1 population. The study design is exactly the same for keynote 24, but the things which is different is that in this study the crossover was not permitted and it was allowed in the keynote 24. And the patient were randomized one-to-one fashion to receive atezolizumab 1,200 milligram, and the treatment was allowed till progression or lose of the clinical benefit, and the primary endpoint is overall survival, and they subdivide the OS analysis into 3 groups or subgroups: those with high PD-L1 expression, and those with high and intermediate expression, and those with any PD-L1 expression for the wild-type non-small cell lung cancer. And there are 2 cutoff points in this analysis. The first cutoff point on the 10th of September 2018, and the second cutoff point on the 4th of February 2020, and what we can see from the primary analysis that the hazard ratio is 0.59 and the median OS is 20.2 and the versus 13.1 for the chemotherapy. And the updated analysis, we can see that the hazard ratio is 0.76 and the CS or confidential interval is crossing 1 in this analysis. But still the OS is 20 and the median OS is 14.7, which almost matching the same difference. This is another report from the Keynote 189, and in this study, what they use pembrolizumab plus doublet platinum, either cisplatin or carboplatin with pemetrexed, and they recruit those with non-small cell lung cancer adenocarcinomas, provided that they have no driver mutation, no EGFR or ALK alteration, and they have good performance status. All the PD-L1 subgroup were allowed, and also there will be no active CNS metastasis. The randomization is 2-to-1 fashion. The first group, they receive pembrolizumab 200 milligram plus pemetrexed plus either carboplatin or cisplatin, and the comparator is the standard chemotherapy, which is the pemetrexed with either carboplatin or cisplatin, and the patient will receive the immunotherapy plus chemotherapy for 4 induction cycles, followed by maintenance pembrolizumab and pemetrexed for almost 2 years or 31 cycles. And those who finish the treatment and they have they have a progression, they were allowed to receive immunotherapy, and also the crossover were allowed for those who progressed on the standard chemotherapy to receive single agent pembrolizumab. The primary endpoint is progression-free survival and overall survival. The secondary endpoint is the safety, ORR, and duration of response. This is the 4-year follow-up OS results for the Keynote 189, and what we can see, there is superiority of the combination chemoimmunotherapy at the 3-6-month rate. The 31 patients are still alive versus 17.4 for the chemotherapy, and the hazard ratio is 0.6, and the median OS is 22 versus 10, so almost there is doubling of the benefit in favor of the combination chemoimmunotherapy. And this is for the PD-L1 expression, more than 50% population, and we can see that the OS is 27 versus 10, and the hazard ratio is 0.71. And those with PD-L1 from 1 to 49, also they maintain the same or almost the same benefit with clear separation between both groups, and the hazard ratio is quite deep, 0.66, and the median OS is 22 versus 12 months. Even those with PD-L1 expression less than 1 or negative, they are still maintaining a benefit and a clear separation between both groups. The hazard ratio is 0.52 with 7 months difference between both arms. And this is the most updated analysis with any PD-L1 expression, any positive PD-L1 expression, and the hazard ratio for this population is 0.6, and there is more than doubling of the OS benefit, 23 versus 11.3 months, in favor of the combination chemoimmunotherapy. This is another updated follow-up report from the Keynote 407 for the squamous group of non-small cell lung cancer, and this updated report, which was published in the ALCC on 2021, on the 36 month landmark, there is 29.7 are still alive versus 18.2 of the chemotherapy, and the median OS is 17.2 versus 11.6. Also, there is the superiority of the chemoimmunotherapy in the squamous group, and the progression-free survival are also in favor of the combination, 16.1 versus 6.5. And this is the progression PFS2. Also, there is superiority of the chemoimmunotherapy. The median PFS is 13, PFS2 13.8 versus 9.1. This is the final section of my talk, and this is for this updated analysis 2 years report from the Checkmate 9LA. And the study design of this trial, they recruit those with stage 4. All histologies were allowed, squamous and non-squamous. Also, any PD-L1 expression were included, provided that they have no prior systemic therapy. Sorry. No systemic therapy or naive patient. They were randomized to receive combination chemoimmunotherapy with two immunotherapeutic agent, nivolumab and ipilimumab, plus the standard chemotherapy. Pemetrexed is based for the adenocarcinomas and gemcitabine based for the squamous carcinoma versus the standard chemotherapy for 4 cycles. And the treatment were continued until disease progression or an accepted toxicity. The primary endpoint is overall survival. This is the OS Kaplan-Meier curve for Keynote 9LA, and at 2 years landmark, there is our 38% versus 26%, and the chemotherapy are still alive, and the hazard ratio is 0.72 in favor of the combination chemoimmunotherapy. And this is the last version of the non-small cell lung cancer guidelines in NCCN. And what we can see that the preferred option for those with positive PD-L1 expression more than 50% is pembrolizumab for the squamous and non-squamous. Plus, the other options are also included. The atezolizumab protocols and also nivolumab plus ipilimumab in both squamous and non-squamous subpopulation of non-small cell lung cancer. With that, I finish my talk, and I will give the mic back to Dr. Humaid to direct the questions.
Thank you so much, Dr. Muad, for this very insightful talk. Due to the delay, 15 minutes around the lunchtime, we're just going to move forward now to the next session. So thank you, Dr. Muad, and we'll move now to the next session.
Thank you, Dr. Humaid. Thanks a lot.
Thank you, Doctor. Our next session is moderated by Dr. Al Khair Abul Khair, who is an adult medical oncology consultant at King Abdulaziz Medical City at the University of Health Sciences, Saudi Arabia. She was appointed the chair of the breast cancer research at the King Abdullah International Medical Research Center in Riyadh, and being one of the renowned oncologists in the Middle East. And she was nominated to be part of the Women High Places Fight Against Cancer. Thank you, Dr. Al Khair Abul Khair, for joining us, and the mic is yours.
Hello, thank you, Dr. Humaid, for this nice introduction, and I would like to congratulate you for this meeting for the second year, and thank you for the invitation. With no further ado, I would like to present, it's my honor to present Dr. Ghossebi, Dr. Gosubi, he is a professor of clinical oncology, a professor of medical oncology, and head of the Division of Early Drug Development at European Institute of Oncology, IRCC, Italy. Also, he has several publications, more than approaching 400 publication, peer review publication. As well, he was awarded with the first ESO Ambro Fernizio Award in Vienna in 2017. He will present to us metastatic breast cancer immunotherapy and triple negative breast cancer. The floor is yours, Dr. Gosubi. Thank you.
Thank you very much for your kind introduction. It's really my pleasure to be with you today. And I will discuss in the next 15-20 minutes about use of immunotherapy in triple negative breast cancer. So those are my disclosures, and this is the outline of my presentation. So first, of course, I will try to present the overview of what is a triple negative breast cancer. I will just mention the role of PARP inhibitors, and finally the role of immunotherapy and antibody drug conjugated. As you can agree with me, triple negative breast cancer is an heterogeneous disease with the range of disease from good prognosis, like metaplastic low-grade, to poor prognosis, like invasive ductal carcinoma high-grade. And in the treatment algorithm of this disease, of course, we have the opportunity to identify different subtypes of tumors. We will have the PD-L1 positive, for which the optimal combination should be a chemotherapy plus an immunocheckpoint inhibitor, and then we will provide an overview of data with atezolizumab and pembrolizumab. And then we have the BRCA mutant, for which the standard of care should be a PARP inhibitor. So if we look also at molecular subtype, we can identify BASA-like, immunomodulatory, mesenchymal-like, and luminal androgen receptor-like. In the BASA-like subtype, the most common is the BRCA mutant, and we have two settings of data. The first setting from the Olympia D that explored the activity of olaparib in BRCA mutant breast cancers, germinal mutant, respect to standard of care, and for which there is an improved progression-free survival and an improved response rate. And then we have setting of data from the EMBRACA trial that compared talazoparib to treatment of choice, for which also here you have an improvement of progression-free survival and no improvement in overall survival. Another open question is whether we can use or not carboplatin in germinal BRCA mutant. Here we have the data of the prospective randomized trial comparing docetaxel to carboplatin, where there was no difference when you compare non-BRCA mutant, but a huge difference when you compare the BRCA mutant. We can concentrate now on the subgroup of patients that I will define immunomodulatory or PD-L1 positive. The first study to be published in this setting is the inpatient 130 prospective randomized trial designed for patients that were PD-L1 positive on the tumor, and the study randomized to atezolizumab nab-paclitaxel versus placebo nab-paclitaxel, considering stratification factors, prior taxane use, liver mets, and PD-L1 status. If we look at the characteristics of the patients, 41% were PD-L1 positive, the majority of them with 0.3 number of metastatic site of disease or more than 4. The most common site of metastatic disease were lung, bone, liver, and also brain in 7% of the patients. Looking at the response rate, there was an improvement in terms of response rate, if not statistically significant, in the atezolizumab nab-paclitaxel arm versus paclitaxel placebo. If we look at the progression-free survival in the primary analysis, since this was the co-primary endpoint, we have a statistically significant improvement of PFS from 5 months to 7.5 months. What's about overall survival? This is the most important endpoint of the study. With a longer follow-up of 20 months, we have a statistically significant improvement of overall survival in the PD-L1 positive population from 17 months to 25 months. It's not transformative for all the patients, but it's clearly transformative for a subgroup of patients that is the 36% of the overall population in the PD-L1 positive disease. If you remember, in the context of the inpatient 130, a PD-L1 was assessed on the platform SP142 that determined PD-L1 on the immunocells. What's about the other setting of data? We have the Keynote 355, a different patient population here. In the Keynote 355, the treatment-free interval was 6 months. In the inpatient 130 was 12 months. Also here, selection according to PD-L1 positivity, assessed on the CPS score, that is a different score respect to SP142. Patients have been randomized to chemotherapy plus pembro versus placebo chemotherapy, and the type of chemotherapy is different here. We have nab-paclitaxel, carbogen. According to the primary analysis of progression-free survival, the addition of pembrolizumab to chemotherapy statistically significantly improved in the PD-L1 positive population the progression-free survival from 5.6 to 9.7 months. Also in the PD-L1 positive more than 1. In the intent to treat population, we have similar data. We don't have data on overall survival that I remember will be presented next week during the ESMO meeting. So next week we'll have data on overall survival in this trial. In terms of treatment-related adverse events, there are no new safety signals in the metastatic setting. Of course, the most common immunomediated adverse events are the ones that we know already for immunocheckpoint inhibitors. So now we have 2 agents approved by FDA. One is atezolizumab plus nab-paclitaxel that was designated as accelerated approval, and as you know, Roche last week decided to withdraw the final application for final approval. And then we have pembrolizumab plus chemotherapy in combination with nab-paclitaxel, paclitaxel, and carbogen. We don't have no role for paclitaxel plus atezolizumab because we have a clinical study, if you remember, that demonstrated no progression-free survival benefit. Another treatment landscape for the future, I would like to mention this because I really believe that in the future we will have much more studies combining antibody-drug conjugated plus immunocheckpoint inhibitors. One of these antibody-drug conjugated is sacituzumab govitecan, that is an antibody drug against TROP2, an antigen overexpressed in several tumor types of cancer, conjugated with SN38, that is a more potent parent compound with respect to irinotecan. The study was a prospective randomized trial comparing sacituzumab govitecan to treatment of physician choice. The primary endpoint was progression-free survival. Secondary endpoint PFS for the full population and overall survival. If you remember, patients have been randomized half to sacituzumab govitecan, half to investigator treatment choice, including eribulin, capecitabine, gemcitabine, and vinorelbine. If you look at here and the characteristics of the patients, the median age was 54 years old. 7% of the patients were BRCA germinal mutant. Many of them received the previous immunocheckpoint inhibitors, 29%, and the previous PARP inhibitors in 7% of the patients. The use of sacituzumab govitecan improved progression-free survival from 1.7 months to 5.6 months in a population of patients that received the median of 7 lines of previous chemotherapy. And looking at the data and the benefit of progression-free survival by subgroup, there is no subgroup who did not have benefit, independently of age, older versus younger, race, prior therapy, more than 3, less than 3, region, use of previous immunocheckpoint inhibitors, and eventually presence or not of liver mets. But the most impressive data were related to overall survival benefit because the use of sacituzumab govitecan improved overall survival from 6.7 months to 12 months. Also, in terms of response rate, we have an increase of response rate from 5% with treatment of physician choice to 35%. What's about safety of sacituzumab govitecan? Hematological toxicity was the most common toxicity, and diarrhea, grade 3 for 46% for neutropenia, 10% for diarrhea. So in conclusion, we have a new, of course, potential agent to be used for triple-negative breast cancer patients. That was sacituzumab govitecan, that improved progression-free survival and overall survival. If you look at the data presented at San Antonio, according to TROP2 expression, does not seem we have a difference, a close TROP2 positive versus TROP2 negative. Do we have other immunocheckpoint inhibitors or other antibody-drug conjugated? Yes, for sure. We have ladiratuzumab vedotin, that is an entirely one. With this agent, we have a confirmed response rate of 25% in patients heavily pretreated. But we have also other agents against HER3, for example, like U3-1402. And don't forget that HER2 low can be also defined as patients that actually are triple negative. So we have also the potential activity of trastuzumab deruxtecan. Don't forget that the major opportunity of antibody drug conjugated or smart chemotherapy, it's really the opportunity to combine them with immunocheckpoint inhibitors. Here, you can see the data of ladiratuzumab vedotin and pembrolizumab, really impressive response rate. So in my envision, in the future, we will have many more trials combining antibody drug conjugated plus immunocheckpoint inhibitors, and less trials with chemotherapy plus immunocheckpoint inhibitors. Which are the research priorities in the future? Now we have a triple-negative disease that is no more an orphan disease. For this subgroup of patients, we have the PARP inhibitor for BRCA germinal mutant. We have immunocheckpoint inhibitors for PD-L1 positive. And we have a large spectrum of activity with overall survival benefit from antibody drug conjugated. So triple negative is no more an orphan disease. For the future will be important to better identify the magnitude of clinical benefit for approval of these agents. We need to implement patient-reported outcome, and we need much more real-world data in order to confirm the benefit that has been described and supported in the patient population in the context of the clinical trials. Thank you very much indeed, and I will be very happy to take questions.
Thank you, Prof. Gosubi, for this very comprehensive overview for immunotherapy and other targeted agents for the treatment of triple-negative breast cancer. And now the floor is open for a question. Dr. Hamid, do you want us to take the questions now, or I think it's panel discussion now? So I will start with one question, Prof. Now, if I have patients with triple-negative breast cancer, she is BRCA mutant, she has pathogenic mutation, as well as PD-L1, which one shall we start first?
This is an excellent question, I believe. So my personal answer is that in the metastatic setting, you have no benefit from PARP inhibitors. So if you are BRCA mutant and you receive a frontline PARP inhibitor, you don't have an overall survival benefit. So in my opinion, you should give first an immunotherapy, and then you can give a PARP inhibitor. You will see the data next week also of the Keynote 522 using pembrolizumab. And if confirmed also an overall survival benefit with pembro, my personal option would be immunotherapy first and PARP inhibitor after.
Okay, any more questions?
Yes, we have a question here in the audience.
So, very nice discussion, thank you. My question, so are you worried with what happened with atezolizumab and the saga of withdrawing the application, that this is going to spill over to pembrolizumab as well? I mean, we are starting to question, was this a wise combination?
Yes, this is a good question. The decision, as you know, was not an FDA decision, was a Roche decision. If you ask me why Roche decided to withdraw the application, personally, I don't know this. But I can imagine that since we have an announcement that the Keynote 522 met also the co-primary endpoint of overall survival, and since pembrolizumab can be combined with nab-paclitaxel, a carbogen, I believe this decision was a marketing decision. The decision of Roche did not affect the European market because I can confirm that still in Europe, the combination of nab-paclitaxel and atezolizumab is an approved combination. And Roche did not decide to withdraw the final combination also in Europe. So in Europe, we will have the opportunity to use both immunocheckpoint inhibitors, and we will select according to the history of the patient, treatment-free interval, previous neoadjuvant treatment. And in the United States, unfortunately, patients will have only access to pembro and not to atezolizumab in the metastatic setting.
So the other point you mentioned, we're waiting for survival, but I'm old enough to remember the story with bevacizumab and chemotherapy, especially in the triple negative as well, and what happened in the US, and the failure to show survival advantage, even though there was a big PFS advantage. Again, they withdrew the application of bevacizumab. So if this is going to be the same and we don't see survival advantage, do you think we may end up similar to bevacizumab in breast cancer?
No, but in the patient 130, the overall survival benefit was confirmed in the last update of the data that have been published on the Annals of Oncology. So with more than 20 months of follow-up, there is a confirmed overall survival benefit for the PD-L1 positive population. So as I said, we have the confirmation of overall survival benefit. The decision of Roche to withdraw the application, as I said, I don't know why, but this will not affect the use of the drug in Europe. It's just a decision for the US market, and my interpretation is related to the fact that pembro will be approved in combination with nab-paclitaxel, and carbogen. So the history of bevacizumab is a different history because the study with bevacizumab was not powered to see an overall survival benefit, but only progression-free survival benefit. Here is a different history because you have a selection of patients according to PD-L1 status, and in the PD-L1 positive population, the benefit of atezolizumab was demonstrated.
Any comment on so-called HER2 low? We have been hearing about HER2 low, the 1+ and 2+. You mentioned ADCs, so
yes.
Trastuzumab deruxtecan is another hot topic, including in triple negative. You think there's a future there as well?
But for sure, there is a registration trial ongoing for HR positive HER2 low. As you know very well, HER2 low is more common in your more responsive population rather than in the ER-PGR negative. The only registration trial that is ongoing is in the context of HER2 low HR positive. I don't know if AstraZeneca is moving to do a registration trial also in the triple negative. I don't think so in any case, because in that field we have other antibody drug conjugated. One of these is datopotamab deruxtecan, that is the entire TROP2 of this company. And then we have also anti-HER3. So the treatment landscape in the triple negative disease, it's so large now that I don't think there is an opportunity for the development of trastuzumab deruxtecan, much more with the entire TROP2 and other agents.
Thank you. Any comment on eribulin? Why did it do so badly in the trial compared to sacituzumab, or compared among other chemo? We remember eribulin, when it was approved, it was kind of a similar study, eribulin versus any choice of chemo. And we saw about 3 months almost absolute difference in the PFS. It didn't pan out.
I know in the original trial, with the eribulin, the original one that brought to the final approval, maximum lines of treatment was 2. Here in the Ascent trial, you have patients with a medium line of treatment of 7. So, of course, in this context, that's why I believe sacituzumab govitecan was better than eribulin. This is my explanation.
Dr. Hassan, are you sure? Please, feel free. Anyone else had any more question? Okay, so with this, we'll conclude the session. Dr. Khair, thank you so much. Dr. Guspi, also thank you so much for your support for our meetings as always. So thank you, and we'll go now to the next session. Thank you so much. So next session will be moving now to optimizing endocrine therapy for ER positive metastatic breast cancer with Dr. Mark Tuttle. He's a consultant medical oncologist at Oxford University Hospital. He's expert in the use of immunotherapy in cancer treatment. He's also specialized treatment of early and recurrent cancer, including prostate cancer, kidney cancer, bladder cancer, testicular cancer, and breast cancer. And he holds a PhD in tumor immunology from Imperial College London. Welcome, Dr. Tuttle, and thank you for joining us.
Well, thank you very much for the invitation to be with you today. I'm sorry I can't be with you in person for understandable circumstances. So I'm going to give you thank you very much for the introduction. I'm going to give you an overview on the role of abemaciclib in the treatment of hormone positive resistant to treatment breast cancer. Waiting for my slides to change, hopefully. I'm sorry for the slight delay. I'm just waiting for my slides to hopefully progress. Okay, so this is where I work. This is Oxford at the top here. This is Dreaming Spires. This is the our main cancer centre here. You can see we have the typical kind of grey UK weather. And this is where quite a lot of the cancer research is based in Oxford. And this little corner building here, which you may be able to see, is where the Jenner Centre is, where the Oxford AstraZeneca vaccine was developed. So these are my disclosures. So I'm going to go straight into some clinical trial data, because I'm sure many of the audience are already familiar with quite a lot of the data. When we're thinking about the treatment of patients who have previously progressed despite some hormonal treatment, and that's hormonal treatment given either in the adjuvant setting or in the old days, if you like, pre-CDK4/6 inhibitors, single agent hormonal treatment given for metastatic disease, there are a number of different treatments options which are available. There are 3 approved combinations, fulvestrant and ribociclib, fulvestrant and palbociclib, and fulvestrant and abemaciclib. And I'm going to talk you through the evidence base for the use of abemaciclib in patients who've had previous endocrine treatment for the treatment of breast cancer. So Monarch 2 is the registration study which we're going to go through today, and I'm going to talk about some of the some of the subtleties of Monarch 2 including some of the very strong evidence base for the use of abemaciclib in patients who've had previous hormone treatment for breast cancer in the metastatic setting. Monarch 2 was a reasonably modest size by breast cancer clinical studies. What they did in the study was they took patients who were hormone receptor positive, they were HER2 negative, that had progressed on prior endocrine treatment. And I'll come on to what that means a little bit later in the talk. 855 patients were assessed for eligibility. A few weren't suitable, and they randomized 713 patients to take part. They didn't allow anyone who was hormone naive. They were studied in different studies. And essentially, it was a 2-to-1 randomization. 233 patients got fulvestrant on their own, and 446 got fulvestrant plus abemaciclib. So who went into the study? Who went into Monarch 2? Well, there were essentially two groups of patients who went into the study. They were all women. That's the first thing to say, although breast cancer does occur in men. And quite a lot of the patients had secondary resistance. And secondary resistance is defined in the study as patients who had progressed within after 2 years of initial hormonal treatment, and or had responded for at least 6 months in patients who had metastatic disease. The primary resistant patients are patients who had actually relapsed very quickly after their initial or progressed very quickly within their adjuvant treatment or during their treatment for metastatic breast cancer. Quite a lot of the patients had treatment in the adjuvant setting beforehand, and some had been treated with aromatase inhibitors beforehand in the metastatic setting. And there was a good breakdown of patients with progesterone disease positive versus negative. And importantly, a substantial number of the patients in this study had visceral disease. And that's really, really important, because when we're in the clinic deciding what to do with an individual patient and they've got visceral disease, what do we do? If somebody has a liver metastasis, do we put them on chemotherapy, as we've always done, or do we put them on a CDK4/6 inhibitor such as abemaciclib and fulvestrant? And quite a lot of the patients had measurable disease. And I think that's important because metastatic breast cancer is a very broad church of disease. And actually, it's those patients with visceral disease, clinically lumps of cancer you can see in an organ, they tend to do the worst. So I think the first thing to take away, and I think this is really striking data, and I think we've kind of got a bit used to seeing this type of data, but we saw a very, very clear overall survival advantage for patients who were treated with abemaciclib and fulvestrant versus patients who were treated with just fulvestrant on its own. There was a 9.4-month difference in overall survival, and what you can see here is a very clear and persistent separation of the curves here. I think it's really one of the things, if we look at cancer medicine recently, in recent years, it's been striking the significant benefits we've seen. Historically, we've all been quite happy with a 3-month overall survival benefit and said that was okay to justify giving somebody chemotherapy. But here we can see a very straightforward benefit of 9.4 months. And I think this is very clinically meaningful for patients. And historically, in treatments of advanced metastatic breast cancer, we haven't seen these types of benefits before, in part because the patient populations get diluted out, but probably in part because many of the treatments we used previously don't make that much of a difference in the grand scheme of things when they're sort of layered on top of one on top of each other. So really, if you've got somebody in this setting, you'll get a clear overall survival advantage if you give them abemaciclib and fulvestrant. So what about subgroup analysis? And I think when we're thinking about subgroups, one of the things I would say about them is that one of the things I'd say about them is they're really hypothesis generating. But at the end of the day, when we're in clinic, we don't have our experience of 800 patients or however it is to guide us. So we can use subgroups to sort of give us a pointer in a direction. But provided we don't hang our hats on them completely and use them to make all of the decisions, that's really, really key. And what you can see here is that those patients who had visceral disease clearly got a benefit from having more aggressive treatment with fulvestrant and abemaciclib. There wasn't much of a difference between primary and secondary resistance either, but clearly the line is to the left, favouring abemaciclib and fulvestrant. And there isn't really a group of patients you would look at from this initial analysis where you would say, well, maybe you shouldn't go on there. Just to go over again the definitions of primary resistance. So that's relapse within the first 2 years of endocrine treatment or progression within the first 6 months of initial endocrine therapy. And secondary is essentially the opposite of that. Now, what if you split your patients up into those people who've got primary resistance? And the primary resistant patients are the ones that causes the most concern in the clinic. When you see somebody, they haven't responded to their initial hormonal treatment. And we know we're in for a difficult time with controlling the disease, predominantly with chemotherapy-based approaches. For patients who've got primary resistance, they get a clear advantage from having abemaciclib and fulvestrant. And strikingly, the overall survival start to separate very, very quickly. So in other words, when you put somebody who's primary resistant onto their treatment, pretty much as soon as you've started it, they're already doing better. What about for secondary resistance? And again, you can see here, although this is a more favorable cohort, you can see that because the overall survival is better, you can still see the curves would separate. So essentially, there isn't a group of patients who wouldn't get benefit, either whether they've progressed quite rapidly on initial hormone treatment, whether that's in the adjuvant or metastatic setting, or for those patients who've had a more favorable disease course, but unfortunately developed metastatic or secondary breast cancer. Now, what about stratifying patients? And this is an updated analysis of the same study. And what you can see here is that if you have visceral disease, patients clearly do better. Bone-only disease, it's kind of in the balance really, and other sites of disease. Really, I think the takeaway message here is that if you've got visceral disease and you think you need to start treatment, the best combination, abemaciclib and fulvestrant, is a very good approach to take. What about tumor grade? Well, we tend not to think about grade too much when we're in the metastatic setting, other than we know that patients with higher grade tumors are more likely to have a more serious or aggressive disease course. In higher grade tumors, again, the abemaciclib and fulvestrant is superior to the fulvestrant on its own. And again, in the lower grade tumors, although there wasn't much of a difference initially, over the passage of time, and I think this is really important, the more effective treatment, the combination did better. What about progesterone receptor status? And again, progesterone receptor status could be a marker for more aggressive disease, luminal B, and essentially luminal B subtypes. And again, although we don't think about that very much, again, what we can see here is in the patients who are PR negative, again, they did better, more clearly, really just reflecting the sort of adverse biology of this group. But again, in those patients who were double positive and HER2 negative, again, in the longer run, the combination was more effective. And what about liver mets? And I think this is really important. Historically, liver metastasis were always an indication for starting chemotherapy. And what we can clearly see here is if you've got liver metastasis, you can clearly see a separation in the curves. So in other words, you can take somebody who's got disease, which we would traditionally start treatment with chemotherapy, and they do respond well. And again, if they have progressed and developed liver metastasis, again, they still do well. What about treatment adverse events? And I think that's something which is really important. If we look through the adverse events, and they are different between different CDK4/6 inhibitors, the main one to be aware of with abemaciclib is diarrhea. Again, the majority of patients will experience some form of diarrhea, but only a minority will have severe diarrhea. It's important to know that it's very straightforward to prevent this. All patients will be given some loperamide prior to them starting abemaciclib, and provided the diarrhea you get on top of it quickly, it is a manageable side effect. Other side effects, including neutropenia, they're mild, taste change, and other blood tests. Other blood tests are largely unaffected. One thing that can happen is the creatinine can go up a little bit during treatment. This is due to a drug effect. It doesn't mean the patients are in renal failure. Overall, abemaciclib is a well-tolerated treatment, and in real-life practice is convenient to use. The other thing about abemaciclib is it doesn't cause cyclical neutropenia, unlike the other CDK4/6 inhibitors. So it actually favors for longer-term dosing without needing for patients to come up for blood tests on a 4-weekly schedule, which if you have a large breast cancer practice, it can become a problem. Now, one of the other things about this group of patients is that often many of these patients who develop metastatic breast cancer will have had previous chemotherapy in the adjuvant setting. Although modern chemotherapy is better tolerated than older regimens that we used, say, 10, 20 years ago, and supportive medicines, so GCSF, antiemetics, are much better, many patients have still got significant memories of the difficult time they had on chemotherapy. And some of the patients are older and very much don't want to start chemotherapy. one of the really important things about, one of the great things about CDK4/6 inhibitors, and you can see here from this data here from the same study, is you can see the time to chemotherapy is very significantly delayed for the majority of patients. And that's really meaningful for patients. Going up and down to the day unit, having an injection, taking tablets for 28 days is generally speaking manageable and compatible with a normal life. So I'm going to give you an example of one of my patients I treated with abemaciclib. She was a 62-year-old woman. She'd previously had breast cancer in 2012 and had developed liver metastasis and had been started on initially an aromatase inhibitor. She then progressed and was also found to have a PTEN mutation and had been treated as part of a clinical trial called the Plasma Match trial, which we're running at the time in Oxford. Now, unfortunately, she progressed and she developed liver metastasis, and we started her on abemaciclib and fulvestrant. When I say the side effects, which were, she had some mild side effects with diarrhea, she managed with loperamide, but otherwise it was very well. She, in fact, was going to the gym several times a week, was super fit and well, and she had an ongoing response which lasted up to a year. Unfortunately, she has had to switch to chemotherapy since then. But one of the key things to take away is that what we could see is when we started the medicines, actually her tumor markers did go up for a bit, and then it took a little bit of time to settle down. So one of the things about starting patients on this endocrine treatment with abemaciclib in the setting is sometimes you can wait, sometimes you have to wait for a little bit for your response to come on. It isn't instantaneous. But she had a very good run with the drug. She was very well on the treatment and overall had really good quality of life during the time she took it. I think one of the other things about it, and I haven't showed the scans here today, is her scans initially look like they were getting worse before they get better. And so that's one of the things I'd say about it. If somebody's very well and their scans are taking a little bit of time to respond, it is reasonable to wait. Now, I'm not talking about waiting 6 months and somebody getting ill, but if you've got somebody who's just started and their scans are a fraction worse, it is reasonable to wait before switching to treatment to get that benefit. The other thing is that in patients who've got molecular mutations, such as PTEN mutations or BRCA mutations or otherwise, or PIK3CA mutations, CDK4/6 such as abemaciclib do work in this patient population. So you shouldn't think that just because somebody, say, has had a Foundation 1 test or other type of genomic test that you shouldn't start them on a treatment like abemaciclib, which is targeting CDK4/6, because essentially patients with these mutations will still respond. And that's something that I've learned over the last few years, particularly as we've had access to targeted therapy. We've had access to sequencing, and including blood and plasma, which we've done mostly in the context of clinical trials. But because most of the patients don't then go on to have a targeted treatment, they have been on CDK4/6 inhibitors and responded. So in conclusion, I hope I've convinced you that abemaciclib plus fulvestrant improves overall survival in patients who've had previous endocrine treatment. Combination is active across a wide different variety of subgroups of patients with secondary breast cancer. The side effect profile is manageable, and the combination is active in clinical practice, even in patients who've got molecular abnormalities. So this is a QR code for prescribing information. I'm not sure if the audience are going to be able to scan this, so I won't change the slide, but I, of course, would be delighted to take any questions.
Thank you so much for this very thorough review, and we'll be taking questions now. And as usual, we'll start with Dr. Hassan Ghazal by default.
Hi, thank you for the nice presentations. I guess a typical question is, since we have two other anti-CDK, and we have maybe some unique differences in the toxicities, for sure, we know that. But with lack of head-to-head, we always have to, unfortunately, compare across trial. So there is no question, like you showed, the visceral disease certainly, and the resistance question looks somewhat stronger message with abemaciclib. But how do you explain the bone disease only? Because, you know, more than half breast cancer have bone disease only. And these patients, when you look at, for example, palbociclib trial, there was good separation when used palbociclib. So biologically, is there an explanation of the difference between among the different anti-CDKs?
So I think sort of the question was in sort of three parts: is how to choose between them, a bit on the toxicity profile, and then is there a stronger rationale for one CDK4/6 inhibitor in one setting versus another? Is that a fair summary?
Yes.
Okay. So I think we'll go in reverse order. So I think there are differences in how abemaciclib is dosed. So abemaciclib continuously blocks CDK4 and 6 with a slight bias towards CDK4. That bias stops you from having low blood counts, etc., which is why the drug can be dosed continuously. So that may be why abemaciclib is more favorable in patients with visceral metastasis. But I think it's important to note that in all the studies of abemaciclib, it's been active in all groups. And I wouldn't want you to hang a hat and say, well, look, in one subgroup analysis, it says that bone only is favorable, in other, because I don't think you can make that decision. In terms of the sort of groups of patients, I think the first thing to take away is that one of the things we've learned with all the CDK4/6 inhibitors, you can use them in patients with visceral disease. The data for abemaciclib are very strong within respect to what's going on in the liver, but of course there are similar data for patients, with palbociclib and ribociclib as well. So choosing between the drugs, well, look, I think there are a number of differences. There are toxicity profile differences. So neutropenia is the main one with the ribociclib and palbociclib, and diarrhea is the one with abemaciclib, which is the sort of the main difference. The diarrhea is relatively speaking straightforward to manage. How do you choose between them? Well, I think familiarity is one. The other thing to be aware of is the presence of an overall survival advantage, which is seen with, for example, with abemaciclib in either of the settings that's approved. The same is also true for ribociclib, but no trials, to my knowledge, have yet shown palbociclib has an overall survival advantage, and that's kind of inferred. Overall, I think all three of them are good choices, but I hope I've convinced you that abemaciclib is a good choice in the hormone receptor setting, in the resistant setting.
Well, Paloma-3, I mean, there was some, at least published lately, the Paloma-3 showed some survival advantage. There were 6 months, I think, difference. But then there's a lot of...
It's a little bit. It's
yeah, borderline. But there's also a lot of real-world data from, Pfizer, if you believe in analyzing these real-world data. There was one nice analysis by Dr. Huprogo, I think, where she tried to sort of control for all the variables. I think there were a few variables she chose and tried to control across the 3 studies. And the end conclusion was, again, the 3 drugs are all the same. No difference when you control for all the other variables. Anyway, but again, the standard should have been a head-to-head comparison.
So I think I agree with it, but I think, let me put it this way, I think it's an embarrassment of riches, okay? I think we're very lucky to have a choice of 3 drugs, really. So I think it's an embarrassment of riches, but again, it's one of the difficulties about comparing across studies. Thank you.
Dr. Aida, go ahead.
Yes, this is Dr. Aida Al-Awadi. I'm one of the oncologists in the United Arab Emirates. Thank you for being with us. So my question is that, I mean, it's a case question, so I don't think there's any particular guideline, but would like to get from your expertise. So I have a patient with ERPR positive, HER2 negative, with oligometastatic disease. And this patient, basically, we decided she's a young patient. It's only single site in the bone, which was confirmed with a biopsy. And we decided to take the curative intent approach. So the patient got like the chemo, the surgery as appropriate, and then also radiation therapy and such, and she also got radiation therapy to the metastatic site. So my question in this patient, would you just go ahead with adjuvant hormonal therapy, like, she was a young patient, so we offered Zoladex with either tamoxifen or Arimidex, but in your case, would you consider CDK for these patients?
So I think so first of all, look, it's obviously an unusual case, and the unusual ones are the ones which kind of stick in our minds. I think the way I would see it is that, do you truly believe she's got oligometastatic breast cancer? And if we think there's just one site and she's had all of her treatment for all of the areas, then I would say that she should go on to hormonal treatment on its own, because we don't have a strong evidence base for, say, putting somebody on long-term CDK4/6 inhibitors. So I think I wouldn't put her on that. There are obviously some restrictions in what we could do here in the UK anyway, because we wouldn't be able to get drug approval for the majority of our NHS practices. So I think I would favour putting her on hormonal treatment, but with the advice that she's at high risk of recurrence. But I don't think there's a right answer here. But I think that's the approach I would go down, because if we truly believe she's oligometastatic, that should be the end of the story. The other thing is, I think you'll know within 6 months anyway about her degree of endocrine resistance. So, or within a few years. So regular scanning, I think, and I think that will, and then what will be will be.
Okay, thank you so much.
I hope that's helpful.
Yes, absolutely. I actually agree with you too.
Oh, perfect.
Excellent. So, Doctor, a general question regarding addressing primary breast tumor in a setting of metastatic liver metastasis disease. What's your current practice if the patient has a good response to their liver metastasis? Let's say, for example, HER2 positive, and the patient has complete response. Will you address the primary tumor in the breast, or will you just continue with systemic therapy? Dr. Ibrahim, if you can listen to this, because we disagreed about this yesterday.
Well, I don't want to get involved in trying to sort of decide for you, but look, I think the evidence for aggressive treatment of the breast primary is uncertain. I think our practice in Oxford in the UK is to say, well, look, if you have somebody who has got metastatic disease and all of their metastatic disease is responding well to treatment, but the breast lump starts to grow, then we offer surgery and radiotherapy often afterwards as well to get good local control. Let me put it this way: if I had a patient in my clinic and she'd had a complete response in her liver and she still had some residual disease within her breast, I think it is reasonable to talk to her about having breast surgery, but with the caveats that it probably won't make much of a difference in terms of her overall disease outcome. So I think it's reasonable. The other thing is, for some patients, if they have got this big breast lump or a lump which is not there, it does have a benefit having it removed, even if we know there's a risk. So I hope that's a suitable answer which helps the situation.
Thank you so much. Yeah, this is very clear. Anybody else? Any comments? Any questions? Yes, Dr. Ghazal again. Leave the mic with him. Don't take it from him.
So talking about, I have a very similar case to Aida, but we were discussing it yesterday in tumor boards. This one is a 30-year-old who presented with actually more of a miliary pattern in her bones, not specific spots. And we did a random biopsy, and it was malignant breast cancer. So she has been on palbociclib and hormonal therapy for about a year and a half. And she had complete resolution, at least on PET-CT scans, to the point that she went ahead and had surgery. That was her wishes, an axillary nodal dissection. So unfortunately, she still have residual disease in the breast, about 2 centimeters, and there were 6 positive lymph nodes still out of 20. So no other diseases now apparent. So 2 questions: would you be aggressive locally and add radiation therapy? And would you continue now back to the anti-CDK plus hormones, knowing now she's no evidence of disease, but of course she's high risk to progress?
So did she have disease around her liver? Was that what you said?
No, just bone only. But it was diffuse.
So my impression is they've got metastatic breast cancer, and I'm not surprised they've got residual disease in their breast, because I think it's more of a shrinkage down, unlike with HER2 positive, with Herceptin and pertuzumab, where you get these dramatic and deep responses even in hormone receptor positive HER2 positive breast cancer. I think it's more of a shrinkage effect, really. So I would carry on with the palbociclib and aromatase inhibitor for the longer run. because she does have metastatic disease. I think if you stop it, then that disease will return. So I would, unless there's obviously unacceptable toxicity.
So you wouldn't give radiation therapy?
Well, it depends a little bit on what the extent is. Is it within the bones, is it, or?
It is within the bones, but there is no active disease at the current time. I'm talking about radiation to the lymph node and chest wall, because she has 6 positive lymph nodes.
So I think it's a reasonable thing to do. I think there's obviously you've got the chance of waiting a little bit longer or going for it now. So we tend to be fairly aggressive locally, actually. Well, I don't know whether it's aggressive or not, but generally speaking, if the surgeons have done a good operation and they think there's a risk of recurrence afterwards, we tend to offer patients radiotherapy to reduce their risk of progression locally. And so I would probably think about offering her some radiotherapy, because ultimately this is one of her prime risk factors for problems later on. And these chest wall recurrences are very difficult to manage in the longer run.
And your initial therapy was anti-CDK at this age. Would you immediately give AI, or would you give a few months of tamoxifen? She was 28 years old in the beginning.
So I don't use any, we don't use any, I don't use any tamoxifen in premenopausal women now. So what we tend to do is to start them on Zoladex and start them on a CDK4/6 inhibitor. And I know it takes a little bit of time for them to become postmenopausal, but we've normally got that. Now we don't come across this situation very much, but generally speaking, we're able to manage it.
Okay.
Hi, thank you for the excellent lecture. Just to answer Dr. Hassan, I'm Dr. Sami Khatib, radiation oncologist. The case that we are talking about is a highly risk woman, 80 years old. So I think that giving her the radiation therapy to the breast and axilla will improve a lot the local recurrence of the disease. Do you agree?
I agree, yes.
Excellent. Okay, so I think...
Nice to see you on the screen.
Do we have any more questions? Except Dr. Ghazal? Okay, in this case, so we're going to conclude. Thank you so much, Dr. Tuttle, for your expertise and your joining us today. And we look forward to see you here in person, hopefully next year. Thank you so much.
Brilliant.
And have a good evening.
Thank you so much. That's great.
Thank you.
Thank you.
Thank you.
Bye-bye.
So we'll be taking a 15 minutes break, a coffee break, and then we'll come back and we'll regroup, inshallah, in 15 minutes. And we'll see you soon. Dr. Ziauddin Trad.
Yes, Dr. Ahmed. Assalamu alaikum.
Oh. Okay, so دكتور أنت موجود معنا أونلاين.
نعم.
Okay, so we'll resume our session now and welcome in Dr. Ziauddin Trad, who's a consultant medical oncologist at Tawam Hospital. Dr. Trad, he's one of the well-known figures in the oncology in UAE, and honestly, he doesn't need much introduction. Dr. Trad, welcome and thank you for joining us, and the mic is yours.
Thank you, Dr. Ahmed. Just before the start, let me congratulate you for this great and successful meeting and for all your achievements. So in the coming 25 minutes, we'll have a presentation by Dr. Imad Anwar, who is a medical oncology consultant at Tawam Hospital. We all know that for the treatment to be effective, some of the important elements that should be available is the efficacy, safety, and convenience. And we all know that we have seen a lot of progress in the treatment of HER2-positive breast cancer. So Dr. Imad will present to us a presentation entitled as Revolution in the HER2-positive breast cancer treatment, the subcutaneous fixed dose Herceptin and pertuzumab. At the end of the presentation, which is going to be over 25 minutes, if we have time, we may have one or two questions at the end of the presentation. So Dr. Imad, the floor is yours.
Thank you, Dr. Trad, for your nice introduction, and another thanks for the organizing committee, and congratulations for arranging this very successful meeting. And also I would like to thank the Hoffman La Roche for inviting me for this talk. My dear friends and colleagues, today I'm going to talk about the fixed dose combination of Herceptin pertuzumab, or what we call the FISGO, as a revolution in anti-HER2 therapy in breast cancer management. So we all aware about the poor prognosis of patients with HER2 positive breast cancer disease. And since the approval of trastuzumab in breast cancer, really we see there is an improvement in the outcome for those patients, whether in metastatic setting or even in early stage. Then one step forward, the dual anti-HER2 considered as standard of care in management of breast cancer, whether Herceptin and lapatinib, or the most recent the combination of Herceptin pertuzumab. And as we all aware about that, pertuzumab is a humanized monoclonal antibodies that targets the extracellular domain of the HER2, and it blocks the heterodimerization of the HER2, so it will inhibit the downstream pathway for the HER2 positive breast cancer. And this combination has been initially approved in metastatic setting based on the Cleopatra trial as the Herceptin pertuzumab. It did really improve the overall survival for those patients and considered as a standard of care plus the chemotherapy. And as a normal process for any drug development, the drug usually moved from the later lines to the front lines. And here we have the approval in neoadjuvant setting and the new Sphere trial that Herceptin pertuzumab plus chemotherapy, it did improve the pathological complete response for our patients. And the most recent approval in the adjuvant setting for patients with the high risk HER2 positive lymph node metastasis, or those with the ERPR negative. And that has been translated into approval of this combination in all the well-known international guidelines. But we have some limitations for using an extra medications in treatment of breast cancer. So by adding pertuzumab to Herceptin and even plus the chemotherapy, this will prolong the infusion time and observation time in our clinics, in our infusion centers. That will cause a congestion of patients in our clinics, something that nobody likes, especially in the COVID era. And also it's adding a lot of burden on the clinical pharmacists, those responsible for the preparation of the medications. So that's mean there is a longer time of preparation and you need more manpower. So that's eventually will increase the indirect cost of treatment. Put in mind that patients on Herceptin pertuzumab in adjuvant or neoadjuvant setting, they need treatment up to 1 year, and in metastatic setting until progression, which is in average 2 years. So this is very long time, and definitely we need a portacath or central line to deliver these medications, and this is another indirect cost adding to these medications. And don't forget that the central line, it needs an extra care, and also there is some complications from these central lines. One of the solutions to use subcutaneous injections, and for those who have experience with the Herceptin subcut, where we do have an evidence that the Herceptin subcut, it has the same clinical activity and efficacy as the Herceptin IV. It's preferred by most of our patients, and the data showing that 86% of patients, they prefer the Herceptin subcut over the Herceptin IV. And it's the same for the healthcare facilities or healthcare providers. They prefer the Herceptin subcut over the IV. And I'm aware that there is some hospital, they change it completely from the IV to Herceptin subcut for a short time infusion. There no need for preparation. And most of the patients, they like the subcut injection. Moving forward for the FISGO or the dual antibody for the HER2 inhibitors. So the FISGO, it's contain both monoclonal antibodies for the pertuzumab and trastuzumab. It has been formulated with the recombinant human hyaluronidase that will allow injection of the larger amount of the medicine in the subcutaneous space. And usually we are injecting the patient in the thigh, and injection time over 5 to 8 minutes according to is it the loading dose or the maintenance dose. So if you compare the FISGO to the Herceptin subcut, there is no major difference. Both are giving subcutaneous injection, but we know that the FISGO, it has a loading dose, but Herceptin subcut, there is no loading dose. And the volume in the FISGO is a little bit larger than the Herceptin subcut. So the loading dose is 15 ml, while the subsequent dose is only 10 ml. When it comes to the injection time, 8 minutes for the loading dose and only 5 minutes for the subsequent doses, which is the same like Herceptin subcutaneous. And one of the advantages of the FISGO that the observation time, it's much lower than the observation time of Herceptin subcut. I would like to have a couple of slides highlighting the recombinant human hyaluronidase enzyme, which is now formulated in most of the novel drugs given subcutaneously. And we have the MabThera subcut, Herceptin subcut, and now the FISGO subcut. This enzyme, it's causing degradation of the hyaluronine matrix in the subcutaneous tissue. And this inhibition or degradation, it's only temporary, and it takes 1 to 2 days, and then it will disappear. And because the drug actually, it has a very short half-life. So in this cartoon, just to show how the benefit from the hyaluronidase enzyme formulated with this new medications. So here the subcutaneous layer where the hyaluronine matrix, it's preventing the large amount of drug to be absorbed or injected in subcutaneous space. Probably if more than 1 ml, it will be difficult to inject that amount. But in presence of the hyaluronidase, it will cause degradation of this layer, allowing more drug to be delivered in the subcutaneous space and a better absorption. And this mechanism will be restored within 1 or 2 days, and this effect, it's only localizes. at the site of the injection. And here, an example for patients injecting a drug without hyaluronidase. You can see here the bulging in the site of injection, which is totally different in patient injected with the drug with the recombinant hyaluronidase, human hyaluronidase enzyme, which injecting up to 15 ml without any bulging in the site of the injection. So what is the clinical evidence behind the using of Physgo? And here, as any normal process of drug development, there is a phase 1 trial to calculate the dose of the Physgo, whether we need loading dose or not. So we already know the dose of the Herceptin subcut, but mainly the trial was to measure or calculate the Physgo dose. So we have the 1,200 milligram as a loading dose, followed by 600 milligram as a maintenance dose. And currently we have a phase 3 trial, the Federica trial, looking for the pharmacokinetic efficacy and safety of the drug. And we have the Francesca trial, where it's a phase 2 trial looking for the patient preference, whether the IV or the subcutaneous injection. And the most recent one, the Fidentia trial, which is still ongoing trial. And here I'm going to present the Federica trial, and which is a phase 3 pivotal non-inferiority pharmacokinetic study. So patients with HER2 positive breast cancer, those are candidate for neoadjuvant chemotherapy plus anti-HER2. They are randomized into 2 groups, arm A and arm B, and the treatment of the chemotherapy was totally according to the investigator choice, whether to go for the conventional AC every 3 weeks or the dose dense AC in each group. So patients received 4 cycles, then one group will receive the Herceptin pertuzumab IV every 3 weeks for 4 cycles, and the other group, or group B, will receive the Physgo, the subcutaneous dose for 4 cycles, then surgery, and after surgery, the patients will continue in the maintenance Herceptin pertuzumab. So the primary endpoint of this trial is to assess the non-inferiority of the pertuzumab at the cycle 7, and this is before cycle 8. So looking to the pertuzumab serum C-trough. Secondary endpoint, looking for the non-inferiority of the trastuzumab serum C-trough. Also the assessing the pathological complete response, the safety, and overall survival for those group, patients. This trial has been stratified according to the stage and hormonal status. And here you can see that this is the baseline characteristic of the patient population, which were balanced between the 2 treatment arms according to the stratification factors in each arm, whether the stage, the menopausal status, or the HER2 status, or even the chemotherapy has been given, whether it's dose dense or the conventional AC. So we have an equal number of patients exposed to the treatment, which is an average of 4 cycles of Herceptin pertuzumab. This trial was positive because it achieved its primary endpoint, and here we can see that there is no significant difference in the pertuzumab serum C-trough within the Physgo when compared to the IV formulation. And the geometric mean ratio was in the 1.22, which is within the average of non-inferiority. And the trial also met its secondary endpoint regarding the trastuzumab serum C-trough, and also it was a non-inferiority range with 1.33, which is within the range. And looking for the pathological complete response, and was pretty similar in both treatment group, 59% in each treatment arm. And that was also matching the pathological complete response from other phase 3 clinical trials in this setting. If you're looking for the pathological response rate according to the pre-specified stratification, which is hormonal status, stage, or the chemotherapy, it was pretty similar between the 2 treatment groups. There was no any difference in pathological complete response. Coming to the safety profile of the drug, so here we have almost the same disclaimer, and we couldn't see any difference in the evidence in the incidence of the adverse events or the rate of discontinuation or even the grade 3 and 4 toxicity. And here the different type of toxicity, which is mainly related to the chemotherapy, but again, there was no difference in both treatment arms. The most important, the cardiac toxicity, which is again, but very, very, very minimal cardiac toxicity reported in this trial, but also there was no any significant difference between the Herceptin pertuzumab IV or the subcut in the physical combination. What about the anti-drug antibodies development? It was very small percentage, less than 5% in each arm. And they have been looking for the anti-drug antibody for the pertuzumab as well as for the trastuzumab. And there was no any significant difference between both treatment arms. Moving to the second trial, which is Francisca trial, and this trial was designed to assess the patient preference, whether patients they prefer the IV formulation or the subcut formulation. So it's a phase 2 trial, and in this trial, patients with HER2 positive has been randomized into Herceptin pertuzumab IV for 3 cycles versus Physgo for 3 cycles. And after 3 cycles, each treatment group will cross over to the other treatment arm. So they will receive, those received IV will receive the Physgo for 3 cycles, and those received Physgo, they will receive IV for another 3 cycles. And this phase, what we call the treatment crossover period. After 6 cycles of the Herceptin pertuzumab, the patients are allowed to choose or to select which combination they prefer, whether to go for the IV or the subcut. Treatment up to 18 cycles. And the primary endpoint of this trial is the patient preference for Physgo. So the statistical assumption for this trial was assumed that the preference rate would be in the range of 70% in favor of Physgo. So if you achieve this percentage or higher, that trial will be positive. So this is the patient population, and it was well balanced in the both treatment group. And this is the patient deposition at time of analysis. So 80 patients in each arm. And those ongoing treatment in the IV, it was 43 patients and 44 in the Physgo arm. So that trial was well balanced in both treatment arms. So here in this table, just showing that a baseline characteristic in both treatment arms regarding the age, the ethnicity, and the race, it was also well balanced in both groups. And here for the ER/PR status, the chemotherapy backbone, the pathological complete response, and even the number of cycles of the new adjuvant of Herceptin Perjeta, it was also well balanced. And all patients, they received the prior neoadjuvant chemotherapy in this trial. So again here was balanced the patient population regarding the histological subtypes, the grade, and the clinical stage. Just to highlight that majority of patients, they have grade 3 tumor, and 85% they are stage 2 and stage 3 patients. So the trial was positive because it met its primary endpoint by 85% of the patients, they preferred the Herceptin pertuzumab subcut, I mean the Physgo, versus only 14% they prefer the IV formulation. And that was matching with other trial that showed the same percentage of patients. And we have 89% from the preferred trial and the 77% Perfimab trial, which is showing that the subcut formulation, it's one of the preferred methods for patients when compared to the IV formulation. And they have been assessing that the reason behind that, why they preferred the subcut injection, and 93% of the patients that preferred the injection, they have very strong reasons to prefer the subcut over the IV, and mainly that because of the less infusion time and less waiting in the clinics, and also they feel comfortable, there is no pain, and there is no need for the central line insertion. While only 64% out of the 14% of the patients they preferred IV, they are they have very strong reasons to prefer the IV over the subcut formulation, and probably this because of the pain at the site of the injection. And at the end of the day, there is no difference in the baseline global health status score between the IV or the subcut formulation. So the both are equal in this matter. And on the other hand, they have been assessing the healthcare providers, which one they are preferred. So the preference was mainly for the Physgo formulation, that because of its subcut injection, there is no need for the infusion and no need for preparation. And also there is no need for wasting of the medications. And they have been reporting the side effects from this trial. It was equal in both treatment group. Probably there is some higher rate of in site injection pain in the subcut, while we have other side effects like the central line complications in the IV group. And also they reported no difference in the cardiac toxicity in both treatment groups. So it's a kind of reassurance that when you are using which formulation, you are giving the pretty similar drug without any difference in the efficacy or in the safety. The only difference in the way of administration of the medications. And here the other the list of side effects from both drug forms, and as I mentioned that injection site reaction was almost reported in 15% in Physgo, and this is the only difference between the two drug formulation. So just to summary what the advantages of the Physgo over the IV Herceptin pertuzumab. First of all, it's ready to use vial. So no need for preparation in our pharmacy, and it's a fixed dose for the loading dose. There is two forms: one loading dose and one for subsequent dose. And for loading dose, the pertuzumab 1,200 milligram, 15 ml, and should be injected in the thigh over 8 minutes. And we need only 30 minutes of observation. And for subsequent dose, it will be only 10 ml for injection and approximately only 5 minutes of injection, and you need only 15 minutes of observation. So if you compare this for the IV formulation, you need preparation in our pharmacy, you have waiting time until preparation, long infusion time, up to 1 hour in pertuzumab, and another hour for Herceptin, observation up to almost 6 hours in Herceptin. It's not in the real life, but in average another 1 hour in each for each drug for observation. So saving a lot of waiting time for our patient by using the subcutaneous formulation. So in summary, Physgo, it has been approved by FDA as a ready-to-use fixed dose formulation of Herceptin pertuzumab over 5 to 8 minutes. And from Frederica trial, we have a pretty similar efficacy in the two drugs and safety. And as a pharmacokinetics was equal in both formulation, we have almost the same pathological complete response in both treatment arms. And from Francisca trial, we have majority of patients, 85%, they preferred the Physgo over the IV formulation, and that mainly because of the short infusion time or injection time, less waiting time, and they are more comfortable with the subcutaneous injection. So by using the subcutaneous formulation, this will definitely reduce the indirect cost of the IV medications. It will need less manpower in your clinic, and also this will reduce the waiting time and the congestion in our clinic and infusion center. So with that, I will end my presentation, and thanks for your listening. I will be happy to take any questions. Thank you.
Thank you, Dr. Imad, for this great and comprehensive presentation. And I think we have no questions from the audience. And I think we are also beyond time. So I will like to give the floor back to Dr. Hamid.
Thank you.
Thank you.
Assalamu alaikum. Good afternoon. Our next speaker is Professor Michelino De Laurentiis. He's chair of Department of Breast and Thoracic Oncology at National Cancer Institute in Fondation Pascal in Nepal, in Naples, sorry. Dr. Laurentiis had his medical degree at the University of Federico II in Naples, Italy, and he was awarded the clinical fellowship at the same university. He obtained PhD for clinical research in oncology and was also appointed as attending physician at the Division of Medical Oncology of the same university. Then he took the responsibility for breast cancer systemic therapy research and clinical and translational breast research. And then he moved to National Cancer Institute, and then he was the director of the breast oncology. In 2015, he was appointed as affiliate professor at the Temple University of Philadelphia, Pennsylvania, USA. Currently, he is the head of the Department of Breast and Thoracic Oncology at the National Cancer Institute, Fondazione Pascal in Naples, Italy. Dr. De Laurentiis, he's a member of ESCO, ESMO, and many other international group, and he's lectured, published, and had a lot of research. Dr. Michelis, do you hear me?
Yes, of course.
Yes, the floor is yours.
Okay, thank you very much. Ladies and gentlemen, dear colleagues, these are my disclosures. After decades of a stalemate, in the last decade, we have witnessed a complete revolution in the treatment of HR-positive, HER2-negative metastatic breast cancer. And the keystone trials of this revolution are reported in the timeline of this slide. Based on the results of these key trials, endocrine treatment in monotherapy is now perceived as a suboptimal treatment for most of our current luminal metastatic breast cancer. Let's now start focusing on most recent data supporting the use of CDK4/6 inhibitors. CDK4/6 inhibitors are commonly perceived by the average oncologist as very similar drugs, and we, too simplistically, expect a class effect in the clinics. Frankly, I do not believe that these drugs are born equal, and I will try to support my belief with some preclinical data. The first important point to highlight is that inhibition on CDK4 seems more relevant to breast cancer than inhibition on CDK6. As you can observe from the graph in the slide, HR-positive breast cancer cell line, the red circles here, are more dependent on CDK4 and less dependent on CDK6, while the opposite seems to happen for the hematopoietic cell lines, represented here by the blue circles. So CDK4 inhibition is key. The second important point is that ribociclib and abemaciclib are more active in inhibiting CDK4 than CDK6 as compared to palbo. These are head-to-head comparison where the bar height represents the ratio of inhibition of CDK4 over CDK6. As can be observed, the bar are much higher for ribo, the light blue bars, and abema, the orange bar, as compared to palbo, the yellow bar. And this is both in cell line and in biochemical, let's say. This demonstrates that ribo and abema are more specific inhibitors of CDK4 as compared to palbo. Furthermore, these dendrograms highlights that ribo and palbo exhibit much fewer of targeted kinase inhibition than abema, which is clearly a pretty different drugs in terms of spectrum of kinase inhibition. Is much more heterogeneous as a spectrum of kinase inhibition. However, even ribo and palbo do not look exactly equal. For instance, ribo is different than palbo here, but also here. They are not exactly the same drug. Finally, if we take into account both molecular potency and pharmacokinetic data, we observe that after correcting for both parameters, ribo is expected to provide in vivo, therefore correcting for the expected area under the cues, is expected to provide in vivo a 27-fold higher CDK4/6 inhibition as compared to palbo and abema. This is because of both the high selectivity for CDK4 and the high bioavailability of the drug. Therefore, we must conclude that these drugs are absolutely not born equal. But are these differences relevant to the clinic? Let's have a look to the overall survival in the overall population, the ITT population of the pivotal trials. 7 pivotal randomized controlled trials have been run to show that the superiority of adding a CDK4/6 inhibitors to endocrine treatment as compared to endocrine treatment alone. And such trials are reported in this table. The study populations included a wide range of patients, and in this table I've tried to summarize the main characteristic of patients included in each single trial. And as can be seen, there is a heterogeneity among trials, with some including postmenopausal patients only, here and here, some also including a small subgroup of premenopausal patients, while the Mona Lisa 7 here is the only randomized controlled trial exclusively enrolling pre- and perimenopausal patients, women. They all enrolled patients with either visceral disease as well as bone only disease. And as you can see from the table, 2 trials also included patients here who had been pretreated with chemo for their metastatic disease, namely the Mona Lisa 7 and the Paloma 3 trial. However, for the sake of a correct interpretation of data, we must understand the main differences between trial population. And I think that particularly helpful is this snapshot table focusing on the endocrine sensitivity of the enrolled patients. As you can see, the first 3 trials, these 3 here, enrolled only patients that are relatively endocrine sensitive for being either endocrine treatment naive or for having been relapsed very late, that is more than 12 months after the end of the adjuvant treatment. While the last 2 trials, namely the Monarch 2 and the Paloma 3, included only patients that were relatively endocrine resistant for having been relapsed during on or early after the end of the adjuvant treatment, that is less than 12 months since the stopping of the adjuvant treatment, or for having progressed on endocrine treatment given as first line for their metastatic breast cancer. Mona Lisa 7 trial did include mainly endocrine sensitive patients, but also a subgroup of early relapsers, therefore belonging to the third column, one of the endocrine treatment resistant category. While Mona Lisa 3 is pretty unique because it's the only trial which included the patients of all the 4 categories, either sensitive and resistant. Let's now focus on overall survival data. Only the last 4 trials in the table have yet reported overall survival data. 3 of these, namely Mona Lisa 7, Mona Lisa 3, and Monarch 2, have reached the statistical significance here, while Paloma 3 have not. So we have 2 trials with the ribociclib, the first 2, and 1 trial with abemaciclib, this one, that are formally positive. We don't have yet a trial which is formally positive with palbociclib. The same picture arises if we look at the clinical significance by drawing the vertical line corresponding to the ASCO cutoff for a clinically meaningful benefit. Again, only ribo with the 2 trials and abema with 1 trial do show clinically significant overall survival benefit. For the sake of methodology correctness, I go back again. I'm only referring this table and the following slides to overall survival results that derive from planned analysis, that are the only ones that can be deemed formally positive or negative. Also, please take note that Mona Lisa 2 overall survival data, not reported here, are being released in about 2 weeks at the upcoming ESMO meeting. So we will leave an additional piece of information about the ability of ribociclib to prolong overall survival. Now, I cannot anticipate embargo results, but I strongly suggest to you to pay attention to this interesting upcoming presentation. Now, the development of endocrine resistance is a major problem in metastatic breast cancer, and therefore it is of great interest discussing overall survival data according to the presumed endocrine treatment resistance of the patient population. As we've already seen, 4 trials did include patients that are theoretically somehow endocrine treatment resistant. The Mona Lisa 7, the Mona Lisa 3, the Paloma 3, and the Monarch 2 trial. Within this endocrine treatment resistant population, each trial has a further subgroup of patients according to the response to prior endocrine treatment. And this has generated confusion since each trial used a different definition for the same patient subgroup. I will try to clarify this issue. I will first draw your attention on the Monarch 2 trial here in the right of the slide, which is the only one that uses the standard definition, that is the ESMO ABC definition. According to this, definition, which I reported in terms of timeline in the bottom part of the slide, they define the primary resistant 2 patient population. The A population, this one here, which included a patient who relapsed during the first 2 years of their adjuvant treatment, very early relapsers. And the B population, this one here, which included a patient who progressed during the first 6 months of their first line endocrine treatment for metastatic breast cancer. So they are both included in the Monarch 2, and they are correctly defined as primary resistant. As you can see from the table, however, these same patients were more generically defined resistant in the other trials. The A and B population in the Mona Lisa 3 trial, the A and B population in the Paloma 3 trial, and only the A population in the Mona Lisa 7 trial. But these are all primary resistant patients according to ESMO ABC definition, the one used in the Monarch 2 trial. Now, overall survival data have been recently provided for these patient subgroups, and we may therefore compare how differently CDK4/6 inhibitors performs in this difficult patient population. Well, overall survival data in the primary resistant population are reported in this slide, and as can be seen, hazard ratio indicates that either ribo in both Mona Lisa trial here or Abima in the Monarch 2 trial here seem to improve overall survival in this difficult patient population. Again, this is the primary resistant population, while palbo here does not. Be aware, however, these are of course across trial subgroup analysis that are descriptive in nature. Therefore, in the absence of a direct head-to-head comparison, this cannot be taken as a certain evidence of a different effect among drugs, but it's a signal anyhow. An interesting question is whether these results apply also to patients with the central nervous system metastasis. And this is because pivotal trial systematically excluded a patient with the CNS mets during enrollment. Let's have a quick look. Abima can boast some data on CNS mets coming from a phase 2 trial. See the right table in this slide. And although the study, this is important, did not meet the study's primary endpoint, here we reported a 5.8% of intracranial response rate, which, however, looks promising in such an heavily pretreated population. Of note is that the only pivotal randomized trial that have allowed patients with stable CNS mets to be enrolled is the Mona Lisa 3 trial here on the left. However, only 8 patients were enrolled, 6 in the ribo arm, the first 6 here, and 2 in the placebo arm. And as can be seen in the left table, all but 1 patient treated with the ribo experienced a partial response as a better overall response, with 3 of them still being alive at the time of this analysis, while all the 2 patients assigned to placebo here did experience progression of disease as a best overall response. This suggests that ribo may be an active treatment in this patient population. Additional data on the use of ribo in these patients are available from the phase 3B trial, Complement 1, in which 51 stable CNS mets patients were enrolled, and data on the first 35 patients have been presented at the last San Antonio Breast Cancer Symposium. And as can be seen here, this data show that there seems to be no difference in the objective response rate and in the clinical benefit rate between patients with the CNS mets, the light blue bar in the graph, and patients without CNS mets, the dark blue bar. This data lend further support to the use of ribo in patients with the central nervous system metastasis. Now, in a disease that is essentially chronic, patients' quality of life is paramount. And from this perspective, recent pooled data from the Mona Lisa 2 trial are really supportive. As you can see from the slide, if we look at time to deterioration of the global health score, health-related quality of life score, as derived from the ORTC questionnaire, we see how it is improved for patients taking ribo as compared to placebo, with time to deterioration to more than 10% that appears delayed in ribo-treated patients, the blue curve here. This effect is on quality of life is even more striking if we look at the Mona Lisa 7 trial, the trial enrolling only premenopausal patients. Look at here. This is to me very important, since younger patients are usually more demanding in terms of quality of life. Now, I would like to show how ESMO, building up on the results of randomized controlled trials on CDK4/6 inhibitors and using clinical judgment in addition to formal statistical testing, has tried to guide the clinical decision making by generating this magnitude of clinical benefit scale. The ESMO magnitude of a clinical benefit scale, for those who are not familiar with it, uses a rational, structured, and consistent approach to derive a relative ranking of the magnitude of clinical meaningful benefit that can be expected from anti-cancer treatment, with rank 5 being the highest possible ranking. And as you can see, as long as HR positive, HER2 negative advanced breast cancer is concerned, the only treatment to reach so far the highest ranking here in the table is ribociclib, with the other CDK4/6 inhibitors, stopping for now at rank 4, which is not bad anyhow. Before changing topic, I would like to summarize in just one slide the overall survival results of CDK4/6 inhibitor in metastatic breast cancer. I have therefore generated this snapshot table representing the overall survival results in various patient populations. As can be seen, ABIMA is able to improve overall survival possibly, but not clearly in premenopausal patients, while the results are clear for postmenopausal patients, resistant population, and in combination with fulvestrant. But it's not clear whether ABIMA improves overall survival in combination with an AI and in the AI-sensitive patient population. Palbociclib does not significantly improve overall survival in any patient population so far, at least according to the formerly planned analysis. While ribociclib is the only CDK4/6 inhibitors to consistently improve overall survival in all relevant patient population, either premenopausal or postmenopausal in combination with an AI or with a fulvestrant in the AI-sensitive or in an AI-resistant population. And I believe that this consistency is the most compelling evidence supporting the use of ribo to improve overall survival in metastatic breast cancer patients. And we look forward to the release of MONALEESA true overall survival data soon at the upcoming ESMO to have complete evidence about the ability of ribociclib to improve overall survival. In the last remaining minutes, very few, let's now switch to the more recent advances related to PI3K inhibitors. PIK3CA, the gene encoding for the PI3K molecule, is the most frequently mutated gene in breast cancer, and its alteration has been extensively linked to a dismal prognosis. And given the biological importance of these mutations, PI3K inhibitors have been intensively investigated in this therapeutic setting. But among these, alpelisib is currently the only PI3K inhibitor approved for use in patients harboring PIK3CA activating mutations. And its registration is based on the results of the well-known SOLAR-1 trial, whose design is reported here. And very briefly, patients with both PIK3CA mutant or wild-type tumors were separately enrolled into the trial and were randomized to receive fulvestrant plus placebo or fulvestrant plus alpelisib. The primary endpoint was PFS in the PIK3CA mutant cohort of patients. The results showed a clear-cut improvement of PFS for patients receiving alpelisib in the PIK3CA mutant cohort, here the left graph, with an hazard ratio of 0.65, which is both statistically and clinically relevant. At the last ESMO, overall survival data were presented, and despite a numerical improvement in the overall survival, the difference did not reach statistically significant. However, the trial was clearly underpowered for such an analysis. And what is interesting to me is that the overall survival improvement was more remarkable in the population of patients with the lung and liver mets here in this curve, who have generally a dismal prognosis. And in my opinion, these overall survival results, although a little below our expectation, entirely support the importance of alpelisib in the treatment of HR-positive, HER2-negative, PIK3CA mutated metastatic breast cancer. Now, the time is over, and I would like to draw some conclusion. Well, ribociclib, palbociclib, and abemaciclib have a remarkable preclinical and pharmacological differences that may well explain the partially different clinical results. Ribociclib and abemaciclib have demonstrated significant improvement in overall survival. Ribociclib showed, however, a consistent clinical benefit across patient subgroups, including endocrine-resistant or sensitive population, and also preliminary interesting results in CNS Mets patients. Ribociclib was associated with improved or maintained quality of life, and so far is the only CDK4/6 inhibitor to reach level 5 in the ESMO EBC magnitude of a clinical benefit scale. PI3K inhibitors, for the PI3K inhibitors, alpelisib improved the progression-free survival in patients with PIK3CA mutated, HR positive, HER2 negative advanced breast cancer, and showed a trend to improve overall survival, non-statistically significant, particularly in patients with visceral metastasis. I would like to stop here and thank you all very much for your kind attention. I'll be happy to take some questions from the audience.
Can you hear me? So thank you for extensive review of the subject. Now, in one of your slides, in early slides, you warned us not to try to compare across trial because there is difference in entry criteria and the characteristic of patients in each trial. So, and if you look at hazard ratios, at least looking at PFS, we see uniformly and amazingly, they're all about the same. So my question to you, I mean, we don't want to act, I know sometimes we speak on behalf of drug companies. I agree that the survival data shown so far is impressive, but we don't want in a way also to be more brainwashed by, specific slides that try to say one is definitely better than the other. I think, or we can conclude that with the current evidence, that's what we have, short of doing a head-to-head comparison. In fact, I mentioned earlier that Hope Rugo did an analysis where she tried to control for as much as possible for variables, and whether you look at PFS and OS, they were actually equivalent. So what's your comment on that?
You are completely right, and of course I agree with you that we should be should avoid to stretch too much data. But indeed, I see a strong consistency for ribociclib in improving overall survival in any patient population, while I see that other compounds like palbociclib suffers when we deal with the overall survival analysis. Of course, this may be, at least in part, explained by the different patient population included into the trial. However, how can I say, this may be true for one trial, but if you put all the information together and have a drug that consistently gives results and another one that consistently suffer in giving such results, take into consideration that they both improve progression-free survival in the same way. If I had to use one on myself, I would prefer using the one that more consistently show an overall survival improvement. And this is it. It's not just saying that we have a direct comparison demonstrating the superiority of one against the other. But you may never have a direct comparison between drugs, but nevertheless, you have to make choice in the clinical practice. And again, if I had to use on myself, I would prefer using the drug that improves overall survival, improves progression-free survival, and also maintains or improves quality of life. I don't think that I could expect a better drug when I have all the three endpoints met.
And then other question on second line, of course, the alpelisib data looks impressive. So compared to what we used to do, which is the mTOR inhibitor plus endocrine therapy, considering potential toxicities of each drug, how would you sequence these agents in later lines?
Of course, for patients that are relatively endocrine sensitive, I would elect using first-line CDK4/6 inhibitors and in combination with an AI, of course, as long as the patient has also a PIK3CA mutation, and preserve the combination of alpelisib and fulvestrant for the second line. For the other patients, the wild type, there is absolutely no place for alpelisib. But for patients that are relatively sensitive to both, if they correspond to the inclusion criteria of the Paloma 2, Mona Lisa 2, and Monarch 3 trial that are relatively endocrine sensitive and therefore may use a CDK4/6 in combination with an AI, I would elect using CDK4/6 first line for two reasons. First, because it's better tolerated. And second, because at least for some compound, higher evidence of an improvement in overall survival. And therefore, preserve the alpelisib for the second line combination with fulvestrant. If I have a patient which is relatively resistant to AI, and therefore I should use the combination with fulvestrant, and the patient has PIK3CA mutation, well, I would still elect using fulvestrant in combination with CDK4/6 inhibitor.
I don't know if you have time for another question, but I would like to ask if in patients with metastatic hormone receptor positive, HER2 negative breast cancer with the PI3K mutation, would you consider using mTOR inhibitor with hormonal therapy after progression from alpelisib? And I mean, we don't have enough data on how would it work, what the efficacy is going to be, but I would like to know your opinion and what do you think of, and how was your experience with this sequence? Thank you.
Yeah, you are right. We don't have data right now, and you can put into question whether it's worthwhile using everolimus after alpelisib, since they inhibit the same pathway. However, on an empiric, from my personal experience, and having empirically tried to re-challenge with the mTOR inhibitors after progression on alpelisib, I cannot state, of course, that this is absolutely correct, but I've seen response to treatment. And I believe that this is linked to the use of the mTOR, because you know, in a patient that has already progressed on CDK4/6 inhibitor plus AI, and has already progressed on fulvestrant plus alpelisib, expecting that just exemestane by itself produce some response, I think it's not sustainable. I've seen some responses, but you know, this is a matter of further research, because we strongly need to have a better understanding of what to do after progression on alpelisib.
Thank you so much. Thank you so much, and we'll move now to the next session. تفضل.
Hello.
Assalamu alaikum wa rahmatullahi wa barakatuh, and good evening everyone, and I hope everyone is doing great. My name is Tamer El-Sallab. I'm the head of Gulf and Levant cluster in Viatris. It is my pleasure, and I would like to thank Dr. Al-Shamsi for arranging such a prestigious and well-organized conference and getting us back to normal, connecting with each other. And let me take this opportunity also to thank the heroes in the room and connecting with us virtually. Without their efforts, we wouldn't have been passing this, I would say, very tough epidemic. So thank you so much. Today I'm here to present the story around Viatris. So Viatris is a new company that has been, I would say, formed in 16th of November last year. Viatris came after the integration of two legacies. Upjohn Legacy division of Pfizer, and it has been, I would say, formed a couple of years back with a focus on the non-communicable diseases with medication famous like Lipitor and Viagra. Together, it combined with and integrated with Mylan, a company that is also famous for medication like Riparil and Dymista, to form Viatris. This company has been coming with a very exciting and very promising vision. Let me take you through this vision. We said that this newly organized healthcare company has a very promising vision to make and empower patients to live healthier at every stage of their life, creating and trying to put a balance in a world that has evolving healthcare needs. The name in itself is also promising because it has a different meaning. Via, which is through, and tris, which is the other part of the name, which means three. So we say that we can create and achieve our mission through three passes: access, leadership, and partnership. Access, where we guarantee and ensure medication that can reach patient any place, regardless of the situation and regardless of the place. Leadership, where we want to advance our operation and make sure that we have up-to-date, innovative solution for our patient. And finally, partnership, where we want to build on our expertise and connect people together with medication. This is our mission, and this is how we want to drive our operation moving forward. Viatris also is one of the strongest multinational companies that is existing across the globe, serving more than 165 countries with more than 60,000 customers across the globe, and we're being divided into four segments. We have the developed markets, we have the emerging markets, we have Great China, and finally JANZ, which is Japan, New Zealand, and Australia. Here in the UAE is the headquarters of the emerging markets, where more than 130 countries are operating. Together with that, we have almost more than 1,400 molecules that are divided into different buckets. We have brands that are famous, as I mentioned at the beginning. We have also generics and complex generics. We have over-the-counter medication. We have also ingredients that we sell. And finally, the oncology or the biosimilars, where we focus on different sectors. Oncology, we have also rheumatology, endocrinology, and other very important therapy areas. And today, I'm also very happy to announce that we are launching in the UAE two of the most promising medication, which is Fulphila and Ogivri, to support patients with cancer. Finally, all of that comes with commitment to quality, because quality is the main driver and the main focus where we drive all our operations. And with that being said, I would like to ask you to stay connected with us through different platforms to make sure that you enjoy with us this interesting journey. We will also try to keep you updated with every step that we take to make sure that we empower patients to live healthier at each stage of their life. Back to you, Dr. Shamsi, for introducing our speaker for today. Thank you so much.
Thank you so much. And we'll move now to the next session, which is Fulphila Biosimilar Pegfilgrastim, Improving Access and Optimizing Practice, by Dr. Matthew Apro. Dr. Apro is an oncologist, blood hematologist, and bone marrow transplant. He's a member of the board directors of Girolaz Cancer Center, Switzerland, and the president-elect of the ECC, European Cancer Organization. And he is also a board member of the ECC and serves International Society of Geriatric Oncology as well. Welcome, Dr. Apro, and the mic is yours.
With all of you, many of you I know, both from previous visits to the Emirates, but of course we are facing difficult times all over the world. So my role here is to discuss about pegfilgrastim, and specifically in the symposium, which is supported by Viatris, a company of which you just heard a summary, very brief, because this is a very large, very important company. To tell you about pegfilgrastim, and one of the pegfilgrastim is Fulphila, which is developed by Viatris. So here are my disclosures. As usual, I mention that I have enough company organizations that I work with, that I don't have any conflict of interest. It was mentioned earlier that I hold several positions. Indeed, I'm also in several non-governmental agencies, including the European Cancer Organization. As this symposium is supported by Viatris, I was asked to specify that indeed I have received the honorarium for this talk, and that Viatris does not bear any responsibility with what I'm going to say, which is, however, as you will see, based on the guidelines that have been put forward by the European organizations and also by our friends in the United States and elsewhere in the world, and some other wordings here about the Viatris disclaimer. So what I would like to discuss with you are things that most of you certainly know extremely well, but sometimes you don't realize why, and that's what I'm going to be discussing with you. I'm also going to be indicating that because of the present pandemic, several societies around the world, and as a European, I will be, of course, citing the European Society of Medical Oncology, have modified recommendations in order to adapt to the pandemic. And then I will mention at the end a setting of neutropenia where GCSF should not be used. This is very relevant to talks that you just heard about CDK4, CDK6. That is the situation. And then maybe mention a bit about antimicrobial therapy in the prevention of febrile neutropenia as we go through febrile neutropenia in a couple of slides. So, presentation plan, very simple. A lot of this will be done around a clinical case, which is built a case of several patients that I put together in order to illustrate what can happen, the questions that I receive all the time from my health staff and from colleagues when I make presentations and try to explain them. So a long time ago, in 2010, the European Organization for Research and Treatment of Cancer, EORTC, came out with some guidelines, which were an update of previous guidelines that were very similar to those that have been put forward about at the same time at the American Society of Clinical Oncology by ASCO. And then these guidelines were taken again by the European Society of Medical Oncology, by ESMO, and I will show them to you. So in 2010, we came with the decision tree, which seems to have been relatively popular. It is often used in different meetings still today because it remains valid. What we have to do when we envisage the use of GCSF in a patient is what do we want to avoid? The indication for GCSF is to avoid febrile neutropenia. So we have to evaluate the risk, and there are tables in many websites that allow you to evaluate the febrile neutropenia risk of the chemotherapy if you don't know it. And what I would just like to say here is that all these tables are very valid. However, this is the febrile neutropenia risk in the studies. And it's often not very well reported, and therefore there can be surprises. And we have learned that some chemotherapies like anthracycline, cyclophosphamide gives a much higher risk of febrile neutropenia than what we think about, especially in patients with a certain risk, as indicated here in step 2. When the febrile neutropenia from the study is 10 to 20%, if you increase the risk because of the age of the patient or because of the prior history of the patient having infections, all of that, the risk is going to be much bigger. And then we have to take this into account. And this is also something that we have to deal with right now in the period of this pandemic. Already in 2010, we did indicate that there were biosimilars available in Europe. We had the first biosimilar in 2004, and we had filgrastim biosimilars at the time, and later other biosimilars of growth factors have been introduced. Then the European Society of Medical Oncology came in 2016 with the guidelines on prevention of febrile neutropenia. It's another way of looking at the use of growth factors. And this was done under the leadership of Jean Kastersky, very well known certainly to all of you. And of course, at the same time, ASCO updated its guidelines and several national guidelines were updated. And I'm certain that you must have national guidelines in the Emirates. Then opened the question once again, about biosimilars, even in Europe. As I said, in 2004, we already had biosimilars. Well, in 2019, the last face-to-face meeting in Brussels about biosimilars was held. We have a reference here for those of you interested in all the discussions that went through the day, which gives all the details about biosimilars, how they are developed, how they are produced, why do the regulatory authorities call them biosimilars and not generics. All of this is available for you in this very important document, which is still absolutely up to date, except for some details about development of new biosimilars. The European Society of Medical Oncology decided to react to all the noise made around biosimilars, all the false information, very similar to what you hear nowadays, unfortunately, about the vaccines against against COVID. There were, and unfortunately there still are, lots of somewhat false information or outrageously false information about biosimilars that is circulated. And the position of ESMO is the one that the European Cancer Organization also has embraced totally the ESMO position, as ESMO represents medical oncology, that if a biosimilar is recognized, and we are in Europe, by EMA, which is a European Medical Authority for Medicines, it is a drug that we can use without reservation. We are not calling biosimilars drugs which have not undergone this review or, in some settings, review by FDA. With all due respect for many other agencies throughout the world, the procedures are not as exacting, not as complete as they are with EMA and FDA. That's the reason of our very strong position about what do we call a biosimilar and which biosimilars do we trust. Biosimilar pegfilgrastim, any biosimilar pegfilgrastim, looked at in this paper that we published with Paul Corns not that long ago, tells us that within those countries where access to drugs is limited because of cost, because a reduction in cost entailed by all biosimilars, there's going to be better access. We are not claiming for access outside of the recommendations of EORTC, of ESMO, of ASCO, and other authorities that recognize several things of the kind. But we are clearly saying that in most settings, we are improving access. We are also putting money aside to be used for other drugs, thanks to development of the biosimilars. And as I said, we have enough literature to tell us the biosimilars recognized by EMA and FDA of pegfilgrastim are excellent products. So let me go through a clinical case. This clinical case will illustrate to you some of the questions that I've been asked, or that continue to be asked when I talk about these types of compounds. The first slide here is adapted from a very old paper, which is still valid, from Gary Lyman and his wife, Nicole Kuderer, in Critical Reviews in Oncology Hematology, that looked at the different factors that we can look at when we are determining the risk of a neutropenia in becoming a febrile neutropenia in patients. And look at the left here. The age is there, the low performance status of the patient, issues of the patient with nutrition. We now know more and more about the importance of real cachexia or sarcopenia without cachexia in increasing the toxicity of many of our treatments, not only chemotherapy, also immunotherapy. And then we have some blood tests that can be done that are helpful to know a little bit more about the risk that the patient could have. Then we also know that when the patients have a febrile neutropenia, we have to treat them very quickly. I will come back to this at the end of my presentation. So Mary of Grow, and I say here, yes, it is a false name, because years ago when I used another name, the company said you cannot use a real name of a patient, so I indicated clearly that this is a false name. Here's an example. So this is an example 69-year-old lady. She's diabetic. She doesn't really mind about her diabetes. She does take her metformin pill, but her diet, well, who cares? She's 87 kilograms for 160 centimeters, so it's clearly obese. And she has a history of frequent urinary tract infections. So, provided it is available in the country in which you are, and I believe it is available in the Emirates, can you use preventative GCSF in this setting? Yes, no, will you do it? Well, I will not be able to discuss this with you because of the setting in which we are, but I will also ask you, are you going to use 3 to 4 days of GCSF, 5 days of GCSF, 6 to 7 days, or as per label until after the major? So let's see. Because of her age, I indicated already earlier, because of female gender, all studies indicate that she's a higher risk. We also now have evidence that EC indeed entails a higher risk. Especially she has also this history of urinary tract infection. So you don't want this lady to go into neutropenia, have a severe urinary tract infection and febrile neutropenia, and possibly risk her life in an adjuvant setting. Then what about the day in which you're going to use it? I'm here again indicating that the question in many countries now throughout the world is solved by the fact that we have access to long-acting GCSF, pegfilgrastim, single injection. We'll discuss when to do it. We'll solve this question of how many days, because we have ample evidence that we reviewed in this paper that shows that 5 days that many use is more or less okay. But if you start to dig and if you start to look at studies that compared 5 days to long-acting, you realize that 5 days isn't really enough. Fortunately, it's enough for many, but unfortunately, some rare cases, it will not be enough. And therefore, this is not what is recommended in the guidelines. So why not think of pegfilgrastim? So the lady started with daily GCSF. She tolerated without much bone pain, but she said, coming back for her second cycle, oh, doctor, those daily injections, what a nuisance. So what are you going to do? I'm going to tell her, okay, lady, this went very well, no problem, sorry for the injections. So let's forget about the GCSF during the second cycle. Or you're going to tell her, well, we have data to say that, no, you have to continue. And maybe you could suggest a long-acting, a single injection, a pegfilgrastim, like full filler or others if available in your different settings. And if you're going to use a long-acting agent, are you going to inject it on the day of chemotherapy? It would be so much easier, wouldn't it? Or 24 to 72 hours later, or a week later when she returns for control. So we do have evidence to have an answer for this. So the first point, are we going to stop? We have a major study published already in 8 years ago by Arts and colleagues from the Netherlands, a study done on the request of the Dutch authorities to prove that even if your first and second cycle go well with GCSF, you have to continue with GCSF, because if you stop, as you can see here, the blue column, then you'll be having quite a few cases of febrile neutropenia with the same chemotherapy. So that's the reason why you should continue with the same chemotherapy, even if everything went well on cycles 1 and 2, with the protection for the patient. Then here's the parenthesis. Here's the parenthesis about COVID. This is the position of the European Society of Medical Oncology. Everything is on the excellent ESMO website. And what ESMO and others, as I indicated, ASCO, for example, indicate is that if you don't need to use a neutropenic regimen, don't use it. But really, in the curative setting, often we have to use a neutropenic regimen. Expand the GCSF prophylaxis to any patient at the low risk, 10 to 10%, provided again that your authorities allow you to do that. Expand, contrary to what has been recommended, the use of antibioprophylaxis in some specific settings which are left to your own judgment. For example, our friends in hemato-oncology do use sometimes antibioprophylaxis on top of GCSF for certain of their patients. And then use a mask index, I will come to this at the end, in order to define whether or not you want to hospitalize the patient or avoid the hospitalization and even avoid the emergency room if possible for the patient. Day 1, day 2, day 3, it's day 1 or day 2 or day 3, not day 0. You have less activity if you use it on day 0, and not day 7. It's absolutely without interest for the patient. It's too late. So the lady accepts to have a single injection, and her GP calls you on day 10 because she went to see her the GP because of the hypoglycemia, and the neutropenia grade 4 is observed as the GP run a complete blood count. So what are you going to say? To start short-acting G-CSF immediately because it seems that the long-acting is not acting, or explain to the GP that no, don't worry, this is okay, and call the patient to reassure her. The answer is here. The comparative studies that have been done with the pegfilgrastims and the originators all show that there is a period of neutropenia. It's shortened. It is not as deep, but there is a period of neutropenia in this patient. If you do the counts on day 7, 8, 9, 10, depending on the type of chemotherapy, you will sometimes hit neutropenia. It doesn't say that the long-acting is not acting. It is acting, but it takes some time. So what about the risk of overshoot? And many say, oh, if I give this injection, it's going to be an overshoot. Well, the overshoot is actually seen when you use filgrastim daily for 11 days, not when you use pegfilgrastim. Why? Because the white blood cells that come out are going to metabolize the pegfilgrastim, it will disappear from the blood and will be not stimulating the production of white blood cells anymore. Just a point about febrile neutropenia. We always insist with our patients that if they have to go to another center because of suspicion of febrile neutropenia, they have to tell the team that is getting them into that center that this is an emergency. And this is very nicely highlighted by Jean Plasterski's ESMO clinical practice guidelines. There's enough evidence to say that this is an emergency, that these patients, you need to deal with them within the hour. The more you prolong the time, the more the risk that the antibiotics are going to come too late and the patient is going to have a sepsis. Which antibiotics? It depends on the environment in which the patient is being treated. So therefore, you have to know the environment in which you are treating your patient in order to recommend the appropriate antibiotic. Hospitalize, not hospitalize. If possible in your country, use the mass predictive model. Here it is, and certainly you all know it, published by Jean Plasterski already 20 years ago. A very simple clinical method to decide whether the patient is at a high risk of a complication or not. And the recommendation of ESMO is today to use this in order to decide whether to hospitalize the patient or not in overburdened hospitals because of the pandemic. So my take-home messages: G-CSF usage according to guidelines can prevent febrile neutropenia. We nowadays support liberal use of G-CSF during the pandemic. I did introduce to you the fantastic paper of Maria Cazzaniga in Breast Cancer Research and Treatment, 2019, showing why you should not use G-CSF prophylaxis for CDK4/6 inhibitors. As soon as you stop these inhibitors, the white blood cells are going to start coming up. You don't need G-CSF. And antimicrobial therapy is not recommended except in this particular setting, in some exceptional settings for which there's no clear definition in the ESMO guidelines. So thank you very much for your attention, and hopefully see you on site in the Emirates very soon when things will be much better for you and for us here in Europe and throughout the world. Thank you very much for your attention.
Thank you so much, Dr. Apro, for this very comprehensive review for the febrile neutropenia. The only comment I may have is that, you know, the liberal use of G-CSF during pandemic could be a challenge with the insurance company because they don't really identify the pandemic as an indication for liberal use of G-CSF support, but certainly that, you know, maybe we're a little bit more using than what we did before, but also we have to keep very mindful about the cost. I'll open the floor now sorry, Dr. Apro, any comments about that?
No, that's why I said, if available, it's possible. If this is a recommendation, I know that many countries it's difficult, but in high-risk patients, we still can convince, even in Switzerland, where we have very conservative insurance companies, that this is recommended, that's it, period, no discussion, this is an emergency.
Dr. Ghazal, by default.
Yes, thank you for a nice talk. My concern when you're giving, you mentioned the example of AC, which is now most of the time we're giving it in a dose-dense fashion, meaning every 14 days. So if you are giving your shot on day 3, many times by day 14, you're still having some effect or remnant effect from the drug. Plus, whether we like it or not, there is more bone pain, certainly, and some women has to take narcotics sometimes to really control the pain. It doesn't happen in all patients. So how, is there danger? We know before that if there is still some residual growth factor effect and you're giving your chemotherapy, theoretically you may causing some damage to stem cells. Any concern about that?
You're absolutely right in raising this question. However, all the recommendations today indicate that an every 14-day interval is acceptable. And indeed, if we inject on day 3, we're not even really at a 14-day interval. We have no such concern. And why? Because if the white blood cells have really increased, the pegfilgrastim is basically away. It's not stimulating the progenitor cells anymore for the last few days. What you have is the remnant of the white blood cells that have already been produced, which are not dividing. So we strongly believe that we can use, even on a 14-day cycle, long-acting GCSF. And this is the practice in quite a few centers also, if I understand well, with our friends in the United States and throughout Europe. But it's an excellent question. And then about the bone pain, my experience is totally mixed. Some patients have more bone pain on daily injections, others complain of more bone pain with the single-day injection. Then I switch them to daily, they're less, and then those that have more on the daily have more or less on the daily one. It's a mixed bag.
How about any, I know with radiation therapy, it's usually contraindicated. Any new signals there, especially lung cancer patients who are giving combined chemoradiotherapy? What's your recommendation there?
Yeah, this is indeed something that is embedded in guidelines and comes from a very, very old study, millions of years ago, when there were some more reports of pulmonary toxicity in patients irradiated for lung cancer and also receiving GCSF. This has not really been proven to be valid nowadays. And for this example, discussing Gary Lyman, Gary doesn't believe in this anymore. So we don't seem to have this concern, but it is indeed signaled in some guidelines. We didn't highlight this in the ESMO guidelines.
And then we have a new CDK drug, indicated in, let's say, small cell lung cancer as a prevention.
Absolutely, we do. And this is absolutely, it's fascinating. I've been lucky enough to be involved with the development of this drug, and I'm co-chairing a study in another setting with it. It's a completely different discussion. It has been now approved by FDA. EMA is looking at it. It's absolutely fascinating. I hope to be able to discuss this further with you in the near future.
So my little question was, is it safe, if the patient still is neutropenic, is it safe to administer GSF if they are on anti-CDK?
No, it's not a question of safety. It's the question of, is it useful? The answer is not useful.
Right.
There are no data, none whatsoever to say. All the data point out to the fact that when you stop the CDK4/6 used as it is in breast cancer, you have recovery of white blood cell counts within 2 to 3 days, and there's no need to use a GCSF in those settings.
And what do you think of those injection that you put, I guess, self-injector that deliver the dose 24 hours later? Have you used those?
It's a very, very nice tool in clinical settings in which it's difficult to organize injection at home, for which is very easy for us in Switzerland, but in many countries might be difficult. provided that this injectable tool is not exposed to heavy sunshine, for example, I think it's a very nice way to use the long-acting inpatients for which it's difficult to organize injections at home, which is true in many countries.
Thank you so much, Dr. Ghazal, and thank you, Dr. Apro, for your time and your presentation. Now we're going to move to the next session, and hopefully we'll be able to see you again in person next year. Thank you.
Maybe. Bye-bye now.
Bye. So moving now to the next session with Dr. Aida Al-Awadi, who is a consultant medical oncologist at Tuam Hospital, who completed her fellowship training at MD Anderson and who has been awarded the Member of the Year with EOS because due to her involvement with the EOS at the level of the activities and research. Welcome, Dr. Aida, and the mic is yours.
Okay, thank you so much, Dr. Hamid, and hope you guys are enjoying the conference and getting maximum benefit out of it. So we will move on to the next session, which is on the treatment of early breast cancer spectrum of adjuvant options. And it's such an honor to present to you my mentor and I can call my friend, Professor Nuhad Ibrahim. Professor Nuhad Ibrahim is going to be with us today. He is a practicing oncologist at the MD Anderson Cancer Center in the Breast Medical Oncology Department. Professor Nuhad Ibrahim has been an expert in breast cancer for more than 20 years, has been actively involved in research, clinical trials, and etc. So welcome, Dr. Ibrahim. Nice to have you again with us. And we are looking forward to learn from you.
Thank you, Aida, and it's always a pleasure to be with you. Thank you, Dr. Hamid, for inviting me and trusting me on discussing such a topic, which I feel it is extremely important topic because for very few of you who are old enough, they remember the days when adjuvant chemotherapy started with CMF and it was for 24 months. And now we are into the targeted biological agents. Between then and now, so many changes happened, but most recently, many of them were significant and worth to discuss in the clinic. Let me start with the very important but an easier topic to discuss, which is the Olympia trial, which is multi-center randomized placebo-controlled trial using olaparib in BRCA1/2 mutations, high-risk HER2-negative breast cancer, which I think is going to play a major role in our management of these patients. In this study, they look at patients who receive neoadjuvant chemotherapy, not less than 6 cycles, and they did not achieve a pathological complete remission, or receiving adjuvant chemotherapy, however considered high risk with greater than PT2 or N1, and also received minimum of 6 cycles of adjuvant chemotherapy. And the patients were 1-to-1 randomized to use olaparib for 1 year or a placebo for 1 year. And indeed, it shows that the invasive disease-free survival showed significant difference of 8.8% and the hazard ratio of 0.58. Great results. The type of first invasive disease-free survival is shown in the table, and it shows that across the board it is lower with the olaparib arm compared to the placebo arm, indicating that olaparib was helping in all aspects of the natural history of the disease. The invasive disease-free survival mature data showing that after follow-up, median follow-up of 3.5 years, again, the difference persisted at 8.6%, just confirming the earlier reported results. distant disease-free survival, showing a difference at 3 years of 7.1% and a hazard ratio of 0.57 and a statistical p-value of 0.0001. Overall survival, although p-value looked statistically significant, however, it was not considered so based on the level of p less than 0.01 in alpha spending plan, although the 3-year overall survival rate is 3.7%, which in earlier adjuvant hormonal therapy, this difference was considered a big change and a big difference, and it was a call to change practice in adjuvant hormonal therapy like 15 years ago. The subgroup analysis of the invasive disease shows that it benefited most of the patients, with a borderline benefit from patients who have a prior platinum or were HR positive, HER2 negative. Of course, this does not come without evidence of increased side effects, particularly fatigue, anemia, and neutropenia and leukopenia, which may not be an issue because all were manageable with these patients. A summary of the adverse events, including special interest adverse events like MDS, AML, pneumonitis, or new primary malignancy. Actually, there were no significant difference between the two arms. However, more than a grade 3 adverse event was higher with the olaparib as expected than with the placebo arm. Despite that, it did not change the quality of life of the patient, as showing here, showing that the placebo or the olaparib arm were almost overlapping across the years. The conclusions is that participants of Olympia with high-risk HER2 negative early breast cancer and germline BRCA1/2 mutation had significant risk of IDFS and DDFS event despite standard therapies. Adjuvant olaparib for 1 year completion significantly improved both invasive and distant-free survival. Fewer deaths were reported on olaparib, and toxicity was limited and manageable. And germline BRCA1 and 2 sequencing is an important biomarker in early breast cancer, and this opens a new highway of whether to test everybody for BRCA1 and BRCA2 if are triple negative to see if they benefit from olaparib, particularly that it seems that to improve the natural history of this cohort of patients or group of patients, and I am supportive of that. The second thing that I wanted to bring it up, and also it changed a little bit the landscape, not a little bit, but significantly, little does not diminish the importance, is the use of pembrolizumab with chemotherapy versus placebo chemotherapy, followed by adjuvant pembro versus placebo. And I brought it because of the adjuvant pembro versus placebo in early stage triple negative breast cancer. As you all know, pembrolizumab shows anti-tumor activity in metastatic triple negative breast cancer. And in the Keynote 522, early results showed that the addition of pembro to platinum-containing neoadjuvant chemotherapy resulted in a statistically significant improvement in PCR and favorable trend in effective-free survival. And this update of the Keynote 522 is shown here. The scheme of the study is looking at patients who are newly diagnosed triple-negative breast cancer, and tissue sample for PD-L1 assessment was required, but it was not necessary to put the patient on the study. The patients were randomized 2-to-1 to receive carboplatin paclitaxel, followed by doxorubicin, epirubicin, and cyclophosphamide. The two combination regimens were given together with pembrolizumab 200 milligrams, and the other arm with a placebo. And following surgery, the patient follow on pembrolizumab or a placebo. The earlier results showing that it indeed showed significant improvement in the PCR with a difference of 13.6 and highly statistically significant p-value, and the first event free survival analysis also showed that the difference of about 6% at 18 months. Really, it was a very positive early indicators that the study is heading towards more good news in the future. Excuse me. Indeed, the event-free survival at the fourth interim analysis showed that the event-free was difference was about 8%, and the hazard ratio of 0.63 and the p-value of 0.00031. And the subgroup of patients analysis shows that most of the subgroup of the patients really benefited from the pembro and the chemotherapy versus the placebo and chemotherapy, and as is shown in this forest plot. The event-free survival, however, by PCR showed that if a PCR was achieved, there was not really benefit as is shown in the top two curves. However, if a PCR was not achieved, the benefit of the pembro was significant with a difference of about 11%. Overall survival, however, is not showing yet any statistical significance, although the trend is showing up, and we hope that with the future follow-ups, the curves continue to separate. I intended here to focus on the treatment-related adverse events in the adjuvant phase, and although it shows that the pembro added side effects such as arthralgias, rash, and the pruritus, but it was very well tolerated. And the difference between the two groups is not very much different, 53 or almost 54 versus 39% of the patient. The immune-mediated adverse events, including hypothyroidism, which we see more often with these medications, pneumonitis, hyperthyroidism, adrenal insufficiency, and myocarditis were very minimal, although we see more frequently with the pembro arm than with the placebo arm. So the summary of this study is that Keynote 522 is the first prospective randomized placebo-controlled trial of pembro in early triple-negative as neoadjuvant and adjuvant setting. The neoadjuvant pembro and chemo resulted in statistically significant and clinically meaningful increase in PCR, and neoadjuvant pembro plus chemo followed by adjuvant pembro showed statistically significant and clinically meaningful improvement in event-free survival. There is a trend in favor of overall survival with the pembro, and the follow-up is pending, and safety was consistent with the known profiles of each regimen without any real hurdle. So really this changed our practice at MD Anderson, and now all patients who are starting on neoadjuvant chemotherapy, we are favoring this regimen as our new standard. This brings us to the adjuvant anti-HER2 options, and the landscape here of the use of anti-HER2 is changing, and many times it's creating some confusion, not to the significance of the data, but to its implementation and what to do. And I think, although I always think that, oh, HER2 positive is easy to treat, but sometimes it may take more deeper thinking to see what you want to do with this patient. And I'm going to go over with you with a few of the things that come across my mind in the clinic. First of all, we were first to report from our department that was a very early study, as you see in 2009, showing that the patients who are with small tumors, 1A and 1B, and having HER2 positive versus HER2 negative, at those days we used to consider that these are very good prognostic patients and no need for treatment for them. It shows that the recurrence-free survival was significantly different in favor of the HER2 versus the HER2 negative versus the HER2 positive, 93.7 for the HER2 negative and 77.1 for the HER2 positive. This kind of not surprising, but the differences were really significant to focus attention on this group of patients, and other studies coming that were along the same lines. And also looking at the disease distant recurrence-free survival, it also shows similar trend, 97.2 at 5 years for the HER2 negative versus 86.4 for the HER2 positive. It means that these patients may need more help. And this help really came from Dana-Farber, where Dr. Sarah Toleni championed a huge study in its significance, looking at those patients with paclitaxel and trastuzumab in node-negative HER2 positive tumors, 12 weekly doses of Taxol and Herceptin, and to see that indeed it showed, it broke the code here and moved up the 3-year rate disease-free survival to 98.7 and the 7-year survival to 94, which were at its best at baseline with no treatment for this group of patients. At best, it was 85%. A significant change and a call, and it was a call for a change of practice for very small tumors, node negative and HER2 positive. And now our standard of care is to use the same regimen, which is weekly Taxol and Herceptin for 1 year. Weekly Taxol for 12 weeks and the Herceptin for 1 year. Now, came the attempted trial. Also, the PI was Sarah Toleni, trying to improve on that. Because now we have TDM1, and the study was randomized between TH times 12 followed by 1 year of Herceptin or TDM1 every 3 weeks, and it did not show much of a difference between the two groups, and paclitaxel plus trastuzumab at this point in time remained the standard of care for these patients. This makes us move now to the dual inhibition of HER2 in patients who have larger tumors, and particularly node-positive tumors. And this brings us to the TIFINA trial. A reminder of the plan is FAC times 3, then docetaxel times 3 with Herceptin and pertuzumab cycle 1 to cycle 6. Notice there is no continued adjuvant. FAC cycle to 1 to 3, then THP for 4 to 6 cycles, or TCHP for 6 cycles. And again, the dual inhibition was during the active treatment with cytotoxic therapy. And indeed, the 3 arms really did not show much difference. As you can see, they were all overlapping. However, it was significant for PTCH that has significant less cardiac toxicity, which is welcomed and an eye opener for future consideration of treatment options with some of the patients that will come to a little bit later. Then the affinity trial came to look at chemotherapy plus trastuzumab and pertuzumab versus chemotherapy plus trastuzumab and the placebo. However, here is using the anti-HER2 treatment for 1 year, a continuation after the chemotherapy which would be at the discretion of the treating physician, could be anthracycline based or non-anthracycline based, and also freedom of use, the taxane of choice. But again, it was an important study too. And I'm here putting down the 6-year follow-up that was recently published by Martin Picard, and it's showing that the overall survival was not really very impressive, with only about 1% difference between the two groups. Here, look, we're talking here about pertuzumab and trastuzumab versus trastuzumab alone in the adjuvant setting. And the invasive disease free survival, again, showing a shy 3% difference between the two groups at 6 years of follow-up, with a hazard ratio of 70.76. However, with the axillary node positive patients, it showed that at 6 years they were showing some benefits of 5 percentage point. The hazard ratio is 0.72, as well as with the axillary node negative, the curves was completely overlapping, indicating that any benefit from this is probably coming from the axillary positive lymph nodes. When looking at the HER2 negative versus the HER2 positive, and again, the hazard ratio was not significant for the two groups and did not show any differentiating points in terms of how to use this regimen. So the author's conclusion was that dual HER2 blockade with adjuvant HP has not demonstrated overall survival benefit. Data for improved invasive disease-free survival at 6 years strengthened that invasive disease-free survival benefit was driven by the node positive cohort. No evidence to justify routine use of dual anti-HER2 adjuvant therapy for patients with node negative, early stage HER2 positive breast cancer, and HR status unlikely to impact magnitude of benefit, and very low rates of cardiac adverse events. The pros and cons of this study is indeed it's a high quality of evidence supporting IDBS benefit of adjuvant dual HER2 blockade and long-term follow-up demonstrating very low rates of cardiac adverse events. However, the benefit limited to node positive patients, but may certain subgroups of node negative disease benefit. We don't really know. The duration of adjuvant dual anti-HER2 therapy. And I think if we intend to use it, the majority of evidence is for 1 year, but again, it's question open to discussion. And also the cost always is on mind, particularly in countries where, including US, where resources are really dwindling to support very costly options. So as part of a discussion that I put it in front of the group, not expecting from me answers, but just to keep thinking about it, is how do we interpret these results in the context of most patients receiving neoadjuvant dual HER2 blockade? And I will come back to this question a little bit later. In patients who attain a PCR with neoadjuvant therapy, should we consider less intensive adjuvant therapy? Again, it depends upon the neoadjuvant support, and we will discuss a little bit later as well. What is the relevance of adjuvant trastuzumab and pertuzumab in light of the Catherine trial, which I will be discussing next? The Catherine trial, which first presented 2 years ago, looking at trastuzumab Emtansine, TDM1, versus trastuzumab and the adjuvant therapy in patients with HER2 positive early breast cancer. Now, if we were struggling about the use of pertuzumab and trastuzumab versus trastuzumab alone in the earlier trial, now we're looking at a similar trial, but did not compare to the right arm, which is a dual inhibition. This probably go back to the time of the design of the trial, and it was unpredictable of what would be the new potentially new standard of care arm, and that's why at the time of the design of study, trastuzumab adjuvant therapy was the standard of care and continued to be the standard of care in many clinical situations. So the design of this trial looked at patients who have neoadjuvant therapy, could be anthracycline based or not, but they should have in the adjuvant setting at least HER2 targeted agent for at least 9 weeks. And patients who has residual, I put it on residual invasive tumor in breast or axillary lymph nodes, were randomized to DM1 for 14 cycles or trastuzumab Q3 weeks for 14 cycles. And again, the common denominator between this study and the previous study is at least they both going after a certain subgroup of patients who have residual disease, including axillary lymph nodes after a neoadjuvant chemotherapy. Invasive disease-free survival showed a hazard ratio of 0.5, which outperformed the statistical design at the p-value of 0.0001, which was in favor of trastuzumab. Was in favor of TDM1 versus trastuzumab option. The first invasive disease-free survival event are showing here, and interestingly, there are more numerically incidence of CNS in the TDM1 versus trastuzumab, and still we don't know the clinical implication of these findings. But definitely this we need to keep track of this, and I'm very interested in this point, particularly because I am very interested and involved in CNS metastatic management. Recurrences, again, showing that TDM1 was in favor of trastuzumab with a hazard ratio of 0.6. And this is quite a significant improvement for TDM1 over trastuzumab. Overall survival, there is no benefit is shown yet, and I think we need also, like previous studies, also to keep an eye on follow-up with the overall survival of the patient. Its safety overview was not surprising. We expected more side effects with TDM1 versus trastuzumab. However, otherwise there is no any red flag there. We see with TDM1 more thrombocytopenia, hyperbilirubinemia, and smaller percentages of liver function or neuropathy issues. The all-grade adverse events greater than 15% in each arm is highlighted here, and is showing more, although the numbers are very small, with fatigue, nausea, thrombocytopenia, and liver function, as well as neuropathy. So the Catherine summary and conclusion showing that adjuvant TDM1 demonstrated statistically significant and clinically meaningful improvement on invasive disease-free survival compared with trastuzumab. 3-year invasive disease survival improved from 77 to 88%, a difference of 11.3%. Benefits of TDM1 was consistent across all key groups, including HR positive, residual disease, and single or dual HER2 targeted therapy in the neoadjuvant therapy. Safety was very acceptable, and the Catherine data will likely form the foundation of a new standard of care in this population of increased the use of neoadjuvant therapy in HER2 positive. And indeed, our practice at MD Anderson, as you all know, a majority of the patients will go as standard of care neoadjuvant chemotherapy with a dual inhibition of HER2. anthracycline or non-anthracycline regimen, and those patients who achieve PCR will continue on the dual inhibition, and those who do not achieve pathologic remission will be given the option of TDM1 for as an adjuvant setting. The follow-up on Catherine trial is trying to figure out what are the markers that will help in addition to the residual node-positive disease or residual breast disease, a marker that will help determine which patients may benefit from that. Again, as a fresh reminder, that invasive disease-free survival improvement was very significant. And the outcome, not going through the details of the study, showing that there is no relationship between biomarker expression and invasive disease-free survival. The consistent benefit with TDM1 was observed across all biomarker groups, including PIK3CA mutations. But important here is that the high HER2 gene expression was associated with worse outcomes in the trastuzumab arm, suggesting the presence of resistance mechanisms in patients who have residual disease after HER2 targeted treatment in the neoadjuvant setting. TDM1 benefit was maintained in this subgroup, suggesting it may be able to overcome these resistant mechanisms. I think this is a very important comment here, and we indeed do agree with it, and that's why our trend of practice at MD Anderson is patients who are on neoadjuvant dual inhibition and achieve PCR, we continue with the dual inhibition. On patients on neoadjuvant dual inhibition and do not achieve PCR, we give them TDM1 as the adjuvant treatment. This leaves us with a subgroup of patients who do not receive, which I imagine are very few and scattered, get surgery first and come back for adjuvant anti-HER2 treatment because they are HER2 positive but they did not receive neoadjuvant. Definitely, if it's a very small tumors that we apply to Lenny treatment regimen, weekly paclitaxel times 12 with Herceptin followed by Herceptin for 1 year. However, if the disease is greater than 2 to 3 centimeters or node positive, these patients should be offered more extensive cytotoxic treatment, whether the PTCH or anthracycline and PTH regimen, which is dual inhibition for these patients. However, if these are node negative, however, if they are node positive, the question remains, should they receive as an adjuvant in addition after finishing cytotoxic therapy TDM1 or continue with the dual inhibition? There is no data yet to compare the two, particularly the Catherine trial, and as you showed with the last bullet, that there may be an assumption of potential resistance to Herceptin alone, and therefore whether these patients should be crossed over after finishing the cytotoxic dual inhibition of HER2 to TDM1 or stay on the dual inhibition remain to be seen, and there are multiple trials designed to address this question. Last but not least, and forgive me if I'm over time, is I want to mention about the neratinib study, which was studied following 1 year of adjuvant trastuzumab, and the patients go with additional 1 year of neratinib, although it did not show any difference in overall survival, but the 8-year survival rate showed a hazard ratio of 0.47 and a p-value of 0.031, and this is considered in patients who did not have a PCR and are the most likely that would benefit from this extension anti-HER2 would be the hormone receptor positive patient. And last comment, which I did not get over with here, is the use of CDK4 as adjuvant therapy in HR-positive tumors. We are waiting on the FDA before this would be considered as a legitimate option of therapy at the present time. I would stop here, and Ida, forgive me, I'm always over time, but I'm ready for your questions.
Thank you so much, Dr. Ibrahim, for this comprehensive presentation. So we'll open up for the podium for questions. Yes, Dr. Ibrahim.
Hello, Dr. Nuhad. Good to see you. How are you? Dr. Nuhad, now with the new advancement of adjuvant post-residual disease, how are you timing each of these drugs with radiotherapy? You know, how when you have the discussions with Eric Strong, and if you see him, say hi to him for me, please. Thanks.
Yeah. Not with TDM1 because there is no safety data, but with trastuzumab and pertuzumab, we are giving the patients, and usually they take at most one cycle during radiation therapy, and so far we are not seeing any added toxicity from this combination. But definitely, we know there is synergism between trastuzumab and radiation therapy. We don't know of this synergism with pertuzumab, but in favor of a longer duration of response in the adjuvant setting, we prefer not to interrupt the treatment for more than 4 weeks, understanding that with the perioperative and post-operative treatment, it is put on hold. So we don't like to keep holding on the anti-HER2 therapy for longer time. That's why we reinstituted. But if we are planning to give TDM1, then we wait for radiation therapy to finish and start with TDM1.
So you wait for radiation for TDM1. Of course, also in triple negative with residual, if you're planning for Xeloda, we also wait for radiation therapy. And for PARP inhibitors, we're not using it yet because it's not FDA approved. But in those cases, and I'm pretty sure that you had these scenarios with oligometastatic breast cancer, ER/PR positive with residual, is there anywhere you've used any of those PARP inhibitors with radiation, or you always kind of withhold these until radiation is done?
Yeah, we don't use it with radiation. No.
Okay. This is for all the medical oncologists in the country. Thank you.
Yes. Yeah. You know, with the palliative radiation, because you're talking about oligometastasis, usually is a very short duration, so it should not be of a major concern. But definitely, we wait for palliation with radiation when needed, and then we start the olaparib.
Okay.
Hi, Dr. Nuhad. My question is like, if we are using TDM1 in the adjuvant setting, and what about when there is a recurrence? Then how you will go for like anti-HER2 treatment? The patient has used already double anti-HER2 and then TDM1, and with the recurrence, what will be your approach?
You mean when they have a recurrence?
Yes. When they present with the recurrence of the disease afterward, like a stage 4 or the recurrence of the breast cancer.
Well, you have other options like in HER2 that you may use, or clinical trial if available.
Okay. So you will not reconsider challenging with them?
Say it again. Sorry, there is an echo.
Can you raise your voice, please, so you can hear?
Okay. Yeah. So I mean, the patient has used 3 mainline drugs. So in the recurrent setting, would you like to re-challenge, or you will go with the newer agents?
This is actually twofold question. Yes, we use the 3 major guns: Herceptin, pertuzumab, and TDM1. And if the patient is having a recurrence, this is very troubling because it signifies the emergence of a significant clone there, resistant clone there. And our major approach, and we are, sorry for the word, but privileged because we have a lot of of clinical trials, we tend to get the patient on a clinical trial. But outside of a clinical trial, or the patient does not want to go a clinical trial, or is not eligible for a clinical trial, it depends upon when the recurrence occurs. If it is more than 2 years, which may be considered what we call secondary or tertiary resistance, we may re-challenge the patient with the same treatments. Yes.
Okay. I think we have room for one more question.
Hello, Nuhad. Nice
Hello.
to see you. So I have first a live case. Maybe you can see if you will give this patient pembrolizumab. This lady had neoadjuvant chemotherapy before the approval. It's triple negative case. And she had significant residual disease as well. And, usually we give these patients capecitabine. So would you consider that patient for addition of pembrolizumab, knowing she didn't get it in the neoadjuvant setting?
This is a very good question, and it is all over the places. And I know a lot of doctors are using it. The data suggests in the adjuvant setting that you start with the chemotherapy as a neoadjuvant and continue. Therefore, our current patients who already on neoadjuvant therapy that get started before this data, i.e. they are not taking pembro, we are not adding it on midway or later. Is there a benefit from adding it later as you suggested? Really, I do not know. I do not see why the benefit would not be there, maybe less, but definitely I would be open to discuss this with the patient, but definitely the group as a whole, including myself, agreed to apply the data as published on this issue.
Okay.
Thank you. And do you draw the line between when do you do primary surgery versus neoadjuvant by the size of the tumor? Where is your cutoff? I mean, we have seen anything between 2 to 3 is a gray zone. Do you follow any cutoff point?
Again, this is a very important, and we are all, and what you're talking about is de-escalation. And what I do, and I can tell you also what some of my colleagues do as well. What I do, I start with the PTH, give 4 cycles, and assess by ultrasound. And I will not be surprised that quite often I see that the tumor by ultrasound is not there anymore. So I operate on these patients. If there's a PCR, I don't give the rest of the anthracycline regimen, but maintain them on pertuzumab and trastuzumab. If by ultrasound after 4 cycles there is still residual disease in the breast or in the axilla, I will continue with FEC and go from there on as I outlined. After surgery, then if I finished with the 2 regimen, then I will maintain either with pertuzumab and trastuzumab if I achieve pathologic remission, or switch to TDM1 if there is no pathologic remission, assuming emergence of resistant clones. Other colleagues would prefer to use the PTCH, which I don't like because of its toxicity and poor tolerability. I want to remind Ida one day when she was in the clinic, we were discussing this issue, and she used to work with a lot of attendings, so she was seeing both sides of the coins. And when we were talking about it, I don't know Ida if she remembers that, we saw Dr. Hortobaji, and he's a legend, walking in the hallway going to his clinic, and I told him, Gabe, would you do this? And he said, meaning PTCH and avoid anthracycline. He said, hell no. And I could see Ida's eye open wide. Oops, what an answer. I did not even stop to talk to us. He kept going.
So what was the train trial? What does he say now? I mean, you've seen the train trials.
The concern is the toxicity from the carboplatin. Yeah. Besides, without the adjuvant setting, the three regimen are equivalent. And if you're planning to give anti-HER2 in the adjuvant setting, there is where the game changer. Second, although the study is showing that there is more cardiotoxicity, but honestly, at MD Anderson and continue, although we are decreasing in number because of retirement hitting some of us, still believe in anthracycline.
Yes, I mean, this debate can continue forever, actually.
So you don't believe you don't believe in the TRAIN-2 trial? I mean, clearly there was no subgroup analysis that even benefit, a hint of any benefit of anthracycline, even in the node positive. Isn't that enough? Maybe you should talk to Dennis Slayman.
Okay.
Yeah, he wanted to make a landmark. I think MD Anderson was not very supportive of that landmark, and he had a lot of confrontations on the stage with Hortobagi.
Yes, thank you so much, Dr. Ibrahim. I think I cannot end this session without asking actually this quick question. Have you guys started adopting the Olympia trial and olaparib in the adjuvant setting for BRCA patient?
Yes.
Okay. Excellent. Because
we are, and we are pushing to test the patients who does not in the first place would qualify for BRCA testing. You know, sometimes we are successful, sometimes we are not, but if we cannot test for it, we don't add it blindly.
Excellent, yeah. So we have been also testing all the patients in my practice just because of the impressive result of the Olympia trial. Yeah, thank you so much, Dr. Ibrahim, for being with us, and hope maybe we can see you in person next year. Thank you.
Oh, yeah. Yeah, I'm waiting for that.
Yes, absolutely. Thank you so much.
Okay.
Take care.
Okay.
Take care.
Take care. Bye-bye.
Good afternoon, dear all. My name is Hassan Jafar. I'm medical oncology. I work in Sheikh Khalifa Specialty Hospital. So I'm delighted to be here with you today. I would like to congratulate Dr. Ahmed Al-Shamsi and the scientific committee for this really outstanding effort in making this meeting happen, especially with the first virtual and in-person meeting. So we lacked this for a long time. And also, I would like to welcome you all for the Pierre Fabre Symposium. And we are delighted to present a colleague and friend, Dr. Mit'ab Al-Fuhaidi. He's an associated professor. His graduation was from Canada, medical oncology, and he had an extra year with a fellowship in breast cancer, so he's expert in breast cancer. He's also the president of the Saudi Society of Oncology. Also, he's associated professor in the King Saudi bin Abdulaziz University. He has a lot of publication in the field of breast cancer, and also he is the president of the MENA NCCN breast cancer guidelines. Dr. Mit'ab, he will discuss the role of neratinib in the extended treatment for HER2-positive breast cancer in the adjuvant setting. So we would like to welcome Dr. Mit'ab, and we hope to see you probably soon in Dubai.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Thank you so much, Dr. Hassan, for your nice introduction. And really, it's my great pleasure to be part of this really successful meeting. And I will take this opportunity to thank and congratulate Dr. Hamid Shamsi and his group for this really excellent meeting. And really, it's hard to give a talk after Dr. Nohad Ibrahim's, but I will try my best. Also, I would like to thank Beer Fabry for their kind invitation. So Dr. Nohad already set this stage, and he discussed the adjuvant treatment in different breast cancer subtypes. So what I'm going to discuss over the next 20 minutes is the how can we optimize the use of neratinib as extended adjuvant setting. So what I'm going to discuss with you, I think there is two important abstract which was presented at the last San Antonio meeting. The first one is presented by Frankie Anholms, discussing how can we continue or the efficacy of neratinib in patient with HER2 positive early stage. And this is the final overall survival analysis of the randomized phase 3 extended trial. So when we look at the background, we know that the neratinib is an irreversible small molecule TKI of HER1, HER2, and HER4 with established single agent efficacy in trastuzumab pre-treated HER2 positive metastatic breast cancer. We know also that neratinib significantly improved the invasive disease-free survival compared with a placebo when given as extended adjuvant therapy for 1 year in patients with HER2 positive early breast cancer after trastuzumab-based adjuvant therapy. And we know also that in the HERA trial that 2 years of trastuzumab did not significantly improve the disease-free survival compared with 1 year of trastuzumab after a long follow-up. And we know that the neratinib and trastuzumab are thought that they are non-cross-resistant in the HER2 positive population. And this is a really very important point to make. And in the phase 3 extended adjuvant treatment of patients with breast cancer, the neratinib, there was an absolute invasive disease-free survival benefit of 2.5% and distant disease-free survival benefit of 1.7% was observed with the neratinib versus placebo in the intent to treat population after a median follow-up of 5 years. And there was also a more marked benefit in the invasive disease-free survival and the distant disease-free survival, which were seen in patients with hormone receptor positive disease who were randomized within 1 year of previous trastuzumab. So we call it the hormone receptor positive less than 1 year. And the benefit was 5.1% absolute benefit in the invasive disease-free survival and 4.7% absolute benefit in the distant disease-free survival at 5 years. Another important that there was more marked benefit also seen in the high risk hormone receptor positive patient group, those patients who has residual disease after neoadjuvant therapy. So we can call them the hormone receptor positive, less than 1 year start of the trastuzumab and no PCR. And the absolute benefit was 7.4% in the invasive disease-free survival and 7% distant disease-free survival at 5 years. So in the metastatic setting, also we know that the neratinib has demonstrated activity in preventing and treating brain metastasis in HER2 positive metastatic breast cancer. And in the adjuvant setting, we know that there is no anti-HER2 directed therapy which has been shown to prevent CNS metastasis as shown in the ALTO and shown in the affinity as well as in the Catherine trial as mentioned by Professor Nohad Ibrahim. So What about the neratinib and brain metastasis? If we will review the data, so we know that the phase 3 trial, the NALA trial, neratinib and capecitabine significantly reduced the cumulative incidence of therapeutic intervention for the CNS disease compared with lapatinib and capecitabine after 2 or more HER2-directed therapy for metastatic disease. And Nohad Ibrahim is the principal investigator of the Nefertiti trial, which is a phase 2 trial. And the investigator looked at the metastatic HER2-positive breast cancer, and those were treated in the first-line setting. And they found that the incidence of symptomatic or progressive CNS event was significantly reduced with neratinib and paclitaxel versus patients who were treated with trastuzumab and paclitaxel. Another phase 2 clinical trial, the TBC RC00022 trial, they looked at the combination of neratinib and capecitabine, and they found it is an active agent against the refractory HER2-positive breast cancer brain metastasis with compositive CNS objective response rate of 49% in the lapatinib naive patients, so those patients who did not receive lapatinib, and 1/3 or 33% in those patients who were treated with lapatinib. And in the extended trial, the cumulative incidence of the first CNS recurrence at 5 years was 1.3 with neratinib and 1.8% with placebo, and also was 0.6% with neratinib in those patients with hormone receptor positive treated less than 1 year from trastuzumab versus 2% with placebo. So regarding this abstract, the investigator reported the final protocol defined analysis of the overall survival from the extended trial in the intent to treat population. And also they report additional descriptive analysis of the overall survival and CNS outcome in patients with hormone receptor positive tumor who initiated treatment within 1 year of completing trastuzumab. And also they looked at a subset of patients considered to be at a higher risk of relapse, those patients with hormone receptor positive tumor who has residual disease after neoadjuvant therapy. So as you know, the extended trial was a multi-center randomized double-blind placebo-controlled phase 3 trial, which was designed to investigate the extended adjuvant therapy with 1 year of neratinib or placebo after standard of local regional treatment and adjuvant plus or minus a neoadjuvant therapy with chemotherapy and trastuzumab. And the randomization was stratified by locally identifying the hormone receptor status, the schedule of trastuzumab administration, as well as the nodal status. Patients were randomized in 1-to-1 ratio to neratinib at a dose of 240 milligram orally once daily, or a matching placebo for 1 year or until disease recurrence. And the anti-diarrheal prophylaxis, which is very important to remember, was not mandated in the extended trial. And patients with stage 1 to 3C HER2-positive primary breast cancer who received standard local regional treatment and completed the neoadjuvant or adjuvant chemotherapy plus trastuzumab within 2 years of randomization were eligible. And in February 2010, the recruitment was restricted to higher risk patients with stage 2 to stage 3C disease, and completion of trastuzumab within 1 year of randomization, and no PCR for patients who completed neoadjuvant therapy. So in regard to the endpoint, the primary endpoint was invasive disease-free survival, and the secondary endpoint was overall survival and the cumulative incidence of the first recurrence of the CNS recurrence. And they looked also at the CNS disease-free survival, which was defined as time from the randomization to any CNS recurrence or death from any cause. It was evaluated on ad hoc basis. In regard to the statistical analysis, the pre-planned analysis of the overall survival was performed in the intent to treat population, which were powered for 248 event and a hazard ratio of 0.70 with 80% power and one-sided of 0.025. E-type 1 error rate. The descriptive analysis also were performed in the hormone receptor positive less than 1 year population and in the high risk subgroup. And the cumulative incidence of the CNS recurrence was analyzed by competing risk analysis. And the result, 2,000 or 2,840 patients were randomized, assigned to the study treatment, and constituted the intent to treat population. So 1,420 patients per group, and of whom 1,631 patients, which is approximately 60% of the total population, had hormone receptor positive disease. And among patients with hormone receptor positive tumor, 1,334, approximately 80%, had initiated the study treatment within 1 year of prior trastuzumab. And within the hormone receptor positive population, less than 1 year, around 1/3 of the patient, 354, had received neoadjuvant therapy, and of whom 295 patients had residual disease. The baseline characteristic in the hormone receptor positive less than 1 year population and no PCR subgroup were balanced between the two treatment group and was similar to the intent to treat population. The median duration of follow-up for the overall survival was 8 years, and 54% of the patient completed at least 8 years of follow-up. So when we look at the baseline characteristic, we can see that in the intent to treat population, the median age was 52 years. Approximately 60% of the patient had hormone receptor positive disease. Approximately 75% had node positive disease, and 60% of the patient received trastuzumab concurrent with chemotherapy. In the hormone receptor positive less than 1 year population, the median age again was 51, similar to the intent to treat population, and 80% of the patient had node positive disease. And in the no PCR group, again, the median age was 49, and 90% of the patient had a node positive disease. So this is the overall survival in the intent to treat population. We can see that the estimated 8 years overall survival rate was 90.1% in the neratinib group and 90.2% in the placebo group, with a hazard ratio of 0.95 and a non-significant p-value. And when we look at the forest plot in the intent to treat population, the subgroup analysis were consistent with the invasive disease-free survival result. The neratinib numerically improved the overall survival in patients with hormone receptor disease. The 8-year overall survival rate was 91.6 in the neratinib and 90.1 in the placebo group, with a hazard ratio of 0.80. And neratinib did not appear to improve the overall survival in patients with hormone receptor negative disease. The hazard ratio was 1.18. So when the investigator looked at the hormone receptor positive less than 1 year population, and this is very important slide, the estimated 8-year overall survival rate was 91.5 in the neratinib and 89.4 in the placebo group, corresponding to 2.1% absolute benefit with a hazard ratio of 0.79. And when they looked at the patient who has hormone receptor positive disease less than 1 year, and they have residual disease, which was 295 patients, so approximately 300, the 8-year overall survival rate was 91.3 in the neratinib group and 82.2 in the placebo group, corresponding to 9.1% absolute benefit with a hazard ratio of 0.47. What about the CNS outcome? Patient in the neratinib group had a lower number of CNS events in all population, intent to treat population, and those patients with hormone receptor positive treated less than 1 year, and those patients who received a new adjuvant and developed residual disease with no PCR. So the cumulative incidence of the CNS recurrence in the intent to treat population was 1.3% with neratinib, 1.8% with placebo, and this is actually when we look at the higher risk group, which are the hormone receptor positive less than 1 year, we can see it was 0.7 with neratinib and 2.1% in the placebo. Those patients who had no PCR and were treated with neratinib, they developed CNS by the rate of 0.8 versus 3.6% with the placebo. What about the CNS disease-free survival at 5 years? Again, at 98.4% of the patient in the neratinib group and 95.7% in the placebo group were alive and did not report a CNS recurrence with a hazard ratio of 0.4. And the same is true in patients with no PCR. It was 98.4 versus 92% in favor of neratinib. And what about the anti-cancer treatment? They looked at the uptake of the anti-cancer medication during the follow-up. It was balanced in both groups in the intent to treat population, and in regard to the safety, the most adverse event was diarrhea, which has been reduced by the dose escalation strategy. So this is the conclusion of the first abstract, the final protocol defined analysis. There were fewer deaths in the neratinib arm, but it was not a significant improvement in the overall survival in the intent to treat population after 8 years, but there was a suggestion of improved overall survival in patients with hormone receptor positive disease who were treated with neratinib. So this is actually what I think is important to take from this clinical trial, that some patient who has hormone receptor positive, HER2 positive, who completed trastuzumab within 1 year, and those patients who did not achieve PCR after neoadjuvant treatment, and those patients who were treated in the adjuvant setting and have a high risk of disease, we can consider neratinib in their treatment. What about the second abstract? And it's actually looking at the control study. So the diarrhea, we know particularly in the first 1 to 2 months is the main tolerability concern with neratinib, and it's common in the absence of the proactive management. And in the extent trial, there was no mandatory anti-diarrheal prophylaxis was used, and the rate of grade 3 diarrhea was 40%, and it resulted in 17% discontinuation of treatment. So the control trial, which was previously showed that the preemptive anti-diarrheal prophylaxis or neratinib dose escalation reduced the raised severity and the duration of grade 3 or more diarrhea compared with that observed in the extended trial. So the investigator looked at a descriptive how of the complete data for the weekly dose escalation, we call it DE1, and the interim data for the ongoing bi-weekly dose escalation cohort 2. And the key results from the previous cohort studied in the control study are also were presented. So this is the study schema. So the control study is an open-label sequential cohort phase 2 study investigated the effect of different anti-diarrheal strategy on neratinib-associated diarrhea. 500 patients with stage 1 to 3 HER2 positive breast cancer with trastuzumab completed within 1 year received neratinib for 1 year. And in the first cohort, patient received loperamide as shown. And in the second cohort, patient received anti-inflammatory budesonide. And in the third cohort, the patient received bile acid sequestrant cholesterol plus loperamide. And the fourth cohort received the combination of cholesterol and loperamide PRN. Two dose escalation cohort. The first cohort, neratinib, dose escalation 1, where patients were started at 120 milligram on week 1, then 160 milligram on week 2, then 240 milligram through the 1 year, plus loperamide PRN, while in the dose escalation cohort 2, patients were started at a higher dose, 160 on week 1 and 2, then 200 on week 3 and 4, and then 240 milligram per day through the year, plus PRN loperamide. And the primary endpoint is the incidence of grade 3 and more diarrhea. So you can see also that in the dose escalation cohort 1, 3 tablets on week 1, 4 tablets on week 2, and then full dose on week 3 or more, while the dose escalation cohort 2, 4 tablets on the first 2 weeks, 5 tablets on week 3 and 4, and then 6 tablets or full dose on week 5 or more, completing 1 year. So this is the summary of the patient disposition. So you can see at the dose escalation cohort 1, 60 patients were off study and the data presented were complete. And in the dose escalation cohort 2, 62 were enrolled. So 78% in the dose escalation 1 completed 1 year of treatment, 22% discontinue treatment prior to 1 year compared to 39 of patients in dose escalation 2. And we can see also that 24% discontinue treatment and 37% are still on treatment. The median duration for dose escalation 1 was 11.9 months, so almost they complete the treatment versus 9 months in the dose escalation cohort 2. And in dose escalation cohort 1, 92% of the patients escalated neratinib to the full dose, while in the dose escalation cohort 2, 77% did that. So there was no grade 4 diarrhea, and the incidence of grade 3 diarrhea was 13.3 in the dose escalation 1. Remember, it was 40% in the extended, and it was 25.8 in the dose escalation 2. So the grade 3 diarrhea the grade 3 diarrhea in dose escalation 1 was actually 9.6 and there was no grade 4 diarrhea, and the incidence of grade 3 diarrhea was 13.3 and 25.8%. So the median cumulative duration of grade 3 over the entire 12-month period was 2.5 days. So the duration is not that much for the dose escalation 1, and it was 2 days for the dose escalation 2. 11.7 of the patients had at least 1 dose halt in the dose escalation cohort 1 versus 14.5 in the dose escalation cohort 2, and 3.3% in the dose escalation 1 discontinue neratinib. So it was 17% in the extended trial, and 4.8% discontinue the drug in the dose escalation 2. And in all cohorts, the lowest rate of both grade 3 diarrhea and discontinue due to diarrhea were observed in dose escalation cohort 1. And we can see also that 75% of the patient in the dose escalation 1 received neratinib for more than 1 year. So the conclusion, the adoption of neratinib dose escalation reduced the incidence, severity, and duration of neratinib-associated diarrhea in the control compared to the extended trial. The incidence of grade 3 diarrhea was low, 13.3 in the dose escalation 1, and the median cumulative was 2.5 days. Dose escalation 1 was associated with a low rate of diarrhea, rate discontinuation only 3.3%, and dose halt 11.7 compared with all previously mandated prophylaxis strategy. So taken together, these results show the improved tolerability of neratinib with dose escalation cohort 1 or the weekly escalation, and suggest that this combined strategy combined with the loperamide PRN allow patients to stay on neratinib longer, allowing them to benefit from this medication. And the dose escalation cohort 2 is ongoing, and the complete data will be presented later. And with that, I would like to thank you for your kind attention.
Thank you very much, Professor Matab, for this comprehensive overview. I've been told that we are behind the schedule, so we can open the question for a couple of questions before moving. Dr. Hassan.
Thank you, Dr. Matab. So the question, just clinical question, how do you choose your patient based on all the data now with what we saw with TDM1 and trastuzumab and pertuzumab, knowing that when the extended trial was done, it was mostly trastuzumab? So how do you choose your patient? Besides, of course, ER, mostly the ER positive are going to be the one to benefit.
Thank you so much, Doctor, for really this is an excellent question. So I think we can consider the neratinib in the following patient. So first of all, a patient who has HER2 positive and hormone receptor positive patients. So we call them the triple positive or luminal B. Those patients who completed the trastuzumab-based therapy within 1 year. And when I say that, it's including patients who completed trastuzumab and pertuzumab and or even the TDM1. Those patients who did not receive or achieve complete pathological response after neoadjuvant therapy, and also the patient who has node positive and did not receive neoadjuvant treatment. So those patients who were happened to stage 2 or 3 and were going for surgery first. So those patients, we can treat them with neratinib. And this is actually the guidelines in Europe. So they are limiting the neratinib use only for the hormone receptor positive population, of course, HER2 positive. In the state, they also include with that those patients who has hormone receptor negative, HER2 positive, but it's on an individual basis, meaning that in very selected patient, and usually they are selecting patients who have residual disease following neoadjuvant therapy. And just to mention that there was expert panel recommendation, and this recommendation was consisting from really very well-known medical oncologists like Nadine Herbach, Hope Rogo, and this expert panel, they recommended those the selected patient population, and also they recommended that neratinib should be started as in the dose escalation cohort 1. So neratinib 120 week 1, then 160 week 2, then the full dose at week 3 till 52 weeks. And we can use other anti-diarrheal medication, other strategy as well as they also mentioned that the duration of neratinib is very important. So those patients who discontinue treatment within 3 months did not benefit from neratinib treatment, but those patients who at least continue to 11 months, they actually get the maximal benefit from this medication.
Yeah, just one comment. I mean, the ER negative, the theory was, or that's what we hear, that really the TKI, anti-HER2 TKI, they work more to prevent endocrine resistance. And that's why we saw the majority of benefit, or almost exclusively the benefit, was in the ER positive, where the ER negative is a completely different biology. And that's probably why even in the higher risk node negative, we didn't see that benefit in the EXTEND trial. But what I was also getting at to that, how confident are we that we are going to get the same benefit that the EXTEND trial have shown when there was no TDM1 and the majority had no pertuzumab either? That's also another question always been asked.
I think the data is the data, and probably at that time there was no TDM1, but at least we have to extrapolate from what we have. Thank you very much, Dr. Mut'ab, and I really apologize.
Dr. Hassan, can I comment on the last?
Yeah,
so you are absolutely right that we don't have data in the early setting, but as you mentioned, Dr. Hassan, the NALA study actually they included patients who were treated with pertuzumab and those patients who were treated with TDM1, and it showed that even in those heavily pretreated patients, there was benefit from the neratinib plus capecitabine. So this is an extrapolation. Also in the phase 2 trial showed that the neratinib also can benefit even in the patients who were pre-treated with TDM1. In regard to the hormone receptor negative population, I totally agree with you that this is not the bulk of the patient, but I'm saying on an individual basis, so not every hormone receptor negative you will give treatment with neratinib as extended adjuvant treatment, but you might consider it and weigh the benefit and risk from toxicity.
And especially with the interest also for the CNS protection. Thank you very much, Dr. Mut'ab, for this very wealthy information. And we will move on for the next presentation. Dr. Falah Al-Khatib.
This is bring us to the last but not the least session of the day. It's been a long day. Therefore, we'll try and keep it short. It gives me great pleasure to introduce my colleague, brother, and Dr. Ibrahim Abu Gaida, who joined VPS Healthcare System and Berjil Medical City, and leading the newly opened radiotherapy center. He graduated from AUB and then he went to the United States. MD Anderson specialized for his higher specialization, mainly in breast, gastrointestinal, and GU cancers. And he also had he completed a Harvard-affiliated NIH-funded research program as well. He has more than 25 peer-reviewed papers, and he is leading the, as I said, the baby center, radiotherapy center in the Emirates, and we expect a lot from him to develop that center. Rahim.
All right, thank you, Professor Falah, the founder of radiotherapy in the UAE. These are very humbling words, and I will go straight to my presentation. I know we're running late, so thank you for bearing with us, for all the on-site and online attendees. I'd like to thank the Emirates Oncology Society, and I'll go straight to my talk. So as Dr. Falah mentioned, this is a, so I have no disclosures for this talk. this is actually a radiotherapy talk. So, but again, because there are only 2 sessions about radiotherapy, rather than doing it site-specific and keeping it boring, I thought that we'll do it more of a generic one and discuss the basic concepts of very advanced radiation techniques. And I will be setting the ground for the next talk, which is our colleague, Dr. Emin from MD Anderson. So this is, as I mentioned, it's a radiotherapy talk. It applies to all sites, and I'm discussing the basic radiobiological concepts of SRS and SBRT. So how do radiation damage cells? So there are 2 ways. There's the, of course, the direct ways, and there's indirect way. In the direct DNA damage, there are 2 major categories. There's the lethal, which is usually happens when double-stranded DNA breaks. Usually, this is an irreversible damage. And there's the sublethal, when we have single-stranded break, and usually this actually can accumulate and lead to lethal damage. And this is just because this is not a radiobiology session. I don't want to keep it boring for non-radiation oncologists, but this is what we actually see. This is the cell survival curve. This is how we see that, the first part of the curve. I don't know if there's a pointer here or is there a mouse, but you can see that the first part of the curve goes linear, and then it goes more of a quadratic. And this is the linear quadratic model. And the first part is related to the sublethal, and the second part is related mostly to the lethal dose. So what are the basics of radiobiology? And this is very important to understand in order to understand how does radiosurgery differs then. So this is a very basic reminder for radiation oncologists, and maybe a refresher for the medical oncologists, is that, so the 5 R's of radiobiology are the repair. So we know that there is a lot of mechanisms of repair that the cells and the nucleus adopts when it was faced with a DNA damage. And a very, very common clinical scenario is the BRCA1 and BRCA2 mutations. We know these are repair genes that are mutated, and these are predisposes patients to breast cancer and other malignancies as well. Redistribution, this is when we know that the cells inside the tissue or inside the tumor are in different cell cycle phases, and we know that there are some cycles are more radiosensitive than other phases of the cell cycle. Reoxygenation, we know that there is a very important concept in radiation oncology. It's called the OER, or oxygen enhancement ratio. And we see that actually, less oxygenated cells are more radio resistant than more oxygenated cells. Repopulation, this is also a very important concept that we see in clinic. We see it mostly when, for acute normal tissues, this is how they heal. And also this is how the actually treatment breaks, for example, in head and neck cancers, are associated with significant worst outcome. Radiosensitivity is also a very broad spectrum. Again, for the sake of time, I'll not talk about this, but we know that different types of tumor have different radiosensitivity. For example, small cell lung cancer is more radiosensitive than, for example, melanoma and other types of cancers. So what are the arguments supporting fractionation? So the standard or the conventional fractionation, that tells you, so we allow time for normal tissue to repair. It allows times for reassortment so that, cells goes back to a more radiosensitive phase that they can be killed faster. It allows reoxygenation. You kill the outer part of the tumor, and then the inner part becomes more oxygenated. So this is also an argument for that. And also allows repopulation of normal tissues, which allows for healing. So these are the arguments that supports fractionated treatment. However, when we talk about radiosurgery or radiostereotactic, like very high doses per fraction, we might be missing another R. Something, is not right. We do, and the other question is like, does the current cell model really applies for radiosurgery? Is there anything else happening? And what about the tumor vasculature, microvasculature? And what about the immune response and interaction with radiotherapy or radiosurgery? So these are very old quotations. And when initially SRS was introduced, there was a lot of criticism, and a lot of leaders actually criticized that, and they said it's probably a suboptimal way of delivering radiation, and it only adds radionecrosis. We don't see any more benefit. However, 20 years from now, you can see actually, that radiosurgery is able actually to give a very high control for very radio-resistant tumors, and when we give very high doses in one fraction. And the toxicity is actually very well. And this has been proven in brain, and it has also been proven in spine SRS when we do stereotactic radiosurgery, it's very close to the spinal cord, and we can see that we are able to give very high doses, very good control, and minimal toxicity. So why does it work? Okay, so there's a lot of concepts for why does it. So first of all, radiosurgery is usually targeted for small targets. So you can see that, and this is like a very nice diagram that shows you how when you have a slightly larger tumor, the amount of normal tissue being radiated is significantly higher. Does this have a pointer? Yes, it does. So, but you cannot see it because this is an active scene. So you can see that there is a significantly higher normal tissue being radiated. So how does it work? We are definitely doing a better job with radiosurgery. We have improved imaging. We have a lot of improvement in physics. We have a lot of improvement in machine mechanics. And we have a lot of improvement in positioning and image guidance for the patients and treatment deliveries. We are able to deliver a lot of treatment much faster than before. So maybe there is more, how does it work? So it's probably not only DNA damage. There might be some other non-DNA related causes that is causing this. So I will start, this is a very important figure as well that summarizes a very important phenomenon, which is the endothelial effect and the effect of microvasculature by giving very high doses of radiotherapy. So you can see when we give doses of more than 10 gray, I don't know if you can see the last figure on my left hand side. If you look and we give the high doses, you actually activate the sphingomyelin ceramidate pathway. This is a very important pathway that actually activated the Bax protein, releasing cytochromes and inducing apoptosis. This happens in the vascular endothelial cells. So this makes the tumor less viable and more likely to die. Also, when we have a very high doses reaching higher than 17 gray per foreign fraction, you actually also directly activate the ceramide synthase, also initially leading to apoptosis. And we know when we cause acute tumor hypoxia, this also prevents DNA repair, which is extremely important even for cancer cells to survive radiotherapy. So this is again going back to the linear quadratic model. Does this really apply in when we give very high doses of radiotherapy or radiosurgery? So this is a real model that shows you that no, actually. So this is if you can see the graph on the left-hand side, A and B represents the normal linear quadratic model, and in both hypoxic, which is more resistance, and you can see it in red, or versus very good oxygenation schema. However, when you can see that when you have a very high doses being delivered, the actual curves that shows are much steeper than this. So this tells you that there is an indirect way of cell death, whether it's vascular endothelial effect or others as well. So again, very important. We've been listening a lot from our medical oncology colleagues about immunotherapy. How can radiosurgery interact with immunotherapy? So we know that immunotherapy is a very hot topic. Actually, the concept of abscopal effect, and this is a very hot topic in radiotherapy, is when we radiate one area and you get the effect on another area that has never been touched with radiation. And this is actually it's not a new concept. It has been initially described in 1953. And we can see that we are seeing more of this, especially with the era of immunotherapy, when we have very good, powerful immune primers that actually allows us to recognize tumor cells. So how can SRS or stereotactic radiotherapy show this? So this is a abscopal case report. Just for the sake of time, I'm not going to go over that. This is published in the New England Journal of Medicine. Patient with metastatic melanoma received immunotherapy and then got 3 fractions of radiotherapy, and then a significant improvement in their entire body that was initially resistant to the same immunotherapy. So something happened after radiation was introduced to this patient. Another case report by Tang et al. Showing how much, after we do the radiation, there was a significant decrease in disease burden, significant increase in all the radiated site and non-radiated site. And so there was an effect happening elsewhere as well. So more evidence for this. We know that patients with diminished immunotherapy do worse. And even they do worse when we treat them with focal radiotherapy. So why is it patients with weak immunity have even weaker local control? So immunity plays a very important part even in stereotactic radiosurgery. So, and this is actually proven in this article by Vogelbaum. So what should we do? How can we prime our immune system so that, you know, we prime it with immunotherapy, then hit with radiosurgery, and then see the response? And we understand that, you know, there's the tumor microenvironment, there's a lot of immunosuppressive agents around it that allows it to evade the immune system. So we can know that, you know, SRS or SBRT might not be enough. We might need the help of the immunotherapy to have those full effect of the stereotactic radiotherapy as well. And this is actually has been proven because, you know, when we hit very high doses per fraction, again, for the sake of time, I'm not going to overgo this, but we know the antigen-presenting cells become activated. A lot of cytokines are released from the tumor cells. The body starts recognizing those as abnormal and starts attacking them, whether in the primary site that's being irradiated or elsewhere. And this is a very simple, basic explanation of that. Of course, it has more details into that. There are many different types of cells in it. For example, when we radiate doses, there is a lot of dendritic cell migration into the tumor microenvironment, and these actually allows us to have more of antigen presenting cells and eventually have more recognition of abnormal tumor cells and being attacked by the body's own immune system. This is actually in a mouse model where, you know, we can see that this there were untreated sites. There are untreated mice, and some mice treated with anti-PD-L1, some mice treated with radiation, and some mice treated with radiation and PD-L1. And there is definitely a synergistic effect that you can see with the anti-PD-L1 and radiosurgery. Now let's go to clinically, you know, so we see this even in clinical aspects. So we know patients, and these are two different articles, but I go to the one to the left, and these are patients treated with gamma knife, and you can see that those patients who received concurrent immunotherapy with gamma knife, and this is brain metastasis, had much better local control for the same type of disease and the same lesion, size lesion. This is another study as well, comparing gamma knife alone or stereotactic radiosurgery versus stereotactic radiosurgery with other targeted therapy or immunotherapy. And you can definitely see the better local control and better even survival in these patients who had received concurrent immunotherapy with their stereotactic radiosurgery. So there is definitely more than that. And this is a nice figure from a recent review article in the Red Journal that shows actually that, you know, so there is this direct cell death, which is the conventional way, but there's actually a vascular and immunomediated indirect cell death that happens days and even months as a response to radiotherapy. So, you know, the effect of radiation is not acute, specifically in the era of immunotherapy. Again, another diagram just to show you how in a direct method we have this, and there's also a lot of indirect way, whether it's vascular or cytokine mediated cells. So also we have to keep in mind the tumor biomarkers. Not all cancers are the same. We know that luminal A breast cancer is different than a triple negative breast cancer, even in response to stereotactic radiosurgery. We know that in lung cancer data, we know that ALK positive tumors versus EGFR positive versus EGFR wild type have a different response and a different risk of complication from SBRT or stereotactic radiotherapy. And of course, there is also the influence of the targeted therapy and the immunotherapy affecting mostly the tumor microenvironment that's being irradiated. So in conclusion, and I'm glad I was able to make it in time. So this is, you know, we understand that radiobiology is key for understanding any form of radiation oncology, whether it's fractionated radiotherapy, whether it's stereotactic radiosurgery or stereotactic radiotherapy. There has been significant advancement in our techniques' ability to deliver this radiation. And of course, it does have a unique mechanism of action, which is not the standard conventional way, and that's why it works. And we know that there is an indirect vascular and there is an immune-mediated anti-cancer effect other than just direct DNA effect. And it remains an area of very active research, whether preclinical or clinically as well. In that, I would like to thank the organizers, everyone. This is our young department, as Dr. Falah mentioned, and this is our bell of hope. So we hope that we see you guys soon, and thank you so much for inviting us. Thanks. Okay. So just for the sake of time, I know Dr. Emil has been with us online for a while, so I'd like to introduce him. I've never met him, but it's great to overlap, even virtually. Hopefully next year we'll see you. I have a slide. So welcome, Emil. So Dr. Emil is a PhD. So actually our last session today is given by a physicist. And as a radiation oncologist, with all the respect to everyone, physicists are the smartest people we deal with. So thank you, Dr. Emil, for being here. So Dr. Emil is a PhD in medical physics, graduated, and he was working for a long period of time at Stanford, working in nanoparticles, artificial intelligence, and flash radiotherapy. For all of you who do not know flash radiotherapy, Dr. Emil will be leading, and he's currently the co-lead for the flash radiotherapy program at the University of Texas MD Anderson Cancer Center, along with Dr. Stephen Lin. So Emil, all yours, welcome. Thank you.
Thank you so much. Can you guys hear me?
Yeah, we can hear you, but we can't see your slides.
Perfect. I am sharing that now. All right. I hope this is working.
Not yet. Okay, we got your slides. Perfect.
Perfect. Thank you so much for that introduction. I'm very excited about being here. I know it's virtual, so that's the life we know right now. But I'm very excited about talking, about giving this talk and about presenting some aspects of flash and flash radiation therapy. This is going to be a pretty general talk, but I would love to at later dates come back and discuss all aspects of flash with anyone who is interested. So the outline of my talk is just going to go briefly through what is flash and what is the flash effect, and also how the early implementation of flash looked like, the beam requirements as far as we know them, and really where we're going in this field is a new field, or at least is a rejuvenated field, and what does a clinical translation look like? So, but just first to get everyone on the same page. So what is flash? So there's two concepts that we throw around there. That's flash radiation therapy, and then it's the flash effect. So the flash radiation therapy is defined as the use of ultra-fast delivery of radiation therapy at dose rates generally several thousand times higher than the ones currently used in routine clinical practice. The early definition for flash was at 40 gray per second and above. That is still a truth through modification, but it's still a good and a good initial point for this definition. If you compare that then to the conventional way that we are delivering our doses right now in the clinic, that's more along the line of 0.1 to 0.01 gray per second. So several orders of magnitude difference. The flash effect is then the phenomenon of the increased therapeutic index. The increased therapeutic index of flash compared to conventional dose radiation. So the early implementation of flash, this, as I said, this field had its renaissance, if you may, in 2014, and that was through a publication coming out of the Favadon group at the Curie Institute in France. For anyone who's ever attended a talk about flash, you've probably already seen this figure. However, I'm still keeping it in my presentation because this is actually how it started, and this was how it started for me, like for many others. This publication came out, and this was one of the results that they showed. So they had a machine that was capable of doing both conventional and flash radiation, and they took a mouse model of and irradiated the lungs. So control, and then did a dose escalation with flash and looked at just conventional as well on 17 grade delivery. And these are slides then from lung sections and at different time points post irradiation. So in the instance of conventional radiation, they saw what we always see when we irradiate lung tissue at these doses. At short time points, we have radiation pneumonitis, and at longer time points, we see fibrosis. However, when they delivered the same dose with flash, they saw no toxicity, and they needed to almost double the dose in order to see a similar toxicity profile as in 17 gray conventional. So this by itself was quite striking. However, we are all trained and have seen too many examples of the fact that when you spare the normal tissue, you also spare the tumor. But they also showed in this study on both subcutaneous as well as orthotopic models that there was an iso-effective treatment on the tumor, but that the normal tissue was spared. So of course, this brought a lot of attention to this, and this has been a field that has been growing exponentially ever since. At my early time, I was at Stanford, where I worked on the early implementation of flash beamlines, as well as the early data on the radiation biology of it. And just an example, this was one publication that we published where we did whole brain irradiation, 30 gray, whole brain single fraction to mice, and looked at the response at 10 weeks post-irradiation. What we saw, which I'm not showing here on a figure, but we saw a preserved hippocampal dendritic spine density, as well as then a reduced microglial activation, so less inflammation in the brain. And you can see that here with these foci of CD68 positive cells. So these are the controls in the hippocampal region. These are your conventional, and the errors are then pointing towards your foci. And this is a flash. So we saw a decrease in the of inflammation generally in the brain after flash compared to conventional. We also saw, did a quick and dirty panel of pro-inflammatory cytokines when comparing control versus conventional radiation. We saw an increase on all levels of these pro-inflammatory cytokines. But on the flash setting, we could not see a statistical significance between the flash and control. Of course, the flash effects have been confirmed in many different organ systems now. This is another study that we were performing, looking at GI tract toxicity, and looking then both at different endpoints on both healthy and diseased mice. So here on your left, you see radiation, a total abdominal radiation to 16 gray of C57 black mice. And in otherwise, these are healthy mice. And this is, this is a quite high dose. And we can see that looking at the body weight following radiation, that both groups do lose body weight equally, but that the flash irradiated mice actually regain their weight by 14 days post irradiation. However, the conventional mice, they all died. And this, we can also see that here in this Kaplan-Meier curve, where almost 100% survival of the flash irradiated mice, but all conventionally irradiated mice died. We could correlate this to the crypt and the crypt regeneration. So the crypt is the functional unit of the GI tract. While the structure itself is very radiation sensitive, there's a subcompartment that is radiation resistant. We can then repopulate the entire crypt. And indeed, that is what we saw to a higher extent in flash compared to conventional radiation. Interestingly, also looking at post-irradiation for 12 weeks post-irradiation, we could see that flash and control there was no histological differences there. And we could, of course, not analyze any conventional irradiated mice because they had succumbed to the treatment. We also wanted to look at a disease state to see how does that affect? Do you still maintain the normal tissue protection when you have a disease state that we are working on? And how is the tumor affected? And so we did an ID8 model, which is an ovarian cancer model, and we did the same kind of treatment. We lowered the dose to 14 gray just to allow a survival of the conventionally irradiated mice. And indeed, we saw what we expected to see. There was a shift in the survival compared to non-treated mice, but there was no significant difference between conventional and flash. And that we can see also when we quantify both the number of solid tumors as well as the tumor weight, just because this is a model that metastasizes. So so it's not just measuring the X, Y, and Z of a tumor. We also did a sub-analysis of the normal tissue, similar to this analysis, and indeed we could confirm the data that we saw in the healthy mice. So even in a disease state, we still have the normal tissue protection, but we have an isoeffective treatment on the tumor. This is not just mice, and there's actually quite a lot of data that is very interesting to go through. But to keep this as an overview, I also just wanted to point out that also in the flash effect has been tried out in higher mammals. So here on your left side, you have skin sparing in minipigs, so conventional versus flash, 28 to 34 gray. In conventional treatments, obviously you introduce necrosis, but in the flash, it's very interesting to see that there is the only toxicity we see when we compare these doses is a bit of epilation. Similar things have been seen in an early cat trial, which they are expanding on now. But this is the early studies that came out looking just at the dose escalation with 6 cats, 6 tumors, and in 5 out of the 6, the tumor were controlled and with a complete response. And the only toxicity that was found was again on hair loss. And you can actually see the field that they were using to treat. Of course, talking about higher mammals, the first in human case report has also been published, which was a T-cell lymphoma patient who had previously received over 100 different localized courses to his symptomatic tumors, but one of these lesions was chosen to be treated with flash, and it was a simple 170 gray per second, 16 gray delivery, and the maximum toxicity following this treatment was a grade 1 erythema, which compared to his previous treatment was very, very mild. Of course, in this publication, they did not show any comparative data, but after talking to them, they are in the process right now of acquiring that data. So there's probably going to be a publication very soon that comes out with a proper comparison. Of course, anyone who wants to do flash can't just go to their normal machine park and just do it. This is some machine consideration that needs to happen, and that is why it took a while for the publications to really start accumulating, because we didn't have a way of generating flash beams going into this. At Stanford, where I was at the time, we were very early on in a conversion of a clinical ovarian clinic. And we could prove that we could do flash irradiations very easily. These systems here is all electrons, just so you know it. But we could now, with updated specs, compared to the original publication, we can now do 300 gray per second at ISO. This is, of course, then limited to the maximum energy of the machine, which is 20 MeV electrons. And if you can do it on one system, you can do it on another. So very soon after we published our data, there was another publication coming out from Lund University in Sweden of a successful conversion of Elekta. Well, I think it was Elekta Precise. There with very similar specifications, about 300 gray per second at ISO and up to 15 MeV electrons. All of the original publications have basically been based on the Ariatrons, so the ones coming out from the Lausanne group in Switzerland, who is definitely the ones who have flooded my email with new publications. They have used the Ariatron to a very high degree. And this is inline linear accelerator, very basic in its design, but it does does the job, especially if you're looking for a preclinical system. The Mobitron, which is new to the market, is just an update of their old Mobitron, which was an intraoperative unit. But here as well, you can get 1,000 gray per second at the end of the cone with up to 9 MeV electrons. And on that side of the available technologies, these are the ones I already mentioned. There's also a flash knife from PMB that the Tube or the Lausanne group is working on the electron side, which could be a tool for us for future clinical translation. Of course, I've not even talked about the proton systems that are out there. They really deserve their own dedicated presentation, just like much of this. But you have the University of Pennsylvania has been very successful with their use of the IBA Proteus Plus system to do proton flash. There's also the Mevion system as well as Varian's ProBeam system that are used and capable of producing flash beams. But then what are the beam requirements? So that becomes the next thing. So think along the context of you want to establish a program, then the beam requirements for flash is actually gonna matter. We are getting more and more information that is not just a mean dose rate effect that we're considering here. Of course, this is mostly work that's now being conducted in the electron flash realm. The reason for that is that there we have a way of manipulating our beam parameters in a way that you can't really do with protons. So, but physical beam parameters that have shown to be of importance has been pulse width, mean dose rate, intra-pulse dose rate, dose per pulse, pulse repetition frequency, overall radiation time. I'm not going to go into the details of this. All I want to say is not just the mean dose rate for the entire treatment we're talking about anymore. There are sub-components to our delivery that might be of interest. And Boris et al. In 2019 did a first try to establish what is the realm of flash effect. What do we need to do in order to obtain a reproducible flash effect? This is a figure that was published in here, and there's an updated figure of this exact data in a recent publication. But first of all, if we ignore this point here, which is actually a sliced irradiation where you scan, and looking at a whole field irradiation instead, and these are studies that were positive, meaning they showed a flash effect. What they needed when they tried to put this on this card and phrase it between irradiation time of delivering a generic dose, 10 gray here, and then the dose rate within a pulse, we could see that to inform us of where we need to be, we probably need to be around 100 to 200 millisecond maximum for our delivery of your entire dose, as well as a dose rate within the pulse, at least approaching 10 to the power of 6 gray per second. Obviously, that is a very high dose rate. These are what we see in the electron side of flash. Sorry. So the another aspect of when it comes to the beam parameters are going to be as this list was showing, there's many different ones. However, even if I said that the dose per pulse, the dose rate per pulse is important, the strongest data we have is going to be on the mean dose rate. Simply speaking, what is the mean dose rate that we're delivering our radiation on? That's where we have data currently. And it's very hard to go into the focus of what specific parameters is important, because when you change one, you change the others. But in an early study coming out in 2017, the Montegrey rule at Lausanne showed a dose rate escalation trial. This is a recognition ratio assay, and they were talking, so it's a whole brain irradiation, and to 10 gray, and then they just escalated the dose rate with the delivery. And they could see here that when they went from 0.1 all the way up to 500 gray per second, that initially they saw no differential response, but at around 30 gray per second, there's starting to be a response. But they needed to go up to about 100 gray per second in order to see a robust response and a plateau. Similar data has also been shown in GI tract. I'm sorry that this figure looks a little bit different here. It's the middle line of the colors that we will be looking at. So we know that we are moving the LD50, so the lethal dose for 50% of the irradiated animals when we do conventional versus flash. However, in a sub-analysis, we could see that this is a mean dose rate effect on this as well. So you have an LD50 on the conventional of 14.7, and these are again black mice that we've been irradiating, and we move it to 16.6 gray if we deliver our dose with 17 gray per second. However, increasing it to 220 gray per second, then we increase the LD50 even further to 18.3 gray. So more detailed data is on its way on this, but it definitely shows that there is also avenues for optimization. And the little data we have right now actually indicates that there's a tissue effect as well, which tissue you are actually working with. But so where are we going? I'm just a few slides on this. I know I'm running a little bit late, but the clinical translation of flash radiation therapy. So active clinical trials right now are numbered to 2, at least that I know of. These are one study coming up from the Lausanne group from TÜV, which uses the intra of Mobitron, which is then a 6 or 9 MeV electron beam to treat melanoma skin metastases. And the trial is based on a dose escalation to find a dose where toxicity is acceptable, but with effective tumor treatments. And the number of patients that they want to include in this study is somewhere between 7 to 21. There's also another study that the Cincinnati Children's Hospital is running. While it is at the Children's Hospital, is actually adults being treated. So it uses a barium probing pencil beam system and are looking at painful extremity bone metastases. So it's just looking at the feasibility of using the system and looking at using the system with 8 gray times 1. While we don't necessarily expect to see any differences there, we hope to see an isoeffective treatment because of the fractionation scheme. 8 gray times 1, we're used to seeing that without any major toxicity anyway to the normal tissue, but it's more feasibility and more to come. But looking short term in our clinical translation, the proton and electron flash can be produced by existing technologies, but they will be applied to limited clinical indications. So for example, on the electron side, it will be superficial targets because we so far do not have very high energy electrons. On the proton side, it's going to be radiation in the plateau region if you want to reach any type of larger than 1 by 1 centimeter target. Because you then need to shoot through the patient, so you will have the Bragg peak on the other side of the patient, so on the outside. Longer term, though, there needs to be technical improvements to achieve proton flash to general clinical target volumes and to really achieve that full proton conformity. However, the discussion happening right now is that if flash really shows the data that has been shown in on the preclinical setting, also in the clinical setting, why would we then work with the Bragg peak anymore? Obviously, that is a debated topic, but it's still an interesting thing to think about. We also need the developing of X-ray flash as well as very high energy electron flash for general radiation therapy indications. But just as a last summary slide, so flash radiation therapy, is it a new paradigm? There are still some high-level questions that needs to be answered. One of the more important ones are, what are the biological mechanisms of flash? So as you notice, I didn't even touch upon this subject on this publication, as there is a lot of controversy, and while very interesting to go into, it will require some more slides. What is the minimum dose that can be delivered? We currently say that we need to deliver at least 6 to 8 gray in order to achieve a flash effect. So there's not just a dose rate effect, we also have a dose effect that we need to, or dose threshold that we need to comply with. However, we don't know if that is translatable or not, or if it's the same dose level in mice as it is going to be in humans. And so we don't know what is the realm of fractionation when it comes to flash, and what is the realm of multiple beams when it comes to flash. Can you wait a few seconds between 2 different beams? We don't know that. We don't have that answer yet. And of course, also, what are the differential effects of flash on various normal tissues? What we do know, though, is that the flash effect is real, and it has been demonstrated with electrons, photons, and protons. Flash also shows normal tissue protection with at least isoeffective tumor control, and the symmetry and beam control are critical parameters for reproducible and robust effects. So with that, I just want to say thank you for listening, and I'm more than happy to discuss any questions you might have. Thank you.
Thank you, Dr. Emil. I don't know, I don't have access to the online questions, but I'll shoot with the question because it's a very important concept. So, Emil, you mentioned flash electron superficial. Proton is being studied even in clinical trials. The question I have for you is that, and it's very interesting how it really kills the tumor, and you have less side effects, almost 0 side effects on their normal organs. The question I have is, like, when do you see this, based on your experience, because you've been working in flash for an extensive period of time, whether at Stanford or at MD Anderson, looking at the rate of progress, when would you advise radiation oncologists and radiation physicists and radiation biologists to, we should start learning more about this. This is happening soon. So when do you think things are going to move forward?
Like I said in a few slides back, I think that we are at a level where we can do some limited indications, at least, of irradiations. So obviously for electrons, we can do skin lesions or superficial tumors. On the proton side, we can shoot straight through, and that's about what we can do on a single beam. That's also probably more limited to extremity, just like that trial at Cincinnati Children's Hospital. So timeline, we are there, right? It's being tested. That being said, though, to more general indications or to better understand what we're doing, I would say that once we know at least what the fractionation is doing, then we can start talking about the bigger trials. I do believe the bigger trials are still several years ahead of us, because there are many different things with the beam delivery that we still need to solve, and where the technical solutions are not yet available to us in a clinical setting.
Okay, perfect. And this is exactly why we wanted this talk, because this is happening. I mean, we know this is going to become more prevalent and more practiced, and it's very promising. So I think from the audience, do you have any questions from the audience, or we're good? Okay, Dr. Falah, okay. All right, perfect. So I would like to thank everyone. Emil, thank you so much. Our esteemed audience and guests and our online viewers, thank you so much. And in that, we will conclude today's session of the Emerson College Society meeting, and we will see you tomorrow morning to catch up with a lot of interesting talks on medical oncology and advances in immunotherapy in different sites of cancer. Thank you so much, Emil, and thank you, everyone. Thank you.
Thank you.